hematomas, which may need to be tackled. If small, undisplaced, no intervention is needed. But if there is a significant change in the position or ocular motility is being restricted, as in larger fractures like this, then we need to do a neurosurgical approach working with the neurosurgeons. If there are multiple fractures like the ZMC fracture here in this patient with a gross restriction of motility and a deformity in the region here because of this fracture in the zygoma and the gross displacement associated with the flow fracture and NOE fracture with incarcerations, we work to carry out repositioning, microplating, and flow fracture repair to improve the position and the motility of the globe very significantly, as well as the deformity. Another case with multiple involvements on the left side already leading to enophthalmos, we can disregard the third nerve palsy, which is present on the right side. And we find not just the maxillary fracture, orbital flow fracture, but a zygomatic fracture, naso-orbito-ethmoid fractures as well, and frontal bone fracture as well. So all that needs to be tackled well with a teamwork in order to carry out a good position. Here we worked through the pre-existing scar and we could improve the position of all the bone fragments. Orbital flow fractures, a proper assessment holds the key, and we use the CT scans in eggshell as well as the coronal sections to assess the volume changes well with the help of softwares. And we also look at the contour of the bone between the medial wall and the flow in order to make the right choice of implants. Transconjunctival and swinging eyelid approaches are the ones that are commonly used because these provide a most aesthetic scar, and they also provide a very extensive approach to you. You can, if combining with the transcaruncular approach, you can get to reach the lateral wall, the medial wall, and the floor very well. So that is the reason why these have become very popular. And the various types of fractures, extensive or small, can be tackled. Small fracture like these are easily lifted off with the use of hand over hand maneuver like this, and then they can be corrected by positioning a small plate, which can be an absorbable plate as well. A flexible plate can be used. But larger fractures with buckling of bones, incarceration of contents, gross displacement of floor like this, need a more extensive dissection. So here we have a relatively larger fracture. So we have needed a relatively bigger exposure and we are lifting off the contents. If the incarceration is recent, it may be relatively easier to lift it off, but the older cases may require more extensive dissection. So here, after the dissection, we need to define the full extent of the fracture. We must see the posterior extent very well and make sure that the force duction test at the end is free. Here, once we have lifted, we can look into the antrum and we can see all the borders of the fracture well. And then an implant can be placed in position as is being done here. But for more extensive fractures, which are reaching further posteriorly or where there are associated medial and lateral wall fractures, titanium implants have become increasingly important, and they provide a good contour correction. They can reach up to the posterior ledge and they're able to cover the medial wedge as well, and therefore provide a very good support. So this is an example of a large fracture with enophthalmos in the right eye. With, you can already see a significant enophthalmos here. There's a floor and medial wall repair. This is after the repair where enophthalmos has been corrected. And you can see that this is because we've been able to reproduce the normal contour and the angulation between the floor and the medial wall with the titanium plate. And we are able to reach up to the posterior ledge and provide the appropriate contour with the help of the titanium plate. Increasingly, computer-based volume measurement softwares are being used, and they give you a good idea of how much the change in volume is and how much of it needs to be corrected. For assessing whether we have really reached the posterior ledge, we can use navigation for those difficult cases. Also, the intraoperative control can be used with C-arm technology with cone beam CT scans. So navigation systems and the cone beam intraoperative monitoring can be held. The computer modeling helps in allowing a full reconstruction of the facial symmetry in a virtual environment. And with the available softwares, now you can even do a virtual surgery and see the effect of that. This technology needs to be assimilated gradually so that you can provide the exact volume replacement in the cases that have an extensive fracture. So the newer paradigms, to summarize them, involve a good data acquisition, planning, creating the appropriate simulation in the lab environment, in the pre-operative environment, assessing what needs to be done. Patient-specific implants can now be ordered with several companies and they are available to us. And then intraoperative navigation where needed and intraoperative cone beam CT scan can be used for assessment in the more difficult cases as needed. Thank you very much. We are in for some exciting times in orbital fracture repair to try and reproduce exactly the anatomy that we want to do. Thank you very much.
Thank you, sir. You elaborated very nicely the complete fractures of the orbit. There is definitely advantage of association of multi-specialty hospital that do have facility for other specialty and more infrastructure. Which welcome, Dr. R.C. Gupta.
Good morning. Good morning.
Welcome, Dr. R.C. Gupta.
Good morning, sir. Good morning. Very nice presentation in the morning.
Thank you.
Sir, really we are delighted that you have presented so recent things. Sir, one thing, Dr. Hardeep, if I want to ask anything,
no,
otherwise
you
I should
carry on,
start.
sir. You carry on, sir. You carry on.
Okay. Sir, just I want to ask something that many times you see that the medial wall of the orbit is very severely fractured, and it's sometimes very difficult to hold on that implants medially, especially. So, sir, how do it, sir?
So increasingly, we are using titanium plates where we have the medial prong associated with the floor implant. And the preformed ones have a very nice curvature of the floor, which matches that of the normal floor, and it can be supported on the posterior ledge. And the medial one can be angulated according to the angulation between the floor and the medial wall on the opposite side. And then it can be introduced behind the inferior oblique. We don't always disinsert the inferior oblique. You can carry out a wide periosteal incision and wide dissection in order to get a good exposure. And then you are often able to introduce the medial plate of on the titanium implants without disinserting the inferior oblique as well. But if you need to, you can disinsert and then place back the inferior oblique attachment.
Sir,
But a good dissection on the medial side is also important. So a transcaruncular and the transconjunctival inferior pharyngeal incision combination is very useful.
Sir, we are using actually this rib grafts. Most of the time we are using rib grafts. They are actually, after splitting, this becomes very useful, and you can change its shape and mold its shape and like that. That also. So sometimes it may becomes difficult for this rib graft to fix immediately. But sometimes that, as you told, that I think the especially molded grafts will work better, I think.
Yeah, but for the large floor and medial wall fractures, I think titanium does hold a specific advantage over other implant options that we have, including the bones and including the Medpor plates. In these situations, yes, titanium definitely, if available to you, if patient can afford it, affords an advantage.
Actually,
Otherwise, other implants also, if you get a good exposure and you use a fairly large implant using a transcarancular approach with wide dissection, you can place them in position well.
sir,
And
couple
with
of times I have used titanium plants. Sometimes they displace from their places. So it happened twice to me that when I use the titanium plant, it actually it has a tendency to extrude out. Means they came forward. So that is that. I think that was the problem with the titanium.
No, I think the ones with screws are the better ones rather than the meshes. Meshes
Mhm.
were not so good.
Yeah,
If
yeah,
you
yeah,
have
yeah.
the titanium implant which you can fixate with the screw on the orbital rim, then they work very well. These are
Okay.
much firmer, and
Mhm.
if you have supported them on the ledge at the back, then they will not displace downwards also into the antrum, and they will stay in position and give the right contour to the floor as well.
Yes, sir.
So
Okay,
instead of the mesh, you need to use the plates that are available.
sir. Thank you, sir.
Welcome,
Thank you.
Fairuz.
Yes, good morning, everyone. Hi.
Morning.
Hi.
How are you?
Hi, good sir. Excellent presentations. I have a question for you, sir.
Yes,
Can you
Fairuz.
please share your experience with osteopore mesh in orbital floor fracture or orbital fracture?
We haven't yet used it. I've recently been given a couple of samples to use, and I'm hoping to use them. Do you have some experience with osteopore?
Yes, sir, I do
Just
have.
tell us.
Yeah, so the indications that I use osteopore mesh is like obviously thinner. So if the fracture is not too huge, it's not a large fracture, and enophthalmos is not too significant. The advantage of osteopore mesh is that the bone regrows. Ultimately, after 3 to 6 months, you can actually find a good, nice bone which is already formed over there. So in such situations, yes, I do use osteopore mesh.
There are various thicknesses available.
Yes,
You have, I
one
think,
1 millimeters and
2
2 millimeters
million,
are the
1.25 and 2, I think.
yes, yes,
So, depending on the strength required and depending on the enophthalmos, I think you can use
yes.
a thicker implant
So,
as well.
yes. So what
But
is
they
your
would be used. Okay,
yeah
go ahead.
yeah no sir, go ahead.
They'd be useful where you have defined edges of the fracture and not very large fractures like the ones where we would particularly want to use titanium plates, where you only have the posterior ledge and you would like to get up to that with a maybe a better defined shape as in a titanium
Yes, sir.
one.
Yes, sir. Like a
Others
trap
with a
road fracture.
well-defined borders, yes, this could be a good option.
Yes, yes, yes.
Thank you, sir.
Thank you.
What about composite graft, the titanium with porous implant?
Yeah, they are all touted as having combining the advantages of the two because of the properties of the Medpor also being utilized and giving you a smoother surface and so on and so forth. I have no
Yes, sir.
personal experience of using those integrated
Oh,
implants. I've either used Medpor or I've used titanium implants.
thank
A lot of
Uh,
options available, starting from the X-ray film, and they all work provided you choose the right one for the right situation. For very small ones,
yes, sir.
the small absorbable ones are very good, and for these osteomesh have a fair degree of strength as well, and of course the bony regrowth takes place over a time as these absorb, and they do retain sufficient strength. One of the initial doubts was whether in the long run these resorbable ones will retain their strength or not, but I think osteomesh particularly has been shown to retain the strength for a reasonable period of time.
Yes, yes. So physically, when we see it, it's almost close to Medpor, the plate that we get. Yeah, yeah.
Thank you.
Thank you, Dr. Grover, sir. And now I invite Dr. Kumudini Sharma for her talk on growing fractures of the orbit.
Good morning, Dr. Bitheria, Dr. Grover, and all colleagues. I would be talking about the. Okay. I would be talking about the growing fracture of the orbit. The fracture of the orbital roof that continues to enlarge after the initial blow to the forehead forms the constitute the growing fracture of the orbital roof. It's a rare and the delayed sequelae of a frontal injury in children. It's mostly seen in the children because the dura of the children is very firmly adherent to the orbital roof. Hence, whenever there is a fracture of the orbital roof, it is always associated with a dural tear. Because of the large cranium of the children and incomplete pneumatization of the frontal sinuses, the impact force is directly transmitted to the orbital roof. Hence, the orbital roof fractures are more common in children than the adult. Most of these fractures, they heal spontaneously, but in some of the cases, due to the continuous growth of the skull and the brain in the children, this fracture enlarges and it results into a bony defect in the orbital roof. And through this bony defect in the orbital roof, the pulsatile force of the developing brain pushes the arachnoid meninges through that torn dura and forms a leptomeningeal cyst in the extracorneal space of the orbit. Sometimes there is no herniation of the leptomeningeal cyst, but there is a continuous extravasation of the CSF in the orbit that stimulates the osteoblast of the bony edges of the fracture and results which causes the overgrowth of the bony edge of the fracture line, which may also cause the decrease in the shallowing of the orbital bony orbit of the child and may cause dystopia of the globe. Clinically, these patients, they present with displacement of the globe, proptosis, swollen upper lid, and restriction of upward movement of the globe. And sometimes there may be a visual loss because of the compressive optic neuropathy caused by the meningeal herniation, meningeal cyst herniation in the orbital space. And these all symptoms, they appear months to years after the trauma. The CT scan helps in defining the fracture line, while MRI delineates the leptomeningeal cyst extension, the extracorneal space of the orbit. These children, they need to undergo frontal craniotomy with a duroplasty, and if the defect in the bony defect in the orbital roof is large, then it needs to be reconstructed. We had so far, I had two patients of growing fracture of the orbit, one of which we published in the JAPOS in 2003. Another patient which we had recently is a 2-year-old child who presented with a swelling of the left upper lid, which increases on crying. It was there for last 5 to 6 months. There was a history of a fall from a height of 2 to 3 feet 10 months ago. At that time, child had a mild swelling, which subsided with the routine treatment after a week. When we examined the child, there was a fullness in the left upper lid with downward displacement of the globe, and the swelling of the lid was soft, compressible, increases on crying and non-pulsatile. And there was restriction of elevation on the left side. The rest of the ophthalmic examination was normal. The non-contrast CT of the child showed a fracture line in the left frontal bone, which was extending up to the orbital roof and creating a defect of 16 into 10 millimeter in the roof of the orbit. There was a herniation, as you can see on the CT, of the meninges and forming a meningocele in the extracorneal space of the orbit. This is the 3D CT reconstruction when you can appreciate the fracture line in the frontal bone. It was not only extending to the orbital roof, but also expanding at the area of the orbital roof, resulting into a bony defect through which the meninges, they herniate and form the orbital meningeal cyst in the orbit. The patient underwent left cranial craniotomy, and the herniated meningeal cyst was excised, and the dural defect was repaired with periosteum. This is the post-operative photograph of the child 3 years after the surgery, and we can appreciate quite satisfactory outcome of the result. So it is important to the ophthalmologist to be aware of this entity and to suspect it when in a case of a child, when these ocular findings, they manifest months or years after the frontal blow. And it's important to recognize this, to diagnose this entity early, because the longer standing cases, it may cause a visual loss in the child. Thank you.
Thank you, madam. It's a very nice talk, and it's very important for the ophthalmologist to note that even cranial fractures can extend into the orbit, and one should be careful while examination, and must take help of our neurosurgeon friends. Thank you, madam. Thank you. And Dr. Milind Chongle is it here? Yeah. Now I invite Dr. Milind for an adnexal trauma. Dr. Milind? Sir, Dr. Grover?
Yes, yes.
Sir, any comments on Dr. Kumudini's growing fracture? Have you come across this type of fractures? Because you are in multi-specialty hospital, you must be seen many cases like this.
Not exactly. So I think we very often leave the roof fractures to be done by our neurosurgeon colleagues, and don't always combine it, work together when it is only a roof fracture. So we probably have not enough experience with that.
Actually, I have worked with all these surgeons, because when there is any doubt that there is any herniation of the meninges, we always call neurosurgeons, and usually we go by the transcranial route, and from transcranial it becomes much easier.
True. Good morning, Dr. Bithariya. Morning, sir.
Good morning, Bithariya, sir.
He's. You have to unmute yourself, sir.
He's unmute.
Am I audible now?
Yes, sir.
Good morning, sir. Good morning, sir.
Good morning.
Good morning to all of you. Very nice seeing you all. Thank you.
Good morning, sir.
Good morning, Feroz. Good morning.
Good morning, sir.
Milind is now back, so you can get him to.
Dr. Milind, you can start, please.
Okay, sir. Am I audible? And my screen is visible?
Yes.
Hello? Good morning, everybody. I am from welcoming all my senior colleagues and all respected seniors. So,
Expand the screen.
yes.
Make it full screen. Yeah. It's okay.
I am talking about late trauma, which everybody we encounter daily, but we want a good result. That is, we don't want ouch, and we want a wow. So, late is complex structure. Whenever we think about the late trauma, we want to see too much. That there is a visa ligament, septal fat, orbital septum, orbicularis, tarsus plate, and many more. But generally, I don't see all this structure. I just concentrate on the aponeurotic complex, tarsus plate, orbicularis, and skin. And the main focus was on the skeletal of the lid, that is tartar plate. If you secure it, the half job is always done. But we have to give equal regard to the lower lid because it's form of pump of the eye and किसी को भी रोते हुए पेशेंट अच्छे नहीं लगते. So we have to concentrate ourselves on the little details, which structures are involved and how to proceed. So we require a good plan. So this is how I generally define the late trauma and classify it depending upon the margin involvement and the canalicular involvement and defect present or not defect present, because we are being ophthalmologists, we sometimes require limited resources. So we have to mobilize the resources like a mini monocle and a stronger suture like a 4-0 or 5-0. So it's a case-based discussion. So we start with the case one. This is one of the patients of RTA. Here we can make out that the scene is unfolded on the one side and the tarsus and orbicularis are visible. So if we see that it looks like there is a defect, but if we unfold the skin, we can make out that there is no defect and we can proceed with like this. This is what I call as a thinking cap. I generally give a thinking cap to the resident and ask them to rearrange the tissue, and we can suture it vertically. This is this is how the defect can be closed. And a simple question to rule out where the posterior involvement is present, that is posterior lamina of the lid is involved or not, is to ask the patient to open the eye. If he can manage to open the eye, means tarsus and the LPS complex is intact, only the anterior complex we have to repair. And if we close this vertically, there's no lid lag or lag of thymus, and subsequently patient won't require any skin graft or other treatment. This is how the vertical line we can make out. But sometimes we get a patient like this where the anterior lamina, that is skin and orbicularis, is entirely debrided. So there is a defect, and if there is a defect, we have to replace with another tissue in the form of skin graft. So this is the thinking cap where there is a defect. We can make out this is LPS complex, which I generally made, and this is tarsus leg, and this is skin orbicularis. And we have to put an skin graft because if we don't put the skin graft, there is will be undue ectropion. That this is the skin graft.
Milind, your voice is cracking too much.
So this requires a skin graft. The post choice. Hello.
Probably
Am I audible?
weak signal. The signal is weak, probably.
Hello.
We can see the slide, but voice is breaking.
I try to reconnect it, or you can proceed with another figure.
अच्छा, क्या इनका आया क्या? कुछ इंटरव्यू अभी नहीं आया? टोबैको काउंसलिंग और ये सब करते हैं। ठीक है, ठीक है, ठीक है, चलो।
Dr. Hardeep, are you there?
Yeah, I'm here only.
Dr. Hardeep, do we go with the next speaker?
Okay, sure.
Yeah.
I think it will be better because actually there is some net issue at his level.
Yeah, and maybe he can come back, Dr. Hardeep.
Yeah.
Dr. R.C. Gupta?
Yes, please.
You take over.
No problem. You can carry on. No problem.
Okay. I think Shalu Bageja is ready.
Yeah.
Okay. We welcome you for your talk on complications of orbital fracture. Please carry on.
Good morning, everyone. We have heard Dr. Grover about the management of the orbital floor fracture, but we know that even despite all the proper surgical technique and the best anatomical reconstruction, we may still encounter the complications, and these lead to the debilitating morbidity among patients and lead to the negative outcome. So we should be well versed with the pathogenesis which lead to the complication and how to manage these. The complications can be immediate or late. Among the early complications can be like vision loss, which is very severe and but rare, with mydriasis, hematoma, and infection. Among the late, we can have persistent diplopia, residual enophthalmos, or eyelid malpositions. So vision loss, as we know, is a very severe complication, but reported as low as 0.4% in literature. It can be due to the retroverbal hemorrhage or improper positioning of the implant, or the size of the implant, which has been placed is bigger and impinging on the optic nerve. So measures which we should take is the most important is the preoperative assessment. If the patient is on any anticoagulants, or we have to screen them for bleeding disorder. Intraoperatively, we should keep on checking the pupil to note any if there is a pressure sign and ensure hemostasis before closure. Postoperatively, we should avoid compressive damage, and vision and pupil assessment every 2-3 hours. It should be done in the first 24 hours. In case we observe any vision-threatening episode, then we should give IV methylprednisolone immediately. If we are suspecting orbital compartment syndrome, we should do the canthotomy along with the cantholysis, and should do the exploration and remove or trim the implant if that is the triggering factor. And if there is a hematoma, we need to drain it. The pupillary mydriasis reported the incidence is about 2.1%. It can be due to a local anesthetic diffusion, which will reverse on its own, or it can be intraoperative traction of the inferior rectus or oblique muscle, or injury to the axillary ganglion. So we should be cautious, and when we are doing the posterior dissection, we should be very gentle. Early post-op edema and hemorrhage can occur, and they are quite reversible with the anti-inflammatory medicines. Infection noted is usually uncommon, but if is there with the present implants available, the infection noted is very rare. But if we encounter them, we have to use the broad spectrum antibiotics, and if it's resistant, then we have to remove the implant, take the patient for removal of the implant, and do the secondary implant augmentation later on once the infection settles down. So persistent oculomotor restriction is well known, and transient diplopia is common post-operatively, and it usually resolves in a couple of weeks. However, the incidence of persistent diplopia range from 8 to 42%, and the cause transient diplopia due to periorbital swelling, but however, it can be due to the persistent diplopia due to the orbital injury to the muscle due to trauma or intraoperative manipulation, or the implant may be impinging the muscle or the soft tissue, which may cause a persistent diplopia and oculomotor restriction. This is just an illustration showing a large fracture which showed the persistent motility even after the good repair, restriction in the motility post-op. So it has been shown in the literature that in cases of the larger fractures and where we suspect that the tissue is incarcerated, we should do the early repair because the trauma to muscle and nerve may lead to the non-resolution of the symptoms. So the early repair, that is up to within 3 weeks, it gives the better outcome in these patients. If there is a persistent diplopia and the force reduction test is positive, then we should do the imaging. And if we find that the tissue is incarcerated, then the resurgery is choice. However, if the FDT is negative, and then we have to resort depending on the angle if for the prisms or the strabismus surgery. Persistent residual enophthalmos can be present in about 7 to 27%. Most common cause is the incomplete restoration of the bony orbital volume, which has been emphasized by Dr. Grover also. And the other causes are due to the trauma leading to soft tissue contracture and fat atrophy following the trauma, as well as the surgical manipulation. So in the milder case, we can do the fat or filler injection or the repositioning of the implant if it's improper place, and sometimes we have to go for the secondary implant augmentation. This is a patient in which the fat injection was given for the superior sulcus deformity, and then another patient showing the enophthalmos post-surgery, and this persisted, and then the second, and CT shows that the implant is anteriorly placed and the posterior, there is no coverage of the implant. So the secondary implant was placed and which showed the better outcome. So sometimes we have to go for the secondary implantation over the previous implant. This is the pre and the post reinforcement of the implant. The eyelid malimposition can occur with both the transcutaneous as well as the transconjunctival approaches. However, the transcutaneous approaches have more complications like ectropion or eyelid retraction. So it is reported to be as high as 40%. It can be due to the scar contracture or secretory shortening of the anterior and the middle lamella or loss of muscle tone. So if it's a milder and we can do give the lubricants, and in the early period we can have do the massage and have the good correction. However, we have to wait for 6 months if it is persisting, and release of scarring and full thickness skin grafting is required in the case of secretory shortening of the anterior lamella. This is the illustration showing the lower lid retraction, in which we have to release the lower lid retractors, and we have to lengthen remove them from the tarsus and lengthen the lower lid retractors. We have to give the graft like a hard pellet. We can use dermis or tarsal graft. So hard pellet is a good choice for replacing the tarsus. Entropion is more common with the transconjunctival approach, and it's due to the scarring or reduction of the posterior lamella. And these cases are due to the irritation, we have to give them lubricant. But initial and the early post-op, if the massage is given properly, they do respond. However, if it doesn't respond, then we have to go for V's, and we have to lengthen the posterior lamella with replacing it with the buccal mucosa. Simlifron can be seen with the conjunctival approach, and thus if the smaller short Simlifron, we can leave shallow Simlifron, we can leave it. Otherwise, we have to go for a Z-plasty or any mucosal replacement. So just to conclude, the proper pre-operative assessment and planning, and with the availability of the newer modalities, and we can do the proper contouring and positioning of the implants, and thus we can have a better outcome. But still we can encounter the complication, as all surgeons in their life, they experience some complication. We come across them, and we have to know how to manage them so that we can give the better outcome to the patient. Thank you.
Thank you, Shalu. How often we have seen implant migration? Hello, Shalu.
In my experience, I have not seen implant migration, but it's reported in the literature.
Which implant you prefer?
I prefer in my practice, mostly I use titanium meshes.
Because titanium has the advantage that you can screw it on the margins.
Yeah.
And, you can
90%, 95% I use titanium, but in children I prefer to use EPTFE sheet.
Okay, good.
Dr. Shalu, very nice presentation. Okay, very nice presentation. And very realistic data, because many times people report complications very less. At the same time, I think you might have the more referred cases, more complicated cases. So this data for you may be little more.
Yeah, because we have a multi-speciality hospital, we see multiple wall involvements, fractures. So the ophthalmos is very common post-operatively also, because if they have 3 wall fractures. So we do see ophthalmos in these cases. So we have
thank
to
you.
manage.
Very nice.
Thank you.
What is the time frame when you think that is the best time to intervene?
For diplopia, at least minimum 3 months, but I try to extend it for 6 months to counsel the patient.
Intervention for floor fracture.
Floor fracture, it depends. If it's a multiple wall, then because being a multi-speciality hospital, the plastic surgeons take them early. So we do them in 2 or 3 days only. But if it's a isolated floor or medial, I'll try to wait. If it's a smaller fracture, I like to observe them. If it's only a floor fracture, wait for 2 weeks at least. Otherwise, if floor and medial, then we take them in a week, depending on the swelling. If it's a swelling, then I like to wait.
Because it is better, it should be done at the earliest.
Yeah.
After subsiding of the swelling.
Yeah.
Ideal time would be between 7 to 14 days. Ideal time would be between 7 to 14 days, because we say that the acute inflammation should go, and so that bleeding becomes less during the operation, and at the same time that the other complications which are associated for the anesthesia and all those things, they are clearly delineated, can be visible.
Yeah, in isolated fractures, if they come to us, we wait for 7 to 14 days, but sometimes the plastic surgeon try, because they have to do zygoma, they prefer early intervention.
Yeah.
And then we have to intervene with them.
Sir, I would like to contribute a little. Good morning, everyone. Dr. Swati Agrawal. I would like to say that trapdoor fractures are the web of kind, which require immediate intervention, say within 24 hours, to prevent long-term diplopia. So they are the ones who would require an immediate intervention, or large fractures which cause globe subluxation, or a potentially vision-threatening condition. They would require an immediate intervention. Otherwise, normally the fractures which we repair are within 1 to 2 weeks. That is also an okay time.
I think Dr. Swati Agrawal is very correct. I think the vision-threatening condition, they must be taken immediately, as early as possible.
They are the criteria, indication for emergent condition repair.
Okay, so we can go with to the next. If there is no question, then we can go to the next speaker.
I have one question, sir. Can I ask one question?
Yeah, please.
Ma'am, you are injecting the fat. You are injecting in the orbit or in the lid?
Orbit.
For correction of
Less for superior sulcus, it is either can be in the subperiosteal on the upper lid, or it can be to the infratemporal approach. It can be in the intraconal space.
Intraconal space. Okay.
Yeah.
So you can go to the next speaker, Dr. Hardeep.
Dr. Vijay is there?
Yes, sir.
Yeah, please.
Very good morning to all.
Go ahead. Okay.
I'm Dr. Bigya Panda, presently working as Assistant Professor in SCB Medical College, Cuttack, Odisha. I have done my long-term oculoplastic fellowship from Arvind Eye Hospital, Madurai.
Share your slides.
Yeah. So today I will be, am I audible?
Yes.
Yeah, your slides are not visible.
Sorry. Now is it visible, sir?
Yeah, okay.
Today I'll be speaking about how to manage a lacrimal canalicular laceration. As we all know that canalicular trauma is the most common lacrimal system trauma we see, with an overall incidence of around 7 to 20%. This constitutes around 16 to 36% of all eyelid lacerations. 20% of canalicular lacerations are associated with globe injuries also. And according to literature, 72% involve the inferior canaliculus, and 15.7% can involve the isolated superior canaliculus, and 12.4% can be bicanalicular. So canalicular laceration can be caused due to direct or indirect trauma. And direct trauma can be from sharp penetrating injuries like from glass, metal, or can be from dog bite injuries. And indirect trauma can be a result of blunt trauma like fist injury, or finger trauma, or road traffic accident, or a fall. And the basic pathophysiology of the canalicular laceration revolves around two mechanisms. One is the lack of tarsal support mechanism, and the other one is the funnel zone theory. So according to Wolk et al., they have demonstrated that due to lack of tarsal support in the lacrimal portion of the eyelid and the stiff attachment to the medial canthal ligament, whenever there is a excessive lateral stretching of the eyelid, the eyelid ruptures at the weakest point, that is the canaliculus, and the canaliculus ruptures. So this is one theory, and the other one is the funnel zone theory by Jordan et al., who have stated that the canalicular system lies in an area like a funnel, where the superomedial orbital rim and the side of the nose, they act like a funnel, and the canalicular system sits at the base of the funnel, which allows, that area becomes very accessible to sharp objects which can approach the area. And they have mentioned that majority of trauma is due to direct injuries rather than the indirect type of trauma, as was supported by the previous study. So what will happen if we don't repair a canalicular laceration? It may cause scarring of the tissues. It may lead to coloboma, or it may lead to symblepharon at the conjunctival, or it may lead to lacrimal canalicular fistula. So we should repair each and every canalicular laceration which comes to us. And regarding the diagnosis of the canalicular laceration, it is quite easy. There's a definite history of injury at the medial side of the eyelid and the medial canthus. The temporal cut end of the canaliculus can be detected by probing with the Bowman's lacrimal probe. As we all know that the lacerations are classified as proximal and distal according to the distance of the lateral canalicular lacerated end from the punctum, and the involvement of single canaliculus or both the canaliculus. So once the diagnosis is confirmed, we should do the surgery as early as possible. In young children, examination under anesthesia should be done. And in cases of complex facial trauma and foreign body, CT imaging should be done. So we should never forget about the injuries to the globe and the adnexal structures. And the ruptured globe should be treated on an urgent basis prior to the eyelid surgery. Tetanus toxoid should be given. It is a must in patients more than 10 years. And in cases of dog bites, after assessing the risk, we can give rabies vaccination. Oral antibiotic prophylaxis can be given in all cases. And in infected ones, we can give intravenous antibiotics. Coming to the principles of a primary canalicular laceration repair, it can be done under infratrochlear or infraorbital nerve block or general anesthesia in pediatric cases. We should first clean the injured area and look for any foreign bodies. And the most important step during a canalicular laceration repair is identifying the medial cut end of the canalicular laceration under high magnification, and intubating the canaliculus with stents to prevent further stenosis. And end-to-end or the pericanalicular suturing should be done, and eyelid laceration should be repaired thereafter. So these are the basic principles. So the most important step, which is the identifying medial cut end by the classical Calamari ring sign, which can be seen here as a whitish ring of rolled epithelium inside the red orbicularis fibers. If it is not visible, we can use even fluorescein dye, viscoelastic air, or methylene blue from the opposite punctum. We can inject local 1 lakh adrenaline or 2.5% phenylephrine to see the cut end. Or as a last resort, we can use a pigtail probe. Various special illumination techniques have also been described, like the 23 gauge optic fiber illumination and the Chandler's illumination techniques. Now, regarding the timing of surgery, 6 hours, the laceration should be repaired within 6 hours, and the standard treatment says that it should be repaired within 24 to 48 hours. And even if we repair it a bit late, like in 1 to 5 days or in or a maximum of 2 weeks, the literature have shown that delayed repair also has good success rate, like as in the primary repair. And in medically unfit patients, we can take those cases in 2 weeks also. So there's a controversy regarding whether you should do a monocanalicular stenting or a bicanalicular stenting. So regarding the monocanalicular one, it is a simple technique. It can be done under local anesthesia. There is no iatrogenic injury to the uninjured one, and there are chances of tube extrusion and the granulomas. Bicanalicular stenting is technically difficult. It requires general anesthesia or a nasal endoscope, and it involves iatrogenic injury to the uninjured canaliculus. But the advantage is that there is good apposition and there are less chances of extrusion, and but still there can be cheese wiring. In cases of repair of old laceration, bicanalicular stenting, I feel it is a must. The various surgical options available are the monocanalicular or the bicanalicular stenting. And bicanalicular stenting can be annular, or it can be used. It can be done by nasal fixation, or a self-retaining stent can be used. The stent material, what do? They dilate the lumen of the canaliculus, they straighten the canaliculus, and by a capillary action, they maintain the patency of the tear flow system. So the most commonly available stent materials are the mini monocas, and we can use, if there is no mini monoca available, we can use the Neoflon or the silicone rods. And for bicanalicular stenting, we can use the bicanalicular Crawford stents. And in a few cases, Prolene sutures have also been used. I'll be sharing the video at the end, sir. Regarding the post-op management, we can give oral antibiotic. We usually give Cefixime 100 to 200 milligram twice daily for 3 to 5 days. And topical antibiotic, moxifloxacin 0.5%, 4 to 6 times a day, we can give for a month. And follow-up should be done at 1st, 2nd, 4th, and 6th week till 3 months. The mini monoca should be removed after 6 to 8 weeks. The bicanalicular stents can be removed after 3 months. We should tell the patients to avoid rubbing. And after stent removal, we can do the fluorescent dye disappearance test and the syringing to know the success of the surgery. So functional success is defined as the lack of epiphora postoperatively, and anatomical success is defined as the when there is a patent lacrimal system on irrigation. Success rate varies from 65% to 100%. Complications after canalicular laceration repair can be the cheese wiring of the silicone tubes at the level of the punctum. They can be pyogenic granuloma. They can be corneal irritation leading to keratoconjunctivitis. And there can be failure of the laceration repair, which can lead to persistent epiphora. Or there may be premature extrusion of the stent material. So to conclude, eyelid injuries require a detailed examination of the globe and ocular adnexa prior to the canalicular laceration repair. And we should repair the canalicular laceration as early as possible, as we all know that healing by primary intention is better than the secondary intention healing. And good illumination and high magnification is required during the surgery to identify the medial curtain. We should always use a stent during the surgery, which will improve the cosmetic as well as the functional outcome. And the pericanalicular suturing should be done by a 5-0 or a 6-0 vicryl suture. Tube removal should be done at 6 to 8 weeks. Thank you. Now I'll be sharing the video. So is it visible?
No, it's not visible.
Share screen option, ma'am, you have to share the video also.
First you open the video, then share it.
Sorry, I'm not able to.
Okay. In the meantime, sir, any comment from the panel?
I think she has presented nicely. And of course, it is a common surgery, and I think everyone should do it. The crux is always that she also stress that actually to find out the medial curtain. That is the key.
Yes, sir.
So
Yes.
by all means, you have to find the medial curtain. Otherwise, whole purpose of surgery will go waste.
Yes,
So
sir.
that you have stressed enough. At the same time, the Minimonoka, of course, is a good choice. Minimonoka is a good choice. But if it is not available, then of course the Venflon 24 or 22 gauge, it is available. And or if it is not available, then of course silicone rod is the option which can be taken. But most of the time, the silicone rod which is available is actually having more thickness. So sometimes it doesn't go actually.
Nasal lacrimal tube, sir, can be used. Nasal lacrimal tube.
So, okay, Dr. Hadeep, if video is can be shared, okay, we'll see. Otherwise, you can go ahead.
Ask one question if I'm allowed.
Yes, sir.
These type of canalicular and lid avulsions injuries are also common in patients having those animal bites, especially the dog bites. So
Yes.
they are very, very common. So, but in the dog bite or in animal bite, principle would be slightly different, whether to do a primary closure or not. So would you like to comment on it?
I think primary repair should be done after giving prophylactic antibiotics and proper vaccination. We can carry on with the primary repair.
Actually, guidelines are that actually you should do a proper lavage with antiseptics. And if there are some necrosed tissue, then you have to do proper this excision of these thing, and then of course all the rabies vaccine or what injection, whatever are
anti-rabies profile,
they should be taken up. And if sometimes it also happens that there's some loss of tissue. If there's a loss of tissue, then of course you cannot go for the primary repair. Then in those cases you can wait for some time and then do secondary repair as advised.
Very well summarized, sir. And one thing more, because these are very, very these are the facial injuries, right? So this is very close to your brain. So you might also want to inject immunoglobulins. Because it comes in the category.
Right.
Thank you, Dr. Swati. Actually, mini Minoka stent is made by many companies in India also nowadays, and that is availability is not a problem. So I hope that all oculoplastic surgeons should have mini Minoka stents in their OTs. And the main important thing after putting mini Minoka stent is the pericanalicular tissue is very meticulously under microscope should be sutured with 80 Vicryl, 2 to 3 sutures. Then you suture the conjunctiva also in 2 layers, so that there should not be any notching or any bunching of the area, because that medial cancer is so beautifully designed. So any kind of scar is quite not appreciable in medial canthal area. And patencies only can be maintained when their meticulous suturing is done.
Even after, I would like to add one thing more. And even after all of this, we always tell the patient or counsel the patient about a possibility of post-operative epiphora, because howsoever meticulous repair you do, there might be chances of tube loss or patient self-inflicting it. So always we should counsel and mention and document it as a complication that patient might land up with post-op epiphora.
Can I make a comment, Dr. Hardeep?
Yeah, sure.
Welcome. Yeah, sure. So, well, we all are oculoplastic surgeons and we do know the need, and we always store these things. We give an indent, but there are situations where, in a medical college or in any centers where they don't have a department of oculoplasty, they see a lot of trauma cases. So is there any alternative, a very simple alternative to, the stenting, which can be at least done and not close it without a stent, which we can just tell the general ophthalmologist here?
A normal nasolacrimal stent can also be used because it is a very malleable tube, and you can bend it and also suture over the cheek. That is the one alternative. The other alternative, you can use 24 gauge Venflon, and you cut the Venflon and heat with the hot plate and just press over the flat surface. It makes a collar. So that also helps in true extrusion and you can suture that collar along with the skin. So that also helps as a homemade type of thing and cheap and best. Yes. Are not available.
Dr. Fairuz, actually, when because I always worked in medical college, so there normally we don't have anything supplied from the government. Absolutely. So we have to make some alternative arrangements, and in that arrangement only I found out this Venflon of 24 and 22 gauge accordingly, and just take that outer part, the plastic part, the synthetic part, and just insert it. It works very well. There is no problem.
Yes. Yeah. Even
we can use the Prolene suture.
You see, mini Minoka came very late in practice. Actually, initially, if you see 20 years back, there were no stent was available. So we were using all these remedies.
Yeah, so what I just wanted to highlight here is not having a mini Minoka handy doesn't mean that you don't,
But mini Minoka is an appropriate stent. But a mini Minoka is an appropriate stent and it's not that costly. Yeah. And being oculoplasty, we are dealing in oculoplasty, we should have all these things in hand.
Yes. So the message that I wanted to highlight here is for general ophthalmologists who are not equipped with an, oculoplasty practice and who might land up with, attending to a trauma case surgically. So yeah, thank you very much.
Thank you.
Dr. Fairuz highlighted that this is what we were discussing is for non-oculoplastic surgeon. Yes. Because what we are getting is as referred cases that without a stent they are suturing very haphazardly, and they are sending them it is very difficult to manage.
And you cannot do anything about it, once it is healed.
From the periphery.
I got it.
Okay, sir. Thank you very much. Sir, Dr. Subhash Betheria, sir. Dr. Binya, you just shut down your this screen.
Stop screen sharing.
Yeah. Dr. Betheria, sir. Dr. Betheria, sir.
Sir, Dr. Betheria, please unmute.
Sir, unmute and.
Okay, am I audible now?
Sir,
yes, sir.
Sir,
yes, sir.
Sir, sir, Betheria, sir. Sir, pranam aapko.
Pranam beta.
Sir, Dr.
Betheria, I am feeling very happy today to see all my students and dear friends here. And I think I'll be telling you something about dermolipomas. Is that correct?
Yes, sir.
You see, we come across dermolipomas, and the problem in management of dermolipomas are twofold. One is you might damage the ductules of the lacrimal gland and cause the dry eye in the long run. And second problem is, since it is on the lateral side where there is lateral rectus, you might damage the portion of the lateral rectus and cause diplopia. So these are the two problems. So how we have to manage these cases of dermolipoma? Many people just do not do any surgery. They just pass a double arm suture and pull the dermolipoma upwards so that it is hidden inside. But if it is a cosmetic problem and especially bilateral in a young person, then you have to manage it surgically. So what we do is anteriorly on the medial side, you place an incision, dissect the whole thing from the conjunctiva, and care should be taken to preserve the maximum conjunctiva without damaging any portion of the conjunctiva after giving a local anesthesia. And posteriorly, there is Tenon's capsule. So you have to dissect the thing from the Tenon's capsule and do not go more superiorly, because superiorly there is lacrimal gland and the ducts of the lacrimal gland. So you have to be very careful to identify the lacrimal gland and prevent any damage to the lacrimal gland and the ducts of the lacrimal gland there. And then if you go too much above and the dermolipoma is going very deep inside and too much above, then it is better to leave small portion of the dermolipoma above rather than risking for a dry eye by damaging the ducts of the lacrimal gland. And then after you excise the whole thing, meticulous suturing is done. For conjunctival apposition, I use 8-0 Vicryl sutures, 3-4 sutures, 3-4 stitches I give, so that the area is nicely covered and the conjunctiva is nicely apposed. This is how we routinely manage these cases of dermolipomas. Thank you very much.
Sir, it was a very nice description have you shown. So just for the sake of this, our audience, how do we identify the lacrimal ductules on the table?
Lacrimal ductules under microscope, you have to see how they are shown. And under microscope, you are able to see the palpable part of the lacrimal. The palpable part is there, which we all see, and the orbital part is only seen when I do the orbital surgery. So what we are seeing is the palpable part, which is a granular appearance of the lacrimal gland, and they are going into the fornix area. So that area we don't have to reach that much above. So we have to avoid basically the area above in the region of the lacrimal gland, so that the glandular part is clearly visible and the dermolipoma part is visible. The glandular part is little whitish, whereas the dermolipoma part is yellowish because of the fat. So you can distinguish and do not go higher up, do not damage the area of the.
But in wide excision, in cases where there is a wide excision, a lot of
Sorry to
noise is
interrupt.
coming.
Sorry to
from this side.
interrupt. Someone is mic is on. Can we tell all the others to mute the mic other than the speaker? Go ahead, Dr. Hardeep.
Hardeep, please tell me what is the question.
Dr. Hardeep, you're muted.
Yeah. In case of very wide excision or big dermolipomas, what else you have used, like conjunctival grafting or some pedicle grafting or free grafting from the conjunctiva? Because it causes a lot of scarring otherwise, causes restriction of movement later on.
No, Hardeep, if your dissection is meticulous, you see, you just inject and just beneath the conjunctiva you inject. Just
only
like
in
you
cases
do.
where there is the big dermolipoma.
No, even if I have the photographs, but I don't want to waste my time on that. We have got photographs to show you the dermolipoma, big dermolipomas. Beautiful. Idea is to preserve the conjunctiva. If you are able to preserve the conjunctiva, there is no need of grafting.
Yeah.
Grafting will come into picture if you damage the conjunctiva, if you excise the conjunctiva.
Yeah.
So you have to be very careful. Actually, meticulous dissection, preserving the entire bulbar conjunctiva, separating the mass, and be careful not to damage the lacrimal gland and do not injure the lateral rectus. These are the two things which are there, which you have to bear in mind, and then you will be successful.
Dr. Hardeep, just if I may want to make a comment that dermolipoma usually you don't have the problem of conjunctival sacrifice because you just give an incision, sickle sap incision on the conjunctiva, just concavity towards the cornea, and just dissect on the dermolipoma from the conjunctiva. As soon as there will be opening, this fat will automatically come out. Only catching the fat as much as you can pull out, you just excise it, and the place where from the herniation is coming, if we close that part only with the vicryl, there is no relapse. So that is, I think, is a key that if you find that the herniation hole from where this fat is coming in front, if that is closed, then there is no recurrence of that thing, and there is no damage of the conjunctiva as well.
True. Have you come across any medial canthus dermolipoma or inferior fornix, which is more difficult to remove?
No.
But in the
Dr.
literature,
Dr. Hardeep is alluding to a situation where there may be keratinized area or hair-bearing area.
Yeah.
Sometimes that area is adherent also to the underlying dermolipoma tissue. In those situations, you do need to sacrifice that part which is keratinized or hair-bearing. But generally, the conjunctiva is expanded because of dermolipoma.
Yeah.
That kind of a spindle can easily be spared. You try and not eradicate all the keratinized area. You just reduce the most keratinized area and the hair-bearing area so that you still have enough conjunctiva. Normally, you don't need to resort to any flaps or grafts in order to make up for the loss. But if you really have to sacrifice, you can easily mobilize conjunctiva or use a flap. In situations you don't, because it's only a small spindle area which is adherent to the deeper dermolipoma tissue and needs to be excised. I think as Dr. Maria has stressed, you're not an eradication program. You are basically trying to debulk. Because it very gradually merges into the orbital fat. So you make sure that your purpose is debulk to an extent that it is no longer a cosmetic or a problem due to the irritation caused. You just excise that part and do a reasonable closure. That suffices very well.
Yeah.
Usually you don't cause any injury to the lacrimal tissue because you can dissect it and retain most of the fat. You don't really need to go very deep and just excise the part which is taking care of the palpebral tissue.
Thank you, sir. Thank you, Dr. Bitharia, sir.
Thank you very much.
Dr. Raj Anand will tell us the ptosis management in anophthalmia. Dr. Raj?
Okay. Can you hear me?
We can hear you, but share your slides.
All right. Yeah, can you see my slides? Hello?
Not yet.
Can you see my
Yet, Dr. Raj.
Not yet.
Is it visible, my slides?
No.
Dr. Raj, please open it. Keep it
Yeah,
near
you
the
have
side,
to
make it
share your
smaller,
screen.
and then share. And
It is
then
there
click
on
on
my device.
PowerPoint.
Okay.
Please share your screen.
Yeah.
Have you opened your presentation?
Yeah, my presentation is open on the device.
Then share. You have to click the share button below.
Zoom, there is a
नीचे लिखा हुआ ना share.
Hardeep, can we have Dr. Mukesh's presentation while Dr. Raj Anand?
Yes, sir. Yes, sir. We can do this. Yes. Mukesh, are you ready? Anand, you make it.
Can we request everyone
to
to
Mukesh.
mute themselves?
I request everybody to unmute, to mute their mics.
Hi, Dr. Mukesh. You might have to unmute your mic.
Good morning, everyone. My presentation is visible?
Yeah.
All right. So I am supposed to speak on ptosis management in 7 minutes, which is, I believe, next to impossible. So I'll just touch upon the silent features, and wherever my time will finish, I'll stop there. So one important point is when to operate a case of ptosis. 4 to 5 years is the ideal age, unless and until amblyopia threatens. Then what are the options available with us? If ptosis is mild, then we can go ahead with conjunctivomullarectomy or fascinella servata resection or levator resection. If ptosis is moderate, then levator procedures are the procedure of choice, resection or plication. And if it is severe and bilateral, then there is no other procedure but to do a frontalis sling. And if ptosis is unilateral and severe, then we may go for frontalis sling, and some people do opt for levator.
You are not audible.
Mukesh, can you check if you are muted or something?
नहीं freeze हो गया sir.
Connection. Yeah. Next speaker try करो फिर तब तक पूनम जैन और फिर
I think he will come.
Signal poor होगा. You were supposed to finish it.
Poonam, then keep yourself ready. In case in a half a minute, if he don't come, then you start.
I am ready, Hardeep.
Just wait for a half a minute in case he comes back.
I can try calling Dr. Mukesh, Dr. Hardeep, and find out.
Meanwhile, Poonam can start.
I think sir is right. Poonam can start. We should not
Okay,
waste the
so
time.
I'll start
Yeah.
sharing my screen, but
It's on the bottom
probably Dr. Mukesh has to stop sharing his screen, huh?
His share is off at the moment. There is no
Acha.
sharing at the moment.
Okay.
So he's off the line now.
Shall I share my
Go ahead,
screen?
go ahead, please.
Yes.
Do that. Share.
Okay.
I hope my slides are visible and I'm
It's
audible.
visible. Yeah.
Visible?
Both.
Oh, now Dr. Rajanand has started sharing the screen.
Yeah.
So I'll stop share. Okay.
Okay. Okay.
Hello.
Is Dr. Rajanand sharing the screen?
Yeah.
Raj?
Poonam.
Okay, you start.
Start your PPT, Raj.
Hello, Dr. Hardeep.
Yeah.
Can
Now
you
it's
see my
okay.
slide now?
Yeah. Now we can see.
Good.
Go ahead.
Okay.
Sorry, Dr. Poonam.
Yeah, that's fine. Fine, Raj.
All right. Thank you, Dr. Hardeep and Dr. R.C. Gupta for the introduction. Ptosis is something similar that we see otherwise, but there are some special points in anophthalmia that I'll be trying to highlight. First of all, we need to understand the dynamics that lead to ptosis in case of anophthalmia. All the septa and soft tissue are held in place by various soft tissue arrangement. And once the eyeball is removed, this support goes and the soft tissue tends to fall back and posterior. As you can see in this diagram, there are two parasagittal sections. Once the globe is removed, as you see in the upper CT scan, everything tends to fall back and cause ptosis. The most important thing in management is, of course, to prevent it from happening. How do we prevent ptosis from happening? Is to maintain the socket dynamics as much as possible while doing enucleation or evisceration, use orbital implants, and during surgery, be very careful not to damage nerve on the orbital apex. And when we operate for evisceration or enucleation, it is important to look at the lid crease position. The patient may be having a pre-existing epineuritic ptosis, which may not be visible pre-op, and then patient may present with ptosis later on after the surgery. Like in this patient, the patient had ptosis before surgery. The patient underwent evisceration, prosthesis was given, but he still had ptosis, and there was raised lid crease. So subsequently, a LPS resection was done to correct this. As I mentioned, meticulous surgical detail is important to maintain the socket dynamics. After the eyeball has been removed, the orbital implant must be placed within this cone of posterior septum so that it remains central and it allows good position of rest of the orbital tissues. And this has to be closed in layers.
Your screen is not visible.
Yeah, my screen has suddenly gone blank. I'll just see. My screen has gone blank. I'll see. Oh, there is some problem, is kind of got hanged. I can't move it.
Pradeep, can we start with Poonam then?
Anand? Can you hear me?
Sorry, Dr. Hardeep, it seems to
okay.
have gone.
You keep it ready. We will see in the end. Let the Poonam start right now. Okay?
Yeah, Dr. Poonam, please start.
My slides have become visible?
Excellent.
Okay.
Okay.
So, blepharoplasty is a powerful surgery to achieve periocular rejuvenation. But the challenge is, now my slide will also not move unless Dr. Raj stops sharing the slides. I think that is a problem. Maybe perhaps because both of us are.
Raj?
Yeah, Dr. Hardeep.
You stop your sharing.
All right.
If both of us will share, it will
I've
not
stopped.
move.
It's coming. Dr. Poonam's slide is coming. You can go ahead.
Okay. Okay. But this is also not moving. I think what I'll do is I'll stop share first.
Okay, you start again.
And then start again. Because I don't, and I will check whether my slides are moving and then I will proceed. Yeah.
Yeah. First you check your slides.
I have checked. They're moving. Now I will share screen. Yes.
Yeah. Now it has come.
Now you can see, no? Yeah. And the challenge in blepharoplasty is because no two eyes are similar in shape and contour. And very often the procedure has to be tailored as per the need of the patient and combined with adjunctive procedures in many cases. Many times, in fact, true perfection is not always attainable. No matter how experienced and trained a surgeon is, but patient satisfaction can more or less be achieved by a good preoperative counseling, setting realistic expectations and good photographic documentation, under promise and over deliver, and take a good informed consent. But what about surgeon satisfaction? When the surgeon looks back at the results, very often the surgeon feels that I can do it better, and next time let me achieve a better result. With this idea in mind, I performed a critical analysis of 78 cases performed by me, and 42% of them were males and 58% were females. Again, contrary to popular belief that females are more interested in cosmetic procedures. This is the first case I will share. I am going to present a few cases with suboptimal results and a few challenging cases in the limited time available to me. First patient, Sheetal Saluja, underwent a 4-lid blepharoplasty by a plastic surgeon. She was not happy with the results. When she came to me, she had obvious ptosis. There was medial fat bulge that she pointed out. There was an A-shaped deformity because of excessive removal of preoperative fat pad. And on careful observation, the lower lid retraction, minimal lower lid retraction was there with rounding of the lateral canthus contour. I performed ptosis correction by the posterior approach and did graded medial fat sculpting. This A-shaped deformity did not fully disappear. For lower lid, by doing a filler injection, the contour and the rounding of the lateral canthus improved to quite a satisfactory extent. The lesson learned and take-home message is that unrecognized and uncorrected ptosis is absolute no-no, which will limit the cosmetic result. Therefore, a preoperative assessment to rule out ptosis is absolutely mandatory whenever we are considering a cosmetic procedure, cosmetic blepharoplasty. If there is any asymmetry in the lid crease height or the brow, must rule out ptosis and measure the MRD1 in all the cases. This patient again underwent a posterior approach ptosis, fairly good result, but I was not happy with this medial fat bulge, which appears in the form of a teardrop. For a couple of more cases, a little problem area in my results was this medial fat bulge. So now I do a more meticulous preoperative assessment of the medial fat bulge, make a note of it, assess the patient in the sitting position, and titrate my fat pad excision more meticulously. This happens because the medial fat pad is different from the central preaponeurotic fat pad, which with time undergoes atrophy, whereas the medial fat, because of being the neuroectodermal origin with stem cells, goes on bulging and presents this unsightly medial bulge in the shape of a teardrop. Ptosis correction with good lid crease height and palpebral height gives good result, and slight brow asymmetry or brow fold asymmetry goes unnoticed if the lid crease height and shape is symmetrical. Whether we do ptosis correction by anterior approach or posterior approach is immaterial. The result can be achieved with whatever the doctor is, surgeon is comfortable with. Another patient with a different problem area. This patient underwent blepharoplasty. On hindsight, later on, I felt she had a deep superior sulcus and more tissue had been removed than required. Why did this happen? Because the judgment error was in the form of the eyebrow to lid crease height measurement was a little erroneous because the patient was plucking out her eyebrows. So one has to be more careful. When I saw the my pictures of the marking, I knew what I could have avoided. So upper eyelid markings are crucial to achieve optimal results in upper blepharoplasty. We should spend more time in marking the incision very carefully, holding the redundant skin with forceps and taking the measurements, leaving at least 20 millimeter under the brow, from brow to the crease. And the rough guideline is that the potential skin to be removed should disappear when the patient looks up. This is a very important key point to give better results as visualized in this patient, that the potential skin to be removed is virtually disappearing in this patient with asymmetric dermatochalasis and symmetric result. Coming to lower lid blepharoplasty, which is becomes more challenging because there is no single procedure. There are different algorithms and different procedures performed for different by different surgeons in different cases. But one thing to remember and always point out and emphasize is that the lower lid blepharoplasty is a surgery to address the contour of the lower eyelid rather than removal of skin. The crepiness of the skin, the wrinkling of the skin is going to remain. So we should not aim to remove more skin, and the skin issue cannot be addressed by the lower lid blepharoplasty. The skin removal and the tissue removal should be towards more conservative side. As evidence in this patient, the contour becomes better, but the crepiness will not go and will require more procedures. And as far as the lower lid is concerned, volume augmentation, deflation because of aging is more important than any other element. Now, my go-to procedure these days is to do a incision in the lateral part, lateral to the pupil. I remove skin only in the area lateral to the pupil, and whenever four-lid blepharoplasty is done, the gap between the two incisions should be more to prevent any webbing. or to bring the eyebrow down, then almost always I do a soof lift to give a better contour. This helps to reduce the amount of redundant skin that will be removed. It is only a few millimeters of skin that needs to be removed from the lower lid if we do not want to create the most troublesome complications of ectropion and lower lid retraction. The contour becomes better. The results are fairly good, acceptable, although even in this case,
Dr. Poonam, please sum
a
up.
better canthoplasty would have, I'll sum up. Yeah, 2 more cases would have achieved a better result. This is an interesting case, the last case that I'm going to show. This patient had extensive xanthelasma and she was more bothered with the xanthelasma in the lower lid. She had already undergone some procedure by a dermatologist for the upper lid. When I planned her surgery, I felt that I should remove the whole xanthelasma and because there was a lot of laxity. Now, the scar looked quite horrendous for some time. I want to again highlight that if we have to do any other intervention, we should wait for 3 to 6 months. Most of the imperfections heal with time. We should be patient when there is an intervention, a re-intervention required. So this is the result after 3 months and the patient is quite happy. So to conclude, blepharoplasty is a rewarding surgery with good anatomy and guidelining principles, and remembering the key points and revising our results and trying to improve them, we can give fairly good results. Thank you.
Thank you, Poonam. It was a nice presentation. The only nutshell take-home message is that preoperative evaluation is very important in these all cosmetic cases, that you have to look into all these parameters, brow height, crease, lid margin, laxity of those things, and you have to mark everything and note down on the paper before going for the surgery. And surgery is not a problem. The points which we have to address the problems, that is more important. It was a nice presentation. Any comment from the panel?
And preoperative counseling is very important in these cases.
Yeah, that is the first thing I pointed out, that preoperative counseling, preoperative assessment, and even documentation with photographs are extremely important, but we keep on striving to improve the results.
If you give more time before the surgery, then
Poonam, highlighted all the points very well. The only thing that you did stress also was the lower lid laxity is very important to assess and should be addressed almost always whenever you're doing a lower lid bleph. If there is a significant laxity, it must be addressed for optimal results. That is the only point to add.
Is there a time for one more question, Dr. Hardeep?
Yeah.
Yeah, Dr. Poonam, one question that I have for you is like, hi, ma'am. If at all there are festoons associated with, lower eyelid bag, is there something that you do or specifically that you would look into?
Yeah,
it's very difficult.
Yeah, this is a very important point. If a patient has got festoons, we must be very clear that the lower lid blepharoplasty is not going to correct festoons. We cannot aim to remove the entire skin to take care of the festoons. Another thing is that after undergoing blepharoplasty, the festoons, the area of the festoon shows much more edema. There may be more hematoma. There are different procedures. Some people excise the festoon separate from the blepharoplasty incision. Recently, I came across an article, but I have only used it in one patient, that tetracycline intralesional injection in the festoons has given good results. So let's see after trying
and what
in a few
injection,
cases, but festoons are not addressed by the blepharoplasty.
Ma'am, what injection?
Tetracycline
injection.
Tetracycline injection. Okay. This was a very recent article of 2020 PRS.
Okay.
And I hope to try more cases. I've given it in one patient only last week. And so far, I don't know.
Okay. Thank you so much for sharing that.
Dr. Raj, are you ready? Raj?
I think that we can take Dr. Mukesh Sharma.
If he's available.
Sure. Raj is sharing.
Raj is come.
Hello, Dr. Hardeep?
Yeah.
Yeah. I'll start sharing my screen.
Okay.
Is it visible now?
Now it's visible.
All right. So I was talking about importance of placing implant, and a right implant in right place can prevent occurrence of ptosis. And it is equally important when we cut the optic nerve. It should be not right at the apex, because there are particularly third cranial nerve. If that nerve gets damaged, patient will have post-operative ptosis, which cannot be corrected with LPS. So this is one such two such examples where patient had injury to third cranial nerve during enucleation, and post-operatively there was complete drooping with no LPS action. Such cases will need sling surgery to correct ptosis. And it is important that when we are correcting for when we are evaluating ptosis in anophthalmia, it must be done with an optimal prosthesis. If the prosthesis is not there, all patients of anophthalmia will show ptosis. So they first need a proper prosthesis, and then we need to check for their ptosis evaluation. Like this lady who presented with ptosis post-evisceration surgery. She was operated for LPS resection, but with the existing prosthesis, she had lid retraction. Because this prosthesis was very thick, in order to lift the lid, the ocularists tried to make a thick prosthesis, which was not actually required. So after correction of ptosis, she had to go for another prosthesis, which was optimally sized, and then she had good correction. So there are three main steps in ptosis management in anophthalmia: conservative, prosthesis modification, and surgical intervention. Naturally, conservative should be taken first, like if there is a deposit buildup, if the prosthesis surface is rough, it can prevent eyelid movement, and it can give rise to sticky discharge that can cause ptosis. So regular cleaning of the prosthesis and yearly polishing of prosthesis surface can take care of this ptosis. Second, there's some modification in the prosthesis surface can also take care of the ptosis. Like this young girl who was operated for enucleation for congenital microphthalmia. She was having ptosis in spite of the everything done well. And then there's all that was needed was a change in the front surface of the prosthesis so that lid can move freely, and it got corrected without any surgical intervention. However, when it cannot be corrected with prosthesis or conservative management, it needs surgery. The only two mainstay of surgery, either levator resection or frontalis suspension. What is important when we check for lid position intraoperatively, it should be done with prosthesis in place. Only then we'll be able to assess which is the correct height where you have to leave the lid. Similarly, in LPS resection intraoperatively, before we finalize, after tying the first suture of LPS, we put the prosthesis in place, and then we check on table if the lid correction, lid height has been achieved. That is the end point. And there are special situations like enterosteophylloma or congenital microphthalmia. In enterosteophylloma, we have to, I think again, there is some problem.
Slides are moving.
Yeah, there is extra lid laxity that has to be addressed during evisceration or enucleation, because if lid is extra lax, invariably it will be ptosis post-operatively. So during surgery, that extra skin has to be removed. And in case of congenital microphthalmia, we have to go stepwise. We cannot go straight forward. First, we have to replenish the volume, expand the lid, correct with prosthesis, and only after this, if ptosis is still persisting, we need to take for surgical correction. So to conclude, Optimal prosthesis must be in place before evaluation. Surgical trauma must be avoided during surgical procedure. If orbital apex is involved, most probably it's a trauma to third cranial nerve and patient will need sling surgery. LPS disinsertion will require attachment or resection with prosthesis in place. And in lax, eyelid needs to be cut, and in congenital anophthalmia, stepwise approach has to be taken. That's all. Thank you.
Thank you, Dr. Raj. I think it was very, very good presentation and you made all relevant points. Hello, we can, Dr. Hardeep,
Yeah.
we can go to Dr. Mukesh now.
Yeah.
Dr. Mukesh.
Dr.
Dr. Raj,
Mukesh,
very nice. We have different look.
He's here only.
Today.
Mukesh, in this, the main important thing is that the care of nowadays the customized processes available.
Yeah.
So there's not much problem of fornicid contraction, other things, but still care of processes is very important, which further leads to contraction and abnormality of the fornices. Okay, Mukesh, are you ready?
Yeah, I am ready, and
Okay.
I'm sorry for that net glitch. So I'll
No
be just
problem.
running through my presentation, and I'll take only 3-4 minutes.
Okay.
So I was telling that for mild ptosis, if phenylephrine test is positive, then conjunctiva mulerectomy can be done, and if it is negative, then it will not be successful. So you'll have to go either for fascinella servata or for levator resection. This is how phenylephrine test is done. If moderate ptosis is there, then levator procedures are the procedure of choice, and if it is severe, then you will have to do frontalis sling. One can do levator resection if levator functions are there. Fascinella servata resection, very simple procedure. Every 2 millimeter of tarsus resection will correct 1 mm of ptosis. But in Indian circumstances, maximal permissible limit of tarsus resection is 4 mm because our tarsus height is not more than 8 to 9 millimeter. So, and it will give you very predictable result. Just a brief video. So, a case of left eye mild ptosis. You pass 3 sutures in the tarsus, 3 traction sutures just to hold it. Then you mark 4 millimeter. You can strengthen your marking with bipolar cautery. It will reduce bleeding also and augment your marking also. Then 3 holding sutures or approximating sutures. They will go from fornix and come out in the tarsus plate ahead of your marking. So that these 3 sutures will approximate both the cut end when we will be doing suturing, and they will make our surgery quite simple. So once you have passed these 3 sutures, cut your marked area either by a diathermy. You can utilize scissor also. And after cutting this, by the help of these 3 approximating sutures, one can do suturing very easily. Classical suture is catgut, 4-0 catgut. One can use 8-0 vicryl also, but you will have to, your initial knot should be there in the skin. Then do a running suturing. And at the end, again come out in the skin. Your knot should be buried inside so that there will not be any corneal rubbing. So just push your needle and come out in the skin. So very simple procedure, but give good results. Conjunctiva mulerectomy, I don't think we have time to discuss this. Levator resection, I think this is the principal procedure for most ptosis patients, unless levator action is very poor. If levator functions are, it is guided, recommended lid position is guided based on the levator action. If levator action is poor, then we keep lid above the limbus. If it is between 5 to 7 millimeter, we keep lid at limbus or 1 millimeter below the limbus. And if levator functions are good, you keep lid at its normal position, 2 millimeter below the limbus. Then there is Puterman method also, guideline that MLD can be multiplied by 3. It will give you amount of levator resection which is required. Difference in MLD. Then this is a brief video clip of levator resection. You mark your lid crease, inject, replace 3 sutures, cut orbicularis. You will have bulge of orbital fat. This is orbital septum. You just identify it and incise it. Fat will bulge out. Underneath this, there is levator aponeurosis. This is levator aponeurosis. Again, pass, then inject xylocaine just to have a good separation plane. This is an optional step. After that, pass 3 traction sutures in levator stump. Cut horn little bit. If it is required in mild to moderate ptosis, you may not cut them also. While cutting lateral horn, you will have to keep in mind that lacrimal gland is there. This is lacrimal gland. So you are not supposed to injure this. This is lacrimal gland. And this is Wittnall's ligament. So you will have to identify Wittnall's ligament. It is not so well formed in all cases, but some marking of Wittnall will always be there. Then you mark your levator. You can mark it from Wittnall downward also, and you can mark it in traditional way also, depending on the amount of ptosis. Then you pass your 3 sutures. You can use either 6O Vicryl or the permanent Prolene or Rathibond sutures. Pass 3 double-armed pair. Adjust the height. Then pass lid crease sutures through orbicularis. Take levator stump in between and again come out in orbicularis. Excise strip of skin, and you can pass a running or interrupted skin sutures. So this is the end of levator resection. Frontalis sling indications we all know. Nowadays, most people are doing silicone rod. There are obvious advantages. It is potentially reversible. It gives least lid lag, ophthalmos, readily available, very easy surgery, and acceptable complication profile. Dictum is that but Fascialata is basically gold standard because it obviates all the problems associated with silicone sling. Though it requires general anesthesia, some learning curve, but still it is my procedure of choice. There are certain points about Fascialata surgery. I don't think we have time to discuss them. It can be done either in Crawford manner or in Fox's pentagon. I think for 1 minute more, I'll just show you silicone sling and I'll wind up my presentation. So pass 2 points equidistant from the center point. Generally, they are on either side of cornea. Then 2 points above the brow in line with lateral canthus and medial canthus, and 1 central point. Best is to use both the needles, then you'll have to make a track superiorly, and best is to use both the needles per eye. If you use both the needles per eye, you will have obvious advantages. I'll tell you what. You can remove your sleeve. You can use both. You can cut it in half and use that half in one eye. So just bend your malleable needles. Pass it from tarsus plate if you are using both the needles instead of passing from superior incision. Now, by doing that, you will have more control. You are not going superior to downward. There you will have less control. Here you will have more control, and you will be passing your needle exactly in the plane where you want, above the levator. Underneath the orbicularis, you will have more idea about the tissue planes because you are going into the natural direction of your hand movement. To do that, your needle should not be entrapped anywhere. Once you have passed it, then you will have to thread your sleeve. It is very easy if you are having both the needles to just thread sleeve by your needles itself. You are not supposed to stretch the sleeve by needle holder or so, because you are having both the needles attached at sling's end. Then you will have to bury it inside the tunnel, long tunnel which you have made. So it is very important. And then do suturing in 2 layers. And you are done with your surgery. Post-operative. This is around 1-year-old child, and this ptosis was pupil covering, so we had to do surgery little early. So I think this is the end of my presentation. Time I already, I think, exceeded my time. Thank you. Thank you for your patience hearing.
Thank you, Mukesh. Very nice presentation and videos. And any comments or any questions from the panels or audience? Dr. Gupta? Shalu?
I want to thank Dr. Mukesh for reviving the old memories.
Yes, sir.
Of showing the modified fascicular servet operation, which I published. That was my first article to be published in British Journal of Ophthalmology, March '83. And it was adjudged as one of the best articles in that oculoplasty section and was republished in 1984 Yearbook of Ophthalmology. So, and most of these sling surgeries, etc., no, they started with my innovation, which I published in Modified Simple Technique of Sling Surgery in British Journal of Ophthalmology in 1985. And then only these needles have come and the things have become easier. Otherwise, I used to have those 2 long needles of about 15 millimeter sharp needles and Ethibond suture and the same method of passing the sling. So that article, every 2 years, I had a publication in British Journal. So that was another publication on frontalis sling, modified simple technique. Thank you very much, Mukesh.
We've all been beneficiaries of the pioneering work of Dr. Bhattaria, I think.
All of you.
I had the privilege of being his senior resident at that time and being a co-author for that article.
Sir, it was in, I think, yearbook. The fascicular modified fascicular servet.
It was.
Yes, 1984 yearbook and 83 British Journal of Ophthalmology.
Yes, sir.
It was my privilege to have worked under Dr. Bhattaria.
Most of us.
Grateful to all of you because we had a one-to-one relation and just like a family. So that was a fantastic time which we enjoyed. I'm grateful to all of you.
Thank you, sir.
So, Dr. Hardeep, we can go ahead.
Yes, sir. You do the final finishing.
Now, everyone has presented so well, and I think it was very good inputs from most of the panelists also.
Sorry to interrupt you.
Yeah.
Excuse me, sir.
Swati Agarwal's
presentation.
Yeah. Swati Agarwal's presentation is due.
Yes.
So, Dr. Swati, can we have your presentation now?
So my presentation is also due, sir. Sorry.
Okay.
Yeah, please start.
Actually, the list which I have, okay, they I think revised the list. Okay.
No, we can go ahead. No problem. Dr. Swati, please.
That is not a problem.
Good afternoon to everyone. I'll be talking on emergencies of orbit and adnexa. I'm a consultant oculoplastic surgeon at Meerut and Muzaffarnagar, and it's indeed an honor to share the screen with so many eminent speakers. So a patient walking into our clinic where inappropriate treatment might lead to a sight loss or a life-threatening situation is a nightmare to all the ophthalmologists. So without further ado, the emergencies can be divided into traumatic and non-traumatic. And these are the few traumatic ones and these are the few non-traumatic ones. I would like to do justice to this vast topic. So first things first, orbital trauma. The three key questions is whether it is a pure eye or a multi-system injury, whether it's an open eye, or a patient has any systemic comorbidities. So first, always assess the ABCs, avoid MRIs in view of any magnetic foreign bodies, and in cases of open injuries or a sinus fracture, always give prophylactic tetanus toxoid, systemic antibiotics, and painkillers. Medical legal aspect of these patients should be always borne in mind. So closed eye injuries usually come with blunt trauma, orbital blowout fractures. But one thing which one should be very, very clear about is if you see a gross ocular hypotony or a relative apparent pupillary defect, then you should keep in mind a possibility of occult globe rupture. So globe rupture like these are very, this is clearly visible. You can see a large scleral limbal laceration with a uveal tissue prolapse, but sometimes it can be subtle as this. So a general inspection of an eyeballs is very important. Sometimes the scleral perforation might underlie a conjunctival laceration or a hemorrhage, which is extending up till the fornix and the posterior extent is not visible, might be a case of occult globe rupture. And things like this, obviously, an issue of primary repair versus a primary evisceration is debatable. Subluxation is that the equator of the globe crosses the orbital rim. It can be traumatic or it can be non-traumatic also. And immediate repositioning of the globe back into the orbit is an emergency. Exposure keratitis, like in this, it can happen. So if there is a no tissue defect, no tissue loss, then you can directly go for a primary repair. Or in cases with tissue loss, consider options like flap or lid shearing procedures. Animal bite, again, facial injuries and most likely dog bites, especially the pediatric age groups. So the general principles of animal bites would remain the same along with concurrent immunization and control of infection. But these are usually pediatric age groups. So one should always tell them to remain nil per oral for the need of general anesthesia. Eyelid and lacrimal trauma. Thorough knowledge of anatomy and principles of repair is very important to achieve maximum functional and cosmetic outcome and to prevent long-term sequelae. Orbital fracture, as I mentioned before, the trapdoor fractures are the ones which should be dealt within 24 hours. But sometimes long-standing fractures can come in our OPDs with discharging sinuses, which could be either due to traumatic nasal duct obstructions or due to retained organic foreign bodies. So intraorbital foreign bodies, organic, reactive, contaminated, should always be removed. But unlike intraocular foreign bodies, if it is an intraorbital small, posteriorly located inorganic foreign body, it can be considered for no-touch technique. Traumatic optic-neuropathy has a very poor prognosis, and a decision, if the traumatic optic neuropathy is progressive or there is delayed vision loss, then one might think to go ahead with surgical intervention. But in both the cases, the prognosis remains the same. Retrobulbar hemorrhage can be traumatic and non-traumatic. Now, this is an orbital compartment syndrome, where the intraorbital pressure rises to compromise the vascular supply of the optic nerve. So a sight-threatening situation, immediate canthotomy followed by inferior cantholysis should be done. If the pupils do not return to normal, one can proceed with septolysis or even a bony decompression. Now, these chemical and thermal injuries, they have a long-term sequelae. So immediately when you see this patient, obviously cool compresses and the normal treatment, but to protect the cornea, you can take a call on tarsorrhaphy or a tenoplasty. Similarly, Stevens-Johnson syndromes and toxic epidermal necrolysis, you have to mention this, you have to do the sequelae repair like lid marginal keratinization, entropion, simplifron. So among non-traumatic things, severe fulminant thyroid eye disease is one where you have to consider corneal protection either by tarsorrhaphy or Botox, and to avoid compressive or dysthyroid optic neuropathy, can go for IV methylprednisolone or can even consider orbital bony decompression, especially the medial wall. In this orbital apex inflammation, I would like to emphasize on mucormycosis, which is one thing which is not only vision threatening, but also life threatening. So an immediate sinus biopsy or an orbital biopsy to prove or to confirm the diagnosis, along with systemic control of the diabetes. Now, endophthalmitis and PANOF, when the medical treatment fails and the patient is still in pain, can consider for evisceration. Eyelid infections, I think everyone of us has come across herpes zoster, but bad eyelid infections like necrotizing fasciitis You have to do an adequate wound debridement, regular patient dressings, and care the patient with systemic antibiotics. Orbital infections have a bad prognosis, and they are emergency cases, especially the orbital abscess or subperiosteal abscess, where you might need an orbitotomy with drainage. And last but not the least, being oculoplastic surgeons, we also face complications like complications of Botox and fillers. So Botox or fillers, if they have allergic reactions, we can manage them with methylprednisolone or epinephrine. But a thorough facial anatomy, especially of facial arteries, is very, very important, because inadvertent injection into the facial artery can lead to skin necrosis and even blindness. So I would like to deeply convey my appreciation and gratitude to my mentor and guide, Dr. Vipasha Mukherjee, who has always guided me and supported me and encouraged me, and has allowed me to share information with her published book, Emergencies of Orbit and Adnexa, which is a must and worthy read, not only for oculoplastic surgeons, but for aspiring ophthalmologists, as well as dermatologists and facial plastic surgeons. With these words, thank you for patiently listening.
Thank you, Swati. You have covered almost all points in the orbital trauma. As we are running short of time, I request the next speaker to please deliver his talk. I don't have the list of the next participant.
Hello, Dr. Hardeep.
Yeah.
I'm Dr. Chandana Chakraborty from RIU Kolkata.
Okay, madam. Please, madam.
Okay.
I think this is the next session or what?
Dr. Chan,
this session has ended, sir.
On the next
our session. Actually, Dr. Hardeep, this was the session up to 12 o'clock.
Okay.
So we have exceeded. So now we have to we have to give away, and the next chairman will do it. Okay. Thank you so much, all participants, Dr. Betharia, Dr. Grover, Dr. Hardeep, Dr. Swati, and others who have joined later, Dr. Lakshmi, Dr. ERM, Dr. Roshmi. So thank you so much for
apologies to them
with us for so long.
Thank you, sir.
Thank you for these opportunities.
Thanks to everyone. Nice listening to great talks.
In fact, I'm really relieved because I was worried about getting late for my session. So there's no worry here.
We are always there to take care of you, Ravindra Mohan.
Sure.
Thank you, sir.
ये जो है ना मेरा इधर है, so I don't want to touch it कि चले जाएगा connection. तो मेरा वाला जो है 12 से 1:30 बजे तक. We started in 12:15. So they were running late.
So we have the next session on orbit to be continued. We have Dr. Subhash Betharia as the chairman, Dr. Ruchi Goel as the co-chairman, convener Dr. Akshay Nair, co-convener Dr. E. Ravindra Mohan, and I will be the moderator. Do we have all the chairmans, the co-chairman, the convener, and the co-convener on Zoom platform? Dr. Betharia is there. Yeah. I can see Dr. Mohan. I can see Dr. Ruchi. Are you there? Dr. Ruchi is not there. Dr. Akshay, he is there. Akshay, do you want to unmute? Yes, perfect. Yes. Dr. Betharia, do you want to open, do you have any opening remarks for the orbit session? And over to Akshay.
I think orbital surgery is a very complicated topic, and it has to be learned from a teacher properly. And the orbital anatomy you have to be very conversant with. At our time, I had a skull which I used to teach all the foraminers, fissures, and what is the anatomy. And now several things have come, especially this endoscopy, etc., which was not very much there at our time. So I'm really looking forward to newer advances and newer techniques which you people are practicing these days. But basic thing remains is that we should not go very posteriorly and should not damage the various nerves at the apex of the orbit. And at the same time, we should not damage the muscles. And the common problem of visual loss and the diplopia were the main things which you have to tell the people, and do not be overconfident in orbital surgery, and try to remove the encapsulated masses with the cryoprobe. That is an advantage which we had. And using the striker saw, be careful so that you do not damage your fingers and all that. I think with this opening remark, I would request you to continue the session. Dr. Akshay Nair, please.
Akshay, are you there? Akshay seems to have frozen. Okay, go ahead, Akshay.
Yeah, no, I think, I'm having a little network issues, but I think with those opening remarks, which are perfect for us to begin the session, our first talk is by Dr. Praveen Kumar Mongre, who is from Delhi NCR, an eagle-eyed surgeon who always has his extremely sharp observations on our social network groups. He'll be talking to us on TED assessment, the assessment of thyroid eye disease. Sir.
Yes, I'm audible.
Yes, sir.
Yes,
we
very
can
much.
See your slides.
Thank you very much for giving me this opportunity to talk on thyroid eye disease assessment. Thyroid eye disease is an autoimmune disorder which is mostly mismanaged and improperly treated because of heterogeneity of its clinical manifestations and failure to understand the relationship between eye disease and the thyroidism. This wide-eyed appearance is quite characteristic of the thyroid eye disease. The most common extrathyroidal manifestation of the disease. 50% of the patient with diagnosed with Graves' disease will develop thyroid eye disease sooner or later, maybe within one year to a decade. If we happen to diagnose thyroid eye disease first, before their systemic diagnosis, 90% of them will turn into hyperthyroidism within 1.5 years. 5% of them hypo and 5% still remains euthyroid for a long time. Just a few points about the pathophysiology. The three key players are orbital fibroblast, TSH receptors, and IGF-1R receptors. These insulin-like growth factor 1 receptor and TSH receptors, they cohabitate on the orbital fibroblast. They transform, express their overstimulated and their antibodies against them. So they act, they have synergistic action and enhance the TSH receptors, causing the release of cytokines, glycosaminoglycan, and hyaluronic acid, ultimately causing fat proliferation and myofibroblast differentiation, resulting into the overcrowding of the orbit and extraocular muscle enlargement, fat enlargement, and later on myofibroblast, causing irreversible scarring and causing orbital tissue expansion, resulting into proptosis, apical carotid, and optic nerve damage. It has two main stages. One is the stage 1 is active inflammatory stage, where the deposition of the ground substances and remodeling of orbital tissue. It lasts for up to 3 years. And the stage 2 is fibrotic stage, where there is loss of elasticity of extraocular muscle, resulting in restrictive myopathies. To evaluate the thyroid disease patients, history is important. history, how whether the autoimmune disorder has already been diagnosed, if so, when it was diagnosed, what are symptoms, how was it managed, especially a hyperthyroid for was treatment managed by medical treatment or radioactive iodine or by thyroidectomy, and how it is being currently managed, whether it is by medicines, beta blockers. Do the patient smoke? Tobacco increases the risk of thyroid disease by virtually 8 times. Careful review of the system will tell you whether you are dealing with a patient along with thyroiditis, whether it is hyperthyroidism or is hypothyroidism, or patient is still euthyroid. In the ophthalmic examination, of course, your basic visual acuity, your intraocular pressure, because once the orbit starts becoming crowded, the intraocular pressure increases. Having a good look at the Idinexa will give most of the clues about the thyroid eye disease. Hurtle to map to see whether glucose is setting, what is the amount of glucose. Ductions to see whether there is restrictive myopathy set up or not. Anterior segment assessment is important because keratopathy is, this is the symptom the patient mostly present with because of their proptosis and it lags. And this is what you need to treat most. You need to definitely look at the optic disc, whether they have clear margins or there is some disc edema. Color plates and pupil reaction will give you to know about the optic nerve functions. Yes, baseline visual fields and digital infrared thermal imaging can also give some clue about whether the thyroid eye disease is inactive phase or active phase. Nerve fiber layer analysis and will also give you a clue about the optic nerve functions. Typically, by the clinical examination only, you can most of the time identify whether we're dealing with thyroid eye disease. If still not, then the lab tests can give you more clues. Thyroid stimulating hormone, free T4, and thyroid stimulating hormone receptors antibodies, 2 antibodies, that is TSI and TBI1. Thyroid stimulating hormone antibodies, they are clinically sensitive and they are significantly associated with the features of thyroid eye disease. They are functional markers of thyroid eye disease and they correlate directly with the severity of the eye disease. Imaging, which allows us to assess the orbital tissue remodeling. CT scan, less expensive and faster to visualize bones and soft tissue changes. MRI gives better assessment as far as the disease activity is concerned. And ultrasound has less role to play. CT scan, you get the classical fusiform tendon sparing muscle enlargement. You can assess the apex, whether there is a crowding of apex, and the inferior rectus is the most common muscle to get involved. You can measure the proptosis from the CT scan by interdiaphragmatic line, and from the anterior corneal surface, it's more than 22. It is significant proptosis. You can assess the bones in the CT scan if you are planning for the orbital decompression. Some important clinical manifestations of thyroid eye disease are eyelid retraction, which is the most common signs of thyroid eye disease, proptosis, intraocular muscle, extraocular muscle, restrictions, pain, tearing and photophobia because of the proptosis and lid lag, blurred vision, optic nerve dysfunction. By these characteristic features, the diagnosis of thyroid eye disease is quite easy. But if there is inconclusive features and there is absence of objective evidence of thyroid dysfunction, then there are problems. Once you have diagnosed the thyroid eye disease, you see the clinical activity score of these patients. There are many tables available, but this is good one. On your initial examination, you can grade and in your follow-up examination also. If the clinical activity score is more than 4, then they definitely needs a targeted treatment. And then you grade your disease into mild, moderate, and severe. Mild, if there is less than 2 millimeter retraction, 3 millimeter, less than 3 millimeter exophthalmos, and only mild to moderate tissue movement, they can be controlled simply. But if it is moderate to severe with more than 2 millimeter retraction and more than 3 millimeter exophthalmos with constant diplopia, they need pulse therapy. And sight threatening, you have to identify where and treat them more energetically. If you properly treat them, patient appears better, so visual functions are better, ocular pain is better, and this is the flow diagram can follow just to an early and appropriate intervention to flatten the disease activity curve and shorten the curve for the best benefits. Thank you.
Thank you so much, sir. Our next speaker is Dr. Rachna Meel, who will be speaking on the surgical management of thyroid eye disease.
Yes, thank you. I'm here and I will just begin sharing my screen. Is the screen visible?
Yes, ma'am. You can start slideshow.
Okay, right. Yes, so I'll be talking about surgical management of thyroid eye disease. Now, a majority of thyroid eye disease can actually be managed conservatively. However, around 20% of patients will need some sort of a surgical management. And according to the study by Bartolena, the most common surgery that is required is for eyelid retraction, followed by strabismus surgery, and only around 7% of patients require orbital decompression. As a general guideline, surgery is not advised till a euthyroid state is achieved and a stable phase is maintained for at least 6 to 9 months. However, there are exceptions to this, and one might need to intervene during the active phase, essentially for dysthyroid optic neuropathy, which occurs in around 6% of patients, and especially in cases where it's a muscle predominant disease and the thickening of the muscles causes a compression of optic nerve at the apex. So if it is non-response to a high dose of IV immunosuppressants, then you would need to go on and do an orbital decompression. And this is mainly aimed at decompressing in the deep medial orbit in order to decompress the optic nerve. The other indication for an urgent intervention during active phase is a sight-threatening corneal exposure where lubrication, aggressive lubrication is not enough. So if there is a case like this of thyroid eye disease, you have to go in and do a tarsorrhaphy. But sometimes tarsorrhaphy may not be possible because of the proptosis-associated chemosis. And so one may have to go in for an orbital decompression even in these cases to achieve ocular surface stability. During the stable phase, the rule of thumb to do a surgical correction is to first do an orbital decompression, followed by strabismus surgery, and lastly, only the eyelid surgery is done. The orbital decompression basically aims to achieve an increase in the volume of the bony orbit, thus correcting the proptosis. And this surgery will not only affect the globe position, but it will also decrease the eyelid retraction and may induce a secondary squint. So therefore, it is done first in order of all the surgeries. The kind of decompression that you do will depend on the kind of disease that one has. So if you have a fat predominant disease like shown here in this image, where fat is in excess, you may just need a fat decompression. But if it is a muscle predominant disease, like in this case, then you will have to knock off one of the walls. One may do a medial wall decompression into the ethmoid sinuses, floor decompression into the maxillary sinus, or a lateral wall decompression into the temporal fossa. Each wall decompression will give around a 2 millimeter of correction. And all kinds of orbital decompressions can be complicated by orbital hemorrhage. The medial and floor decompression can result into squint and chronic sinusitis. Floor decompression can result into hypoglobus and hypoesthesia. So this is a video of lateral wall decompression. Sorry, I just... Yeah, so this is a lateral wall decompression where we conserve the margin, the bony rim. So after giving an incision at the lateral eyelid crease and extending onto the lateral canthus, the orbicularis oculi was dissected. I'm so sorry. Just go back to the previous slide. Yeah. So initially we did hook the LR muscle, and after that an incision was made, our lateral eyelid crease incision extended onto the lateral canthus. Orbicularis oculi muscle was bluntly dissected to reach the periosteum. A vertical incision was given into the periosteum, and the medial and the laterally it was dissected off the bone. Now laterally, at the lateral edge of the orbital rim is the temporalis muscle which is inserted. So we have to disinsert it and cauterize it. Medially, we know that the lateral palpebral ligament is attached to the lateral orbital rim, which has to be cut, and the periosteum, the periorbita, is then bluntly separated from the lateral orbital wall. So for this case, we had used a bone aspirator, which makes it easier to work on the bone. Here we are actually working on the lateral edge of the bony rim. This increases the access to the temporal fossa. So after shallowing this lateral edge of the lateral orbital rim, you can see that the temporal fossa is quite easily seen. And then we make a small bony window after inducing a small fracture, and then increase it by using this aspirator. You have to create a bone window large enough for the fat and the periorbita to prolapse. Posteriorly, you can go till the trigon, and you have to just be short of the inferior and superior orbital fissures. After incising the periorbita, the fat that prolapses out can be cut after cauterizing, but be careful, you do not have to pull the fat, which might induce a orbital hemorrhage. So after this, a Minivac suction drain is put into place. The periosteum is closed, followed by the closure of the incision. Post-operatively, the patient is kept on systemic corticosteroids for around 5 days. So this is the post-op of this patient. This is the pre-op proptosis, and there was almost a 4 to 5 millimeters of correction with the lateral wall decompression with fat excision. This is after we also corrected his eyelid position following the orbital decompression. As far as strabismus is concerned, the inferior rectus and the medial rectus muscles are most commonly involved, resulting into hypotropia or esotropia. Indications for strabismus surgery are mainly an intractable diplopia or abnormal head positioning, or one that is cosmetically unacceptable. What you do is recessions. Adjustable sutures are helpful, but one has to remember that large vertical muscle recessions can result into eyelid retractions, and also an infradection deficit in case of inferior rectus recession, which will result into a difficulty in using of bifocals. Eyelid retraction is the last surgery that is done after you've done orbital decompression and corrected the squint. This could be treated variably depending on the amount of retraction that one has. One could implant an eyelid weight, or one can weaken the eyelid retractor. So for the upper lid, it would be the levator palpebrae superioris or the Muller's muscle. A full thickness blepharotomy can be done, and a spacer may be required if there is severe eyelid retraction. Various materials have been used for same. Eyelid contouring can also be used when you just have to work for minimizing the temporal flare. Now, the eyelid retraction can be graded as mild, moderate, or severe. And usually for a mild retraction, a levator tenotomy works pretty well. Eyelid retraction, which is of moderate grade, can be treated with levator recession. And a severe eyelid retraction will usually require a spacer. This is a video. I will just try to run through it very quickly. It is a recession with the spacer. Just a minute. So after passing the marginal suture, this is done through the conjunctival route. we incise the conjunctiva at the superior tarsal border, and this is done all through the length of the lid. And after having done the same, the second layer is that of molars, which is, so now this is the molars. The molars muscle is identified and disinserted from its attachment on the tarsus. And once you have done that, you reach the levator. So this is the levator now, which is inserted on the anterior surface of the tarsus. And so now this is identified and again incised all through the length. So the steps are similar as we would do for a conjunctival root LPS resection. And once you've done that, this is the conjunctiva along with the LPS, and we pass cotton sutures through the LPS. And once we have done that, now it becomes more identifiable. Now you can separate the fibers of the orbicularis, and you can see the underlying orbital septum. And an incision is given through the septum to reach the, yeah, so that's the septum. And here we open the septum to release the fat, pre-epineuritic fat. You can see that's a pre-epineuritic fat. And once we have done that, we now give incisions in the horns to cut the horns on both the sides, lateral and medial. And then we harvest an MMG, which I've not shown here, but this is the MMG being sutured to the edge of the LPS here. And the other edge of this is sutured to the anterior surface of the tarsus. So these sutures are taken through the tarsus, and then they are taken out through the lid crease. 3 such sutures are passed. And you just stretch, yes, stretch the spaces so that it occupies the appropriate space. That's about it. And so to conclude, surgery in thyroid eye disease is required in only a small fraction of patients. Outcomes of rehabilitative surgery are dependent on the timing of surgery. So it's very essential to rightly time the surgery and the order of surgical correction. Patient counseling is extremely important. Expectations of the patient must be carefully addressed, because we know that predictability of many of these surgeries is not very good, and they can have associated complications. Thank you. Oh, sorry. And shows.
Yeah. Thank you, Dr. Rachna. This is Dr. Ravindra Mohan, if I can add a comment or two. Dr. Betaria, sir?
Yes, please. Go ahead.
Yes. Yeah, I think that was a nice presentation which gave an overview of surgical management in thyroid eye disease. The vast majority of patients needing decompression with the availability of methylprednisolone and other medications, the vast majority of patients who undergo decompression are actually male patients. Though thyroid eye disease is predominantly female in a ratio of 4:1 or 5:1, but the vast majority of patients undergoing decompression are basically males. They tend to be older males, smokers, or patients who have received preoperative radioactive iodine, actually. So these are the profile of patients whom you should be very careful, watch them closely, and they may need decompression. The other thing that needs to be mentioned is in some of the patients who are unable to tolerate steroids, they have osteoporosis, peptic ulcer disease, uncontrollable diabetes, one can actually progress and do the surgery early in the disease. It is well known that doing the surgery early will also reduce the compressive symptoms, because the big muscles and the tightness around the apex tend to work like a tourniquet and cause venous congestion and inflammation. In some selected patients, it can even be used early in the disease. Having said that, of course, there are many approaches to the orbit, and transconjunctival and skin approaches, and of course the neurosurgeons go through other approaches. But this is one area where oculoplastic surgeons have actually grabbed back an area which was out of their hands. 2 decades ago or 3 decades ago, when I was training under Professor Bitaria, we were not doing much of orbital decompression. The ENT surgeons were doing it through the Caldwell-Luck approach, which today doesn't look like a great approach. The approach we oculoplastic surgeons follow is far better functionally and cosmetically. Thank you. So Bataria sir, anything you would like to add?
I just want to ask Dr. Rachana, you have removed the thinner part of the greater wing of the sphenoid, and how much fat we have to really take out to produce the desirable result? Or you combine it with only lateral approach and you do not do I think lateral and inferior approaches are little easier, and medial approach to the orbits are difficult. So how much fat we really need to take out to reduce the proptosis, say by 4 millimeters? How much fat really needs to come out? Or do you assess the table somehow that you have removed enough of the fat? What is your assessment guideline?
So from whatever few surgeries that I've done, because we started this recently, and so there is no set amount that you want to remove, because we are not going into the orbit, digging out the fat, whatever prolapses out. I mean, so we don't set, say, supposing, okay, we need to remove this particular volume of fat. So when we are doing a lateral decompression and you're allowing, you've cut the periorbita, whatever fat actually prolapses out. So what we used to do is that after we've made the window and given the incision in the periorbita, we just press the globe and we see how much of the fat is prolapsing out on its own. And then only that much of fat is actually removed. So that we cannot really say whether we will be able to remove enough fat when you're combining it with a lateral decompression. So we know that around 2 millimeters will be corrected by the removing the wall itself. And you expect that around 2 millimeters more might get corrected if you remove, some amount of fat, but I cannot say how much. Because I have, in one of the cases where I had wanted to do a fat excision, after doing the incision, there was not much fat prolapse, not enough for me to get a good quantity to be removed. So this is something that you have to see on table. We cannot say beforehand whether enough will be removed, but that's about it, sir. So no guidelines as such, I think. But as we
add a point or two here, sir.
I understand, because I think this orbital decompression too much is talked about, but the results of orbital decompression are you produce many complications, as you have said that there may be muscle injury and all those problems. And suggest that we should do 2-wall orbital decompression. Single wall orbital decompression may not give us the adequate result, and therefore I think the inferior wall and lateral wall, these 2 walls we can easily do, and pressing the globe and whatever fat will be under pressure is likely to come out, as you are telling.
Yes, sir. So lateral wall decompression doesn't have many complications.
Yes.
I've done 4 or 5 patients recently, and there weren't many complications from this. Yes, if you would say how much proptosis was corrected with lateral wall decompression alone, 2 to 3 millimeters is all that we were able to achieve. So then we started combining the medial wall decompression along with the lateral wall decompression, which is called the balanced decompression. So here, by a transcarincular approach, we were very skeptical initially, because this is an area that we are really scared of, going posteriorly in the medial wall. But I realized that it is not that difficult. It is actually quite easy to do a medial wall decompression, because the wall is very thin. And once you are in the right area, and even a small amount of decompression in that area along with the lateral wall decompression works quite well for the patients. Although my experience is not much, I've just started doing it. So I cannot say for sure, but as a beginner till now, I've had a good experience with the few cases that I've done.
Okay. Can I add a few, please? Hello?
Yes, please. Go ahead.
Similarly, for eyelid retraction, the surgeries do not give that gratifying results. Early cases are in fact quite commonly in the OPD, we are giving triamcinolone at the superior margin of the tarsus, and it gives quite good results. Even fillers also makes patients happy.
In the acute phase, Dr. Mungre, you're giving triamcinolone in the active phase.
So, because that is one of the most common presentation of the patients, right? And patients are really bothered about this as far as their cosmetic appearance is concerned.
Botox can also be given in the active phase for taking care of the lid retraction. But again, the outcomes are very unpredictable actually.
Yeah, but they give them good relief. They give good acceptable cosmetic results. They are happy. That.
The surgical treatment of lid retraction, if you see my earlier articles way back in 1982, Mueller's muscle excision with partial levator tenotomy, little more generous on the temporal side to take care of the temporal flare, gave really good results. And I presented the work in the first Interspecialty Facial Surgery Congress in New York in 1983. So I have a large series of cases. So surgical treatment is also very useful, because if you have a scleral show in a young lady not married, then definitely you will like to do something like either you use a spacer as Rachna has shown us, or you do the Mueller's muscle excision with partial levator tenotomy. And the key to this operation is that you must bring the lid in position of ptosis.
Yes.
This is very important, that you must cover half of the pupillary area, or if there is a large scleral show, then you should completely cover the pupillary area on the table and assure the patient that lid will rise up slowly. In 2 weeks' time, the lid becomes normal and the retraction is gone. So, development of ptosis, making the lid droop on the table, is the key factor in management of surgical treatment of lid retraction.
Sir, what would be the ideal for the surgery for the lid retractions?
Ideal?
When their time?
You see, normally we see that the patient should be euthyroid. Patient should be corrected. Means he should be euthyroid. He should not be hyperthyroid or anything like that. And then if the lid retraction is too much, and especially if there is a scleral show, then certainly you would like to do the surgical treatment. Because now this medical therapy, etc. has come up, but that time only this Mueller's muscle excision with partial levator tenotomy and bringing the lid into position of ptosis. These were the important points which produce good results. Yes, Dr. Ravindra Mohan, you have anything to add? Dr. Ravindra Mohan?
Yes, sir. Just
anything
unmuted
to
myself.
add?
Yeah.
Anything
I
to
think I've been doing orbital decompressions for about 15 years now, and there is obviously a very steep learning curve.
Yes.
Today, my standard procedure is a balanced medial plus lateral, and a part of the floor which is far away from the infraorbital canal. Fat removal, we always measure the amount of fat we have removed by putting it in a syringe, removing the saline. And so initially one is very apprehensive because you keep thinking about fat removal, bleeding, intraoperative hemorrhage, orbital hemorrhage, loss of vision. So all that, as an orbital surgeon, we are always very concerned about that. But over the years, I think I'm able to remove consistently in most patients. Even I do simultaneous bilateral orbital decompression. At least 2, 3, or even in some cases more than 3 ml of fat. So there is obviously no algorithm which says, so all the fat you can safely remove without going close to any structures, without teasing it out, and without going into the posterior orbit, as Dr. Betaria rightly mentioned. Now, I do not do the isolated lateral wall decompression at all. But overall, balanced decompression is very, very safe, very predictable, enough for me as a surgeon to do bilateral simultaneous on an elective procedure. So that shows the kind of safety we can achieve by following some of the very basic principles, good hypotensive anesthesia and preoperative counseling. And even complications like strabismus, etc., are extremely rare, in fact. And only patients who have preoperative strabismus, that means they are having double vision and squint before surgery, only they may persist after surgery. New strabismus is very rare, though it is a scary part. So fat removal, one can push the margins a little bit with safely, I can say that. And so the surgery is gratifying results. It's a site-saving surgery. Oculoplastic surgeons are often blamed for not doing anything site-saving, but this is one area where we certainly save sight of many patients, and timely referral by our ophthalmologist colleagues and friends for a decompression is important, rather than persisting with oral steroids while the vision is going down, the fields are worsening. So I think these are the few messages that I think.
So I had a question.
Just for time, I think we may have to conclude.
Yeah, just one question.
Okay.
Yeah, so in cases where you have an optic nerve compression, do you do it yourself, or do you get an ENT surgeon to do it? Because in such cases, we usually send them to ENT surgeons because I think we don't reach that deep medial orbital wall.
Yeah. See, the number of patients, in the start of my career, the medial orbital decompression was done by my ENT colleague, and I used to do the floor. So we used to do a 3-wall, floor and lateral wall I used to do, and my ENT colleague used to do the medial wall. Then I left the organization which I worked for, and I was on my own. And the medial wall decompression looked like a reasonable, as long as we understand anatomy of the ethmoidal vessels and other things. And that has worked very well. See, the aim is not that you're not doing a canalicular decompression. You're not opening up the annulus of Zinn. All you're doing is removing a lot of the bulk from the orbit so that the compression of the nerve goes away. So it does equally well. I don't think you need to really take an ENT surgery if you are confident of your technique. So you're not, it's not an optic canal decompression. You're basically decompressing only the orbit. And so you could do it.
I think we can go ahead with the next speaker.
Thank you so much. Thank you.
Yeah, I think Dr. Lakshmi Mahesh, our past president of Oculoplastic Association of India, she'll be presenting her talk on periorbital swelling seen in women.
Good afternoon to every one of you. Thank you so much, DOS, for this opportunity. Can you see my slides?
Yes, ma'am.
The etiology of orbital disease, you know, is very many. We broadly divide it into these 7 basic headings: inflammatory, infectious, hemorrhagic, vascular, neoplastic, metastatic, congenital, and traumatic. Among the inflammatory diseases, thyroid eye disease, as just discussed by Rachna and Praveen, is the commonest. Even before this lockdown, it was said almost 45 million Indians suffer from thyroid eye disease. Sorry, the thyroid issues. And I think with this lockdown and increased stress levels, job loss, etc., and especially in Indians, it's very many among the young patients. So we are going to see more and more of this. Cellulitis infections, again, is the next category. Granulomatous and non-granulomatous lesions, we are definitely seeing, though they are less, but fungal infections is on the rise. Fungal orbital disease is on the rise with COVID. And inflammatory pseudotumors. The crux of this talk is not to use the term pseudotumor as much as possible. I feel every single lesion has some diagnosis or the other at some point of time. To begin with, it may all be negative. So cellulitis is pretty straightforward. It's almost secondary contiguous to the sinusitis, maxillary or ethmoid. sometimes even from the sphenoid, which is more lethal because it directly, the pus impinges on the nerve. We have to watch out for a subperiosteal abscess where we have to drain. And initially we were making so many cuts into the orbit to remove the pus. Nowadays, with the help of ENT surgeon, and to some extent, we are confident up to the second or third pass of functional endoscopic sinus surgery, we can open the natural passages of the sinuses and allow the pus to drain, so that in that way, the chances of recollection is also minimized. Mucocele is something like a volcano which is just waiting to be erupted. Many a time the patient wouldn't be aware of the problem itself unless there is a sudden collection of pus within the mucocele, and then there is periorbital swelling and puffiness. Of course, the acute lacrimal abscess also can cause a lot of puffiness all around the periorbital area, and this is acute on chronic. This was just a external hordeolum in a very severely diabetic patient. Fungal infections, as I mentioned, is on the rise now. This was a post-renal transplant patient. But of course, you know that it's locally morbid and it can be devastating. And many a times we fail to save the patient, almost 70% to 80% morbidity. But of course, with the newer antifungals and the initial liposomal amphotericin B, we are getting a little more encouraging results. Now, fungal again can be very tricky. This was a lesion way back in the apex, and she had a very quiet orbit except for a mild proptosis and periorbital swelling. And when I started decompressing this lesion with the lateral orbitotomy, it was so thick and densely fibrous, and surprisingly, it turned out to be fungus. So mucor is more devastating. The aspergillus can sometimes linger on. The initial infection may subside, but then you can also see fairly significant sinusitis in this patient. And then it can behave very, very strangely as whatever you call as an inflammation or a pseudotumor. So we have to really keep fungus at any point of time, be it acute or chronic. Lacrimal gland inflammation, the reasons are very many. Most of the times it is hormonal. It starts typically in the third decade, especially if the patient has recently become hypothyroid and if there is menstrual irregularities. Now we are seeing a good number in the second decade itself. And these people have other hormonal imbalance as well. They have thyroid issues. And of course, we should not miss the commoner one, which is sarcoid. But I think the lesion because of lacrimal inflammation, because of hormonal issues, are becoming much more. Even in thyroid eye disease, we see a significant lacrimal gland enlargement, both in men and in women. Now, reactive lymphoid, I don't know whether we are going to see them more after COVID, but I don't think so far in our groups we have discussed on that as much as we have discussed on fungus. This happens usually after a bad bout of viral flu, where the lacrimal gland and the muscle enlarges. We almost think it's a lymphoma, but when we go in, luckily it's not malignant. There can be unilateral severe enlargement of the muscle. There's usually cervical, preauricular, axillary node involvement. So this is another important sign to tell us that this is a RLH, reactive lymphoid hyperplasia. Sometimes when the acute symptoms have subsided and only the lacrimal inflammation lingers on, then you have to do very careful imaging, watch them serially and see here there is some amount of muscle thickening as well. So in this case, she did have history of a very severe viral infection, but after that, she had more features of thyroid eye disease. Of course, as I said, tuberculosis, we should not forget. Luckily, they say that because of COVID and all this mask wearing, hopefully the incidence of and the prevalence of TB should come down in our country. Let's hope for that. Then of course it can form a very cold abscess, and we may think it's a histiocytosis typical because it tends to erode the bone. Sometimes there may be sequestrum, there may be an intracranial or an intratemporal fossa spread, and we have to really watch out for that. Of course, when we investigate them systemically, you will have all these telltale signs, chest involvement, and here you see the intromedial erosion of the bone. Thyroid eye disease, as Praveen was mentioning, you can have fat enlargement or muscle enlargement, sometimes a combination of both. In our South population, we generally don't see it, but this was a lady from Calcutta. You can see she hardly had any proptosis, more of periorbital swelling, puffiness, and this erythema of the eyelids. Of course, she has the Coca-Cola sign of the on the scan, but not that much of fat infiltration. It was mainly periorbital edema, and this is very beautifully demonstrated on the scan as well. This patient was wrongly diagnosed as thyroid eye disease. She did have some amount of hypothyroidism, but you will see the COX-2 dilatation of the blood vessels. She had a mild inflammation going on in the posterior apex. She had something like a venous stasis retinopathy. These patients usually have superior ophthalmic vein congestion, some amount of VSR. Sometimes they frankly develop into a full-blown central retinal venous occlusion, and that is the time when they present with vision loss. So that's generally not what happens in thyroid. Thyroid, it's more of corneal changes, or it is the dysthyroid optic neuropathy. Then, of course, in the last few years, this entity we have to bear in mind. Instead of diagnosing a pseudotumor, please ask the pathologist to do the relevant markers and diagnose IgG4 disease. Of course, the Mikulicz is pretty rare, but again, it causes severe puffiness. Sometimes it comes and goes with every menstrual cycle, and lacrimal gland invasion is also seen. Vaginous is again an enigma. Initially, for many years, all your ANCA tests may be negative, and we would have ruled out. The rheumatologist will swear it's not a vaginous, but late sometime down the line, the patient can become positive, and they will definitely need immunosuppressives. Pseudotumor, that's what. The basic crux of this talk was not to use this word. Now, this lady had a dental problems of about 6 years before she presented to me. And she had a similar lesion. I'm sorry, I don't have that scan here. It all subsided with some steroids. And I think she was also put on immunosuppressants because she was the sister-in-law of a doctor who was pretty aggressive in getting her treated. And when she presented to me again after many years, she had a typical lesion, again involving the inferior rectus and in the infratemporal fossa, temporal area of the orbit. There was no contiguous sinusitis, but she did have a very bad dental inflammation. So what I can say is that, so we have to rule out all causes, just like uveitis. We should ask infectious etiology in every case which we see in addition to hormonal issues. This patient, of course, was put on some OCPs to regulate her periods, a lot of hormonal imbalance. She was not conceiving. Then they have that enigma and the psychological problems when they are put on so much of treatment. So all the stress itself can induce. She had a mild component of thyroid eye disease as well, but here you can see a lot of fat infiltration. The biopsy was done by another surgeon before the patient came here for a second opinion, and it just showed some chronic non-specific inflammation. So here you see there was very massive inflammation, again hormonal issues. There was also some history of trauma, she says, but this inflammation directly impinged on the nerve. When she presented, she came with loss of light perception. Despite IVMP and despite all course of oral steroids, she did not improve. So sometimes I feel these immunosuppressors, are they addictive? Because many a time patients think it's very fashionable to take them, and once they're put on them, it's very difficult to regulate, and so you have to bring down the doses and carefully work with your rheumatologist. It's not easy to take away these patients from these medications. So the first question is, does this patient really require an immunosuppressant? Because we should not just fill in the blanks at that particular time because they're suffering, because we know very well about all the long-term implications. In the last 3 decades, I have lost patients due to the side effects of immunosuppressants rather than the disease per se. Now, this alone is a pediatric patient, but I didn't have good slides of an adult. But what I mean to say is, as soon as we see this inflammation, let us not chop the case and try to establish a diagnosis unless there is a specific history of recent metastasis or recent malignancy where we are suspecting a metastasis, etc. Because aggressive use of COT3 with these inflammations can cause severe fibrosis. You see the lag ophthalmos in this child, exposure keratopathy. So what starts with an orbital inflammation, you don't want to land up with something more disastrous where you need your cornea colleagues also to manage the case. And this child is around 14 now. I'm still have done 2-3 surgeries to bring down the lag ophthalmos, but it's not really helping. So the conclusion and challenges are we have to properly evaluate. Let's observe the patient. Let's not jump in and start something. And even this intralesional steroids for this inflammation is a little scary because I recently saw a patient. She's absolutely fit otherwise, but she's diabetic already. She gave history of 3 shots of intralesional Tricot into her lacrimal gland sometime back. So ever since then, her blood sugars have not been behaving very well. HbA1c is also raised. So that's what I mean to say. So we think oral steroids are not safe. Let's give IV. IV actually among the 3, I would say is better. Intralesional and oral, we have to be pretty wary. Symptomatic treatment first, especially in the acute stages, antibiotics. A low dose of steroids if really required. I would prefer IV again if it is infection or inflammation. Good history and clinical evaluation is very important. Closely work with the rheumatologist. Imaging is a must in all cases. Many a time we need MRI. And if we work out with our scan centers, we can get MRI for very good subsidized rates. Patients can afford all kinds of fancy cell phones, but I'm sure they can afford a good MRI without contrast also if need be for a very nominal price. Biopsy excision only if required. And as I mentioned, work very closely with your physician or a rheumatologist and your oncologist in select cases. Managing the post-treatment sequels becomes the more of the nightmare rather than the disease per se. And let us not be aggressive. Let's not even think of exenteration, especially in this fungal infection. The initial debridement, repeated debridements, antifungal wash, lavage is the key. Patient dies because they get so upset with that radical surgery rather than the disease again. So I think exenteration, even like Dr. Goldberg's talk yesterday, we should see it less and less and do it even lesser. So the ultimate goal is to preserve function, vision, and cosmesis. And please, every pseudotumor must have a diagnosis. Pseudotumor word per se is a dustbin diagnosis. Sometimes even see a radiology, even a schwannoma and a meningioma, they would like to term it as a pseudotumor. So I think just as we have to think of radical surgeries much less, we have to think of the term called pseudotumor also much less or not at all. Thank you very much.
Thank you, Dr. Lakshmi.
Thank you so much.
Can we go for the next speaker? Akshay?
Yeah, our next 2 talks are linked and very interesting. Roshmi Gupta from Bangalore will be presenting orbital vascular malformations, followed by Dr. Gautam Lokdarshi, who will be talking on fluoroscopic guided sclerotherapy in similar lymphovenous malformations. So 2 interesting back-to-back talks.
Go ahead, please, Dr. Roshmi, go ahead.
Good afternoon. Okay, is my
Yes.
showing? Thank you.
Yes.
Good afternoon, everyone. Dr. Patharia and the panelists. Thank you to DOS for this opportunity to speak to you here today. So this talk is about an overview of the current concepts of orbital vascular anomalies, which have been undergoing change over the last several years. There have been multiple classifications used, starting with the Orbit Society classification, which divided it according to hemodynamics, no flow, low flow, and high flow. By location, it might be superficial, deep, or a combined lesion. And the modified IASBA classification talks about the initial tissue of the lesion. That is, for instance, the vasoproliferative lesion versus vascular malformations. And among the vascular malformations, it could be simple. Only a capillary malformation, lymphatic malformation, venous malformation, and so on. These, again, the arteriovenous malformations would be high flow, and the lymphatic and venous malformations would be low flow or no flow. We'll deal with them one by one. The vasoproliferative lesions, the commonest one we talk about is the infantile hemangioma, which starts off around the 3rd month of life and reaches its largest size by the 5th or 6th month and involutes from 1 year to 7 years. If it is causing danger to the vision, we would be treating with oral propranolol 0.5 to 2 milligram per kg per day and observe for adverse events. And this would give very gratifying results. Another option is use of intralesion steroids, which would be about 6 milligram per kg prednisolone equivalent. The known side effects include embolic phenomenon, including CRAO, atrophy of the tissues, and hypopigmentation. Other vasoproliferative lesions might be benign, such as pyogenic granuloma treated by excision or topical timolol maleate, or it might be malignant. And the hemorrhagic tissue inside the tumor shows that it is of vascular origin and treated by exenteration or radiation. Among the vascular malformations, the lymphatic malformations will usually present with sudden onset proptosis or enlargement during upper respiratory tract infections. The proptosis is because of hemorrhage into the lesion. These lesions on imaging do not enhance with contrast. They may be macrocystic or microcystic and may show fluid levels. And so these are no-flow lesions. Drainage will give very rapid relief, surgical drainage. Nowadays, it's more common to use aspiration and sclerosant injection into the lesion. And the sclerosant commonly used nowadays is the bleomycin. Next, we come to the venous malformations, among which the distensible ones were known as venous varix. They're the low-flow lesions. They'll distend with a dependent hand posture or Valsalva maneuver, and this change can also be seen on imaging. They mostly cause enophthalmos because of fat atrophy in the orbit, but they may also have pain on exercise. Occasionally, there may be sudden onset proptosis as pain because of thrombosis, in which an endovascular procedure will be needed. The non-distensible venous malformation, the commonest one would be the cavernous venous malformation, which used to be known as the cavernous hemangioma. So this is going to lead to slowly progressing proptosis, and we'll find a well-circumscribed lesion, mostly intraconal. It might be compressing the optic nerve, it might cause hypermetropia, or it might cause gaze-evoked amaurosis. And you can see that it will enhance with contrast in the late venous phase, and there will be a heterogeneous appearance internally. These are classically surgical lesions and can be removed very well with concealed incisions. Combined lesions are commonly venolymphatic malformations. So they have a combination of low or low flow characteristics, and they behave according to the dominant component, the lymphatic dominant or the venous dominant. They may be diffuse or circumscribed. This, for instance, might be confused with a cavernous venous malformation. However, it enhances very poorly with contrast and was treated with intralesional bleomycin, and it responded very well. So the other differentiating features of a venolymphatic malformation would be that it has a more elongated appearance and sometimes an irregular edge, and a thrombosis inside it would cause an area of calcification. A more diffuse venolymphatic malformation may need multiple procedures. For instance, this girl over the last 7 years. So initially we injected cyanacrylate glue and debulked the lesion. And she, over time, underwent 2 sets of bleomycin injection. And you can see the change in the orbital lesion from the initial to 2020. And this is on telemedicine, a selfie where even the medial canthal component of the malformation has receded. The arteriovenous malformations are high flow lesions. So I hope the pulsatile proptosis is visible here. That is a characteristic. There can also be pulsating vessels. There can be dilated episcleral vessels and secondary glaucoma. And arteriovenous malformation itself is going to be a pulsatile mass where there's a nidus of arterialized vessels fed by the ophthalmic artery. There can be the ophthalmic artery steal syndrome. And so the feeder vessels have to be coiled, and then the nidus has to be excised within 48 hours. Otherwise, the lesion keeps on recruiting more vessels. Arteriovenous fistulas, on the other hand, will cause flow voids within the cavernous sinus and an enlarged superior ophthalmic vein. So after coiling, this gives very gratifyingly good results. The syndromic lesions include the Fesis syndrome, Sturge-Weber, Osler-Weber-Rendu, and Wyburn-Mason. This Sturge-Weber patient, for instance, has capillary malformation, but unlike the infantile hemangioma, this is not going to involute and this is not going to blanch. So overall, the history is very important as to when exactly the patient started having the problem. A venolymphatic lesion, for instance, will grow rapidly because of the bleeding, whereas a cavernous venous malformation is going to grow slowly. We need to do a dynamic evaluation for each proptosis patient, look for pulsatility and distensibility. We need to select the imaging modality, contrast enhancement, and which phase it is at to interpret the imaging, and then select the management strategy accordingly. So we see there are varied treatments for varied lesions. One size is not going to fit all. And that is how we try to achieve a good result in orbital venous anomalies. Thank you.
Thank you, Roshmi, for your wonderful presentation. Really good slides. Excellent, excellent work.
Thank you, sir.
Akshay, can we go for the next speaker, please?
Yes, it is the fluoroscopic guided sclerotherapy for lymphovenous malformations. Dr. Gautam Lokdarshi. Dr. Gautam, can you unmute yourself? Yeah, thanks.
Yeah. Good morning, sir. Good morning, everyone. Just uploading, just sharing the slides.
You are from which place, Gautam? Can you just introduce yourself a little?
Sure, sir. Can you see the slides, please?
Not so far.
Okay. Actually, there is no option.
Yeah, now we can see your screen.
Okay, thank you. So, sir, actually, I have recently gone from left the government institution and now working as a exclusively as an oculoplastic and a squint surgeon, because I have trained in both of the specialty. So I work in Patna at various hospitals, and recently I have also attached to the Iris Super Specialty Eye Hospital and Orchid Eye Hospital, which is a multi-specialty hospital in Jharkhand, Ranchi. So coming to the topic, I think Dr. Rosmi has nicely summarized and discussed everything regarding the how to classify and differentiate different vascular malformations. So I will directly or mainly discuss about the procedure itself, the fluoroscopic guided sclerotherapy, how I perform in one of the patient, taking as an example. So this was the patient who presented to me. He was 8-year-old boy with sudden painful bulging of right eyeball since last 1 week. You can see the proptosis and conjunctival chemosis and the fullness in the lower eyelid. The history was since last 1 month he had a sudden swelling of the lower eyelid with fullness, and he was diagnosed as a case of orbital cellulitis by one of the ophthalmologists, and it was started on IV antibiotics and oral prednisolone with no improvement. There was no any significant history. In the systemic examination was within normal limits. There was no history of fever also or upper respiratory tract infection also. On examination, the child was not very comfortable because of a pain. So the vision was not reliable. The PR was also doubtful on the first examination, and the pain was significant and tenderness and discomfort was very significant. The left eye vision was 6/6. So rest of the examination was not possible, and we took him as an emergency case of proptosis. So on examination, we ruled out the arterial malformation or any pulsation. There was no, the proptosis was non-pulsatile. There was no change with crying or Valsalva. So, and the proptosis was non-axial. So it was the eyeball was up and out and unilateral. So all the extraocular movements in all gazes were restricted. The globe appeared frozen. There was a separate swelling in the inferonasal area, which was bluish in discoloration, and there was no purulent discharge. The nose, anti-rhinoscopy and roof of the mouth appeared normal. On palpation, there was no pulsation or no regional lymph node enlargement, no brew. Hertel was not possible in this case. The conjunctiva was chemosed, as seen in the photographs. Dilated lymphatics could not be seen as the child was not sitting on the straight line properly. So, but there was no not visible on examination at that time. And the rest of the ocular examination was normal except for the pupil. The RAPD was there, but there was no anisocoria. The left eye fundus was posterior pole was also appeared normal. So we made a working diagnosis of acute painful abaxial unilateral, which was right proptosis in pediatric patient, which was likely no or low flow vascular etiology. Our differential diagnosis in this case was lymphatic or lymphovenous malformation with chocolate cyst or post-traumatic or some causes of retrobulbar hemorrhage or subperiosteal hematoma, AV fistula, post-traumatic, capillary hemangioma, orbital or post septal, but there was no history of trauma in this case. So we ruled out everyone. The orbital cellulitis, there was no local rise of temperature or no history of fever. Leukemia, the fundus was normal in the fellow eye. And rhabdomyosarcoma, because of the direction of the proptosis. We urgently advised NCCT in our emergency department, and ultrasound orbit was advised. The rest of the blood profile was routine blood profile was normal. On NCCT, there was a tinting of the globe. You can see
Go ahead.
there was about 100-degree tinting of the globe was there, which means there was a compartment syndrome and a compressive optic neuropathy was a possibility in this case. And there was a diffuse extracorneal and intracorneal lesion with multiple cystic areas which appeared in the different scans of the film. And though the fluid MRI was not done, but this was the area which was the bluish separate cystic lesion at the inferior nasal, and it we thought that this could be the fluid level here, cystic separate cyst or chocolate cyst. We did the ultrasound and measured the dimensions, and it appeared a multi-loculated cyst which was more on the medial side of the compartment of the orbit, and it is the inferior along the floor of the orbit, from anterior to posterior. Is all the cyst is there, and which appear multi-loculated. So we made a diagnosis of right deep orbital lymphangioma with chocolate cyst with orbital compartment syndrome. So treatment was urgent. The child was admitted under emergency and was planned for the right orbital cyst aspiration with sclerotherapy under general anesthesia, under ultrasound and fluoroscopy guidance, and was counseled about the multiple sitting if required. So this is the drug we used here, the bleomycin, which come by the name of ceblocin, which come in the different vial. We use 15 unit vial, and in the first sitting was planned, and this bleomycin is prepared with the normal saline. We mix it with the lignocaine and iohexol contrast in this ratio, 3:1:1 or 3:5:1:1. So this is the intra procedural this CT. In the DSA room it was performed, and is a long needle about 21 to 22 to 23 gauge is available, and some needles are MRI compatible also. So but we have experience with the only CT guided, not MRI guided fluoroscopy. So we aspirate with this needle. We place the needle under ultrasound, ultrasonography, and is the direction of the needle is going in the cystic cavity. So after the aspiration of this photograph is after the aspiration of the blood, dark blood from the chocolate cyst. This is the how we aspirated, and these are the syringes. 1 ml syringe is more comfortable, and once you put the 1 ml syringe inside the cavity, the piston itself goes behind. But 2 ml syringe is less. You have to put some pressure to aspirate, so it is not that comfortable. So slow aspiration is more advised than using 2 ml or 5 ml syringe. So 1 ml syringe is the better choice. Here we aspirated total volume 7 ml. So you put the needle there, leave the needle there, and change the syringe one by one. So this is the unedited video. You can see here the person. This is the radiologist, my friend. He is loading the local anesthetic in one of the syringe, about 1 ml. 1 ml iohexol was already taken, and now what he is doing, he is mixing with the this 4.5 ml of the bleomycin. So 15 unit vial, 4.5 ml of NS. The bleomycin comes as a dry powder. We mixed 4.5 ml of NS in it, then 1 ml of local anesthesia, that is lignocaine 2%, and 1 ml of iohexol. So total 6.5 ml in a concentration of 2.3 unit per ml, about 2 unit per ml. So we discard now. He is discarding. So he is discarding 2.5 ml out of 6.5 ml. So the remaining is 4 ml, and this gives a 9.2 unit or about 9 unit dose of bleomycin. So this is what he is telling me. So he is now, so after aspiration, we are under ultrasound guidance again to recheck the position of the needle. So this is the real-time ultrasonography they are doing, and the Doppler is also there. So this is the cavity. So this is time taking. So once you confirm the position of the needle in the cavity, then you inject it and take a scan, because you have injected the contrast. So at the same time you take the scan. So post injection we gave prednisolone, because the main side effect of bleomycin is short time inflammation after injection. So you can add this one and some antibiotic and pain and analgesics also. So this is after injection. Still the bulging of eyeball, proptosis is there, chemosis is there, redness and fullness is there, and some fluid discoloration is seen here also. There is shifting of the blood. So on examination, still the PR was doubtful, and there was RAPT was still there, but the sign symptoms has improved. Now we were able to measure through Hertel, so we documented it as 16 and 12 for the follow-up purpose, but these were abnormal. The color contrast and visual field were abnormal for the, and the child was also not very allowing for this eye, but the left eye was normal. So here the PLPR was doubtful. So we have a doubt whether it is sclerotherapy induced vascular occlusion or due to compressive optic neuropathy. Because the fundus was normal, so possibility of the first one was less than the second one. So to recheck this, we retrospectively reviewed the fluoroscopic record. So this is how the contrast is injected, and there is no contrast is going in the blood vessels or vascular artery. So this confirms that the contrast is inside the cystic cavity. So it means the possibility of the one is remote, and this one is the more possible answer to the loss of vision. The second sitting was planned within a week, and we injected, we again aspirated 3 ml of blood, because there was still blood was on the ultrasound. So ultrasound guided this injection was performed. Next day follow-up was this. The proptosis was not much changed, but the sign symptom has increased, and the possibility of the repeat procedure and surgery was explained. On subsequent follow-up at 1 month, it is resolved. The proptosis has improved, and this chemosis and movements in all cases has improved, and the fundus was normal, and so the VR was also suppressed in the right eye. So the patient took another opinion at some different hospitals. They advised MRI. MRI, you can see the 2 pockets of these enhanced contrast enhancing these lesions are there. So these are very small, and they are not causing much proptosis or deformity. The eye has already lost the vision, and it is very close to the right optic nerve, though it does not make sense because already it has become a PL negative. But Hertel has improved to 14 to 12 mm, and there is some dystopia of the globe, but there was no diplopia because right eye has no vision. So these things, so we advise.
Can you sum up, Gautam? Can you sum up now? Please sum up.
Yes, sir. So there are different options, and one option is microcystic. One has to differentiate between macrocystic and microcystic. In microcystic variety, these procedures are not much successful. Some has advised Avastin also, some has tried sildenafil also. We had a few other patients in which they are not, we have excluded for the from the sclerotherapy group because they have microcystic lesion and there are certain limitations. So I can conclude it with this statement that sclerotherapy can be considered as a feasible and urgent therapeutic option in selected cases of orbital lymphangioma. Thank you.
Thank you very much. Can we go for the next speaker?
Yeah, I think it's Dr. Manish Kumar who's speaking on orbital fat prolapse.
Yeah.
Just a moment.
I will request all the speakers to
Yes,
keep
sir.
to time, please.
Yeah.
Yes,
I
Dr.
also-
Ravindra Mohan, you
Yes,
have any
sir.
comment?
A couple of things. I think we did inherit a very huge delay, and we've possibly added to that also, unfortunately.
Yeah.
So I wanted to find out from Dr. Fairuz, I think who's our moderator, whether we have any session after this where the people are going to come in and the whole thing is going to do. Because I think all the invited speakers must get an opportunity to speak. That's
Yes,
very
yes.
important.
Correct.
And at the same time, we shouldn't add to the delay. So I think we try and...
I think let us request the speakers to stick to time and we'll not have any questions. Let us listen to them and stick to time, please. Thank you.
Gautam, can you stop sharing your screen?
Dr. Mohan, I am really not sure about which talk is coming up, but I'm definitely sure that, since the halls are quite active, we are like too much past the time. So, yeah. Do we have anyone from the technical team in the Zoom platform here?
Dr. Gautam, can you stop sharing your screen, please?
So I have already stopped. Sir.
No, we are seeing your desktop.
Do we have the DOS backend co-host? Are you there? Harsh, are you there?
Excuse me, ma'am, there is a session from 3 to 4:30 in the same hall, like rival system and socket.
Acha, theek hai.
So,
Okay, fine.
3 to 4:30.
How many speakers are remaining in our session?
So we have, I'll tell you that.
Just about halfway, I think.
Yeah.
Yeah, Manish is 6th out of 11. So just past the halfway. I mean, at the halfway, right? So,
okay, then.
And I'm the last speaker, so I'm determined to speak and go. So,
so we have
audience
6
or
more
no
to
audience.
go. 6 more to go.
6 more to go.
Okay, let us stick to time.
6 into 7 should be 42. So that should be just about it.
Okay, so just let us stick to time now. That is very important.
Okay, good afternoon to all of you. Are my slides visible?
And touch upon the relevant points. Don't present like junior resident. We are all senior people here. Just stick to time. Give us some positive points and emphasize 2-3 important points and finish off your presentation. That's the way to go.
It won't take more than 4 minutes, sir.
Okay.
Am I
good.
audible?
Yes.
Okay, I'll be talking about orbital fat prolapse. Orbital fat prolapse is an anterior herniation of orbital fat through a defect in the Tenon's capsule. Now, such an innocuous looking condition like this, why should this merit any kind of discussion at all? The question is because this lesion is many times confused with dermolipoma, the lacrimal gland lesion, cyst, or a lymphoma. Indeed, in a series of 1,200 consecutive orbital lesions, 2% cases of orbital fat prolapse were there, which were referred, thinking them to be a neoplastic lesion. Now, orbital fat prolapse basically consists of the fat in the intraconal area coming forward through a defect in the Tenon's capsule. And the most common site of orbital fat prolapse is subconjunctival area in the supratemporal fornix. The fat comes here. Mostly the reason it comes spontaneously with aging. The risk factors include male gender, obesity, previous surgery, trauma, or floppy eyelid syndrome. The clinical presentation consists mainly of obese elderly males having supratemporal conjunctival fornix is the location wherein fat prolapse can be seen. Usually it is bilateral, although it may be asymmetrical on 2 sides. It consists of a yellowish lesion, which is the most important thing is that this is a yellow lesion with overlying normal conjunctiva, and it is freely mobile and displaceable condition. Now, how do we differentiate it with dermolipoma? Dermolipoma is seen mainly in childhood. It is a unilateral condition. The surface, if we examine in the case of dermolipoma, it may contain hair. The overlying conjunctiva is adherent to the lesion. The elevation is much less. It is much less yellow in color. It is not compressible, and there may be association with golden heart syndrome. Herein you can see the dermolipoma over here, and herein you can see hair on the surface and a limbal dermoid, which is part of golden heart syndrome. Now, versus dacroadenitis, lacrimal gland swelling can be inflammatory, or it can be a prolapse of lacrimal gland, in which case it will be a whitish sort of a thing. Whereas inflammatory swelling will be pinkish in color and painful. If we do imaging, MRI will show enlarged lacrimal glands. Cyst is very well apparent here. Transillumination will be positive, and on CT scan, we'll be able to make out the cyst quite clearly. Lymphoma consists of subconjunctival deposition of lymphocytic cells. This is a diffuse lymphoma. It is basically firm in nature, and it is of pinkish color. Orbital fat prolapse is a clinical diagnosis. In majority of cases, imaging is not required. But should we do the imaging, we'll be able to find out that the radiolucency is equivalent to the radiolucency of the fat. Herein we can see a clear-cut area which denotes fat. Now, if we were to do an MRI, we'll be able to appreciate that the intraconal fat, this is in continuation with the fat in the subconjunctival area over here. Management, majority of cases, we don't have to do anything. We just observe the lesion. We have to reassure the patient that nothing is going to happen to the vision as such, and this is not a growth. Surgical excision can be planned for lesions which are large, causing a cosmetic deformity, or there is irritation in the eye because of inadequate tear film or improper tear film. And in other cases, such as cataract surgery, if you think that the lesion is going to interfere with the surgery, then partial excision can be planned. Now, this is a small video of the surgery being done. The important thing to realize in this is that we have to remove the anterior part of the lesion. We can't remove the lesion totally. We do not have to be too aggressive, and hemostasis is to be maintained. This fat is in continuation with the retrobulbar fat or the intraconal fat. So any bleeding in this area directly goes to the retrobulbar area, with its attending risks of retrobulbar hemorrhage causing pressure on the optic nerve. So here you can see we are isolating the anterior part of the orbital fat. The idea is to clamp, cauterize before leaving it. So cautery is being done before leaving the stump of fat. We don't have to be over aggressive in doing this excision. The results are quite good. The recurrence rates are less than 10%. At the end, we just have to oppose the conjunctiva, and that is it. So this completes the surgery. Caution needs to be advised as far as diagnosis is concerned. Diagnosis needs to be revisited if the lesion is unilateral, it is occurring at a young age, and it is associated with inflammatory signs. Then it is most likely not an orbital fat, but something else. Surgery is to be done only if it is necessary, and the most important thing is to maintain hemostasis and avoid excessive dissection. Thank you.
Thank you, Dr. Manish. I think that was a very nice talk, giving the differential diagnosis and not to assume it is orbital fat and to how to do it. I think that was a very nice talk, and you respected the time. In fact, you saved some time for us. Thank you very much. Our next talk is by Dr. Chandana Chakrabarti, and I invite her to start her talk. Dr. Chandra?
Yes, I can.
Yes.
Previous persons sharing the screen. Ask
Yeah.
Dr. Manish to talk.
Yeah, just a minute, please.
Yeah. Sure.
Is it okay?
Yes, we are able to see well. Please start.
Good afternoon, Dr. Betheria and all the panelists. So I'm going to speak on diagnostic challenges in orbital diseases. I have 3 cases. I'll quickly go through the cases. Case 1, this was a 14-year-old boy who presented to us with the chief complaint of bulging of the eyes with the lower eyelid. No history of fever or weight loss was there. The visual acuity was almost to the normal limit, and there was the conjunctival chemosis, diffuse, firm, non-tender swelling over the right orbital region and infratemporal region also. Extraocular muscle was, movement was restricted. Fundus examination, disc edema, choroidal folds were there. I don't have the fundus picture. Right submandibular and preauricular lymph node were enlarged. So investigations, we started with CBC, which was within normal limit. The next one, we went for the CT scan. If you look at the CT scan, the CT picture shows that there is an isodense orbital mass, both in the maxilla and the right orbit. And there is an, which is eroding the posterolateral wall of the maxilla. So initially we did an CT guided FNAC, which said it could be a case of non-Hodgkin lymphoma. So to be more definitive, we did an incisional biopsy from the lower lid area. And that time it came as it is a blast cell. So we did bone marrow biopsy also that time. And that also confirmed the diagnosis. Immunohistochemistry also was suggestive of granulocytic sarcoma. So after 1 month, when we did the repeat CBC, the abnormal blood cells were found. So that time we referred the patient to oncology. And when we went to the literature, the de novo granulocytic sarcoma is a condition where actually the lesion, the bony lesion and the mass can appear before the proptosis can have well ahead before the CBC to be suggestive of acute myeloid leukemia. So it can take almost 10.5 months, 10.5 years to appear this complete blood picture. Case 2, it was a 9-year-old female who presented with gradually increasing swelling of the blepharoptosis of the left orbit. And there was a history of trauma 2 months back. There was no history of fever or any other systemic diseases. Family history was within normal limit. Treatment history, after the fall of the patient, immediately after the trauma, they consulted a doctor, and she was asked for an CT scan, which was with the normative head. It was with the normal limit, and the minimum treatment was given that time just for the trauma. Then after 1 month, the picture was like this, as you can see, blepharoptosis. There's a soft, fluctuant, non-tender swelling over the left upper lid and the frontotemporal area. Palpable preauricular and submandibular lymph glands were there. So what investigations we did? Complete hemogram, total blood count, ESR was high, 58 millimeter. MANTU test duration was high. Chest X-ray, multiple calcific lesions in the lower lobes was found. Sputum was negative. FNAB from the left preauricular lymph node showed reactive hyperplasia. We did a diagnostic aspiration, and 5 ml pus was taken at that time. So we are tempted to do an incisional drainage of the pus, and we sent it for the smear culture and AFB, but everything was negative except the some staphylococcus was seen. And we started the treatment with ceftriaxone IV. But after 5 days, the pus reappeared and the fullness came like before only it became. So again, we repeated that CT scan. We thought that previous CT may not pick up the lesion. So this time the CT, as you can see, there was an osteosclerotic lesion, erosion of the frontal and the zygomatic bone. So depending on the clinical examination, the positive MAN2, positive ESR high, and the sclerotic lesion of the orbital bone. This time we did the diagnosis of tuberculous osteomyelitis of the left orbit along with cold abscess of the temporal area, and treated the patient with an ATT CAT1 4-drug regimen. For 1.5 years we continued. Now it has started improving the lesion, and follow up at 3 months. As you can see, the patient has improved, but there was a sinus was formed. So what we did a sinus surgery, fistulectomy with removal of the sinus tract, and sent it again for the HP and the gram stain and tuberculous bacilli. Everything was negative. Now the patient is doing well after the sinus surgery. So to conclude, the history of trauma may be just a coincidence in case of, but it has been seen that trauma has initiated an bony tuberculous lesion. This has also been reported in the literature. Repeat CT one should do, it can help. High index of suspicion should be kept for early diagnosis and timely treatment of the orbital tuberculosis, as it is especially in an endemic country like India. This is another case of a 6-year-old boy who came with fever, pain, bulging for the right eye for 4 days with a dystopia downwards, restricted extraocular motility. People was normal. So we thought it is a case of a clear-cut case of orbital cellulitis. We started the patient treating with treatment of broad spectrum antibiotic and anti-inflammatory, and the patient responded. At 3-week follow-up, the picture was like this. It was partially resolved, and there is a cystic lesion you can see in CT scan. And this was the picture in MRI. And the radiologist, they said that it is rhabdomyosarcoma. The MRI picture was suggestive of rhabdomyosarcoma, and it could be a rare case of cystic rhabdomyosarcoma. So we thought we'll do an FNAC. And during FNAC, CT-guided FNAC, 5 ml pus came out. So it was a case of abscess, in the orbital abscess. We sent it again for the Ziehl-Neelsen, but no acid-fast bacilli was seen. It was just an suppurative inflammation. So again, we started with broad spectrum antibiotic for 1 week. And now after the drainage of the pus, the patient improved. This is the picture at 1 month follow-up. The patient has improved totally. So to conclude, radiological comments may be sometimes misleading also. We should be very careful about this supportive investigation results. And we have to be very careful in doing the history and the ancillary investigations. Sometimes you may have to repeat this peripheral blood culture, you may have to repeat the CT scan or the MRI, and multidisciplinary approach involving all other facilities like neuro, like ENT, all these are necessary to a hematologist. These are helpful. Thank you, sir.
Yeah. Thank you, Dr. Chandana, for a very nice presentation. I think it's a real Shame that we are unable to discuss such wonderful cases because of paucity of time. Now I call upon Dr. Fairuz to deliver her talk, and we go ahead with the session.
Hi, thank you, sir, and hi to everyone. I'm going to share my screen. Ma'am, can you please stop share screening? All right. And I'm going to go really quick. Yeah. So good afternoon, everyone, and thanks to DOS for this kind invitation and opportunity. And it's an honor to be able to present before Dr. Bateria, who's like our grand mentor, who's sitting here in orbit. And I was asked to talk about management of difficult orbital cases, share few cases, but I have put it as interesting cases over here. I'm Fairuz and I'm from Bangalore. So this is an interesting case that I would like to share with everyone here. It's a 12-year-old boy who came with proptosis of the left eye, and the complaint is proptosis for the past 2 months, which has been rapidly progressing. Way back in November 2015, his Hertel's exophthalmometry showed a difference of 5 millimeters between both the eyes, although the extraocular motility was free and full. On fundus evaluation, in fact, his vision has reduced recently, and on fundus evaluation, the vision in the left eye was 6/60 with grade 2 RAPD, and this is what the fundus looked like with, severe disc edema, and they were in fact choroidal folds, which was visible, which was correlating to the reduction in the visual acuity. And what would one do after this? So an imaging was done, and this is what we found in the CT scan. So there is a large lesion occupying the intraconal compartment. And why intraconal? As you can see here, the medial rectus is really pushed medially, and the optic nerve is pushed laterally, almost kind of abutting the lateral wall over here. So this lesion had an heterogeneous appearance. As you can see here, there is hyperintense area, there is hypodense area, and isodense area. And of course, there was scleral indentation as well. So considering the age, the rapid progression with a large orbital lesion sitting in a 12-year-old, the differential diagnosis was, malignant orbital tumor, possibly a rhabdomyosarcoma. Even I was thinking of a mesenchymal sarcoma, and in fact, solitary fibrous tumor, although it's very, very rare, was also considered. So as we all know that rhabdomyosarcoma in an orbitotomy, probably we may not be able to completely excise the tumor because it's closely associated with the muscle. So it's kind of a maximum debulking. And that's exactly what I went ahead with, thinking that it could be a rhabdomyosarcoma. Now, on histopathology, as you can see here, it was a spindle cell tumor. And more to my surprise, although, I expedited the histopathology report with the frozen section, which was sent so that I get the report, by the evening. Another thing which was noticed was Verroque bodies. So this, with the immunohistochemistry, was suggestive of a schwannoma, a neurolemoma in a 12-year-old, which was in the intraconal compartment. Now, I was in a fix because, we all know that schwannoma, if it is incompletely excised, it is going to recur back. And well, there is nothing more than a surgical excision, which will actually give a relief and complete, treatment to this patient. So what I did was I did discuss this case with colleagues and seniors. I plan to observe at this point of time, thinking that I will go ahead and excise it if at all there is a recurrence. And without surprise, within 2 months, he came with a recurrence. And this is how the proptos. So there was, again, a rapid progression in the lesion within 2 months. And I did not have any other way but to go and do a repeat excision. And at this point of time, a complete excision was, made sure, and the tumor was excised. Now, the child was doing fine, but he landed up with an exotropia. There was no neuroparalysis. There was no third nerve palsy was ruled out. Muscle injury was ruled out. As you can see here, abduction is absolutely normal, but he had an hypertropia and left exotropia. So I had to actually bring in my squint surgeon, and this is what we found in the imaging over here. As you can see here, the muscle, the medial rectus muscle, is completely folded. And why did this happen? Because as the tumor enlarged, it was stretching the medial rectus muscle, which I did notice intraoperatively that it was a very lax medial rectus muscle. And that was the reason for this exotropia. So now what we did was, I had a wonderful colleague who's a squint surgeon, an excellent surgeon. She went ahead with the squint surgery. And this was, last year in April 2019. And then this is how, he was turned into orthotropia. So this took from 2015 to 2019 in actually managing an orbital case by various specialty, and it was absolutely heartening and happy to have this result at the end of it. Yet another case, a 10-year-old girl who came with proptosis diplopia with rapid progression. In fact, I was asking her whether you had any onset of pain, inflammation, fever. Absolutely not. And I was praying deep inside, it should be an infection or an inflammation, although there was a remote possibility of a bad malignancy. We went ahead with a CT scan. Now, CT scan, as you can see here, there is a lesion in the lateral orbit, again in heterogeneous mass. Well, this was kind of, looking like a cystic space, and I was kind of praying, let it be an orbital abscess. It's good for the child. But then, as you can see here, there is an intracranial extension and some amount of erosion of the lateral wall over here. You can see in the coronal section over here, there is intracranial extension. Well, it could be again an orbital abscess or a frontal abscess or a tuberculous osteomyelitis and an abscess. So crossing my finger, we went ahead doing an incision biopsy. Although the neoplastic tried radiate lesion differential diagnosis are neuroblastoma, PNET, sphenoid meningioma, plasmacytoma, leukemia or lymphoma, and all the investigations were done. Leukemia lymphoma was ruled out. Now, it came out as an Ewing sarcoma PNET OS, which was a rapid, almost simulating an inflammation and infection in this child. And even a genetic marker was done in her. The FLI1 gene was negative, which also actually helps to prognosticate. So this is the kind of evaluation that we done in this particular child. And the bone marrow biopsy was normal, luckily, and the PET scan was also normal. So she went ahead with, systemic chemotherapy and radiotherapy. And for the past 2 years, she has been stable. 18-year-old student, proptosis diplopia, no history of trauma. She was advised a craniotomy and excision biopsy in her right eye proptosis by a neurosurgeon, and she came for a second opinion. Why a neurosurgeon? Because she again, so these are like the orbital bone erosive orbital lesions, which I really wanted to highlight here how different it can be. There is a dural exposure over here, but when anything that is in the orbit, I think it's in the realm of an oculoplastic surgeon, an orbital surgeon, and not the realm of a neurosurgeon. And she underwent excision. This was a lesion. This was some amount of bone which was excised in order to go for an histopathological diagnosis. And it was an intraosseous extragnathic myxoma. We did systemically evaluate her for other sites of myxoma, and she was within normal limits. And this was a benign lesion which presented with an orbital, bone erosion. An old lady presenting with a triradiate lesion like this. Well, of course, the differential diagnoses are again many, and this came out to be an orbital sphenoid wing meningioma of the left side. Now, why I wanted to present this case, this was a case which I saw during the COVID times. And why is it important was like we went ahead with an hypofractionated radiosurgery, which was done with 25 gray in 5 fraction. This was like a frameless hypofractionated image guided volumetric modulated arc, which was used for her for 5 days, and she was treated for this meningioma. So orbital disease, to conclude the management pearls, it's very important to differentiate between infection, inflammation, neoplasm. There can be an overlap. It's very, very important. And if you are sure about these 3 components, it's very easy to manage orbital disease. Now, about the management, few pearls here. There are orbital lesions which you can go ahead and treat completely non-surgically, as Dr. Roshmi has already presented, various other speakers have mentioned. This is a, lymphatic malformation which was treated just with bleomycin. Now, whenever there is an extensive lesion, you don't have to go and, be over confident trying to remove the entire lesion, and in simple incision biopsy is good enough. In diffuse extensive lesion to prove the diagnosis and management further, well, if it is a very well defined lesion, excision biopsy is definitely a possibility. But there are situations of orbital lesions when you really don't have to enter the orbit, like a child presenting with a proptosis, ecchymosis. The child is very pale, a peripheral blood smear is just enough to get the diagnosis. Now, this is a cavernous hemangioma right at the apex. You don't have to go inside and cause an optic nerve injury. Just that you have to refer the patient to a radiotherapist for a gamma knife radiosurgery. Now, stenting and coil embolization is the only thing that you need to do in vascular lesion. You don't have to enter the orbit. A 65-year-old lady, diplopia, discomfort in the right eye. This is the lesion.
I think we just have about 25 minutes, and really, I think
done, sir. And the diagnosis was only with the conjunctival lesion over here. So this actually correlated to the orbital lesion, which was a sarcoid. And well, this was a sarcoidosis of the primary orbit where orbital biopsy was not even required. So timely referral is very, very important in orbital disease. And it is a Pandora's box. So you have to be careful about, starting from a clinical diagnosis, diagnostics, biopsy, genetic markers, IHC, etc. Thank you very, very much for your patient listening.
Yeah. Thank you, Dr. Fairuz. I think we call upon the next speaker, Dr. Seema Kashyap, to share her valuable experience. And
Fairuz, I must tell you, it was excellent presentation, and we really look forward to you from Bangalore. Both of you, Roshmi and Fairuz, have to be observed carefully. Very nice.
Thank you very much, sir. It's a big thing for me to hear that from you. Thank you so much.
Dr. Seema Kashyap there? Or? No? So if Dr. Seema Kashyap is not there, then we go on to Dr. Renu Sinha.
I'm around. I'll just try and share my screen.
Sure.
Is Seema Kashyap from RP Center?
Yes, Dr. Area.
I'm just trying to share.
Ma'am, good afternoon.
Good afternoon.
Good afternoon.
Ma'am, there is a huge echo coming from your voice.
Okay.
I remember we had two Seemas, Seema Kashyap and other also Seema.
Seema Sen, Dr. Seema Sen.
Yes. Yeah. Both from pathology section.
Ma'am, are you able to share?
Yeah. I'm so sorry. There's some problem with my.
I think, can we have another presentation?
Yeah, sure. I'll just try and you can have the other presentation, next presentation.
Yeah. Dr. Renu Sinha?
Yes.
Is Dr. Renu there?
Yeah.
No, I don't see her name.
So Dr. Renu doesn't seem to be here.
Doesn't seem to be there. So then that just leaves me.
Yes, yes. So let me have the pleasure to invite you, Dr. Ravindra Mohan, who has vast experience in oculoplasty, and he has been excellent orbital surgeon. Where we have grown up seeing him and his surgeries and surgical videos in various conferences and forums. So we are looking forward to your presentation, sir. Over to you.
Thank you. While my screen gets shared. Yeah. Screen share. Desktop. Pushing.
So everything is all right?
Absolutely, absolutely.
Yeah.
So, right. Okay. Thank you. I think it's a great. Yeah.
Now, share screen. Now choose this.
Yeah.
Share. Yeah. Okay. Share. It is that.
Right. Thank you very much. I think that was my technical consultant, who happens to be my youngest son, helping with the screen share. I think it's a great privilege and honor to be presenting in front of my teacher, Professor Bitharia, under whom we learned how to crawl, walk, stand, run in terms of orbital and oculoplastic surgeries. So I'm going to be speaking today about minimally invasive orbital surgery and how today we need to like the rest of medicine itself, like the rest of surgery itself, try and do things in a minimally invasive manner to reduce complications, increase safety, increase patient comfort, and try and reduce the cost of healthcare as it is. Now, this is the case that I would like to highlight, and then we'll quickly run over a few cases. This is a child who underwent ultrasound as a fetus and was picked to have a large intraorbital cystic lesion. And obviously, the physicians and gynecologists waited for the child to be delivered. And these are some of the pre-delivery ultrasound pictures which show the large tumor. The child was born with a fairly noticeable proptosis with a very tense orbit. While we did consider the possibility of waiting for some more time rather than operating on a neonate because of the anesthetic and other risks, but it was a very tense orbit, and I was very sure that the child will possibly lose vision if we wait too long. So based on that, and based on the CT scans where you see the large cyst, which is filling up a large volume of the retroocular space, we decided to perform the surgery for this child. This is the MRI also, which is showing a large cyst, which is tense, which is pushing the globe, significantly compressing the optic nerve. Now, this is the view, because the side view does show the proptosis much better. With a good team of anesthetists and neonatologists, I went in through a transconjunctival approach using a lateral canthotomy, cantholysis, a transconjunctival fornicial incision, very small incision, and using the finest instruments available with me in my theater, we went ahead and very carefully did the surgery using malleable retractors till the cyst came into view. And as expected, it was a fluid containing cyst, and we took out a fairly large window of the cyst rather than trying to dissect. This was deep in the orbit, as the pictures showed. Any extra dissection, any extra pressure on the globe would have meant disaster. And following which, we left the conjunctiva unsutured as a self-draining orbitotomy fashion. And this is the wall of the cyst, and a single lateral canthal suture to close the wound. This is the patient about an hour after the surgery in the recovery area, where there's a considerable amount of edema. These are the post-operative pictures, and fortunately, to the relief of everyone concerned, the report came out as a cyst with benign respiratory epithelium lined cyst. And this is a patient a week post-operatively, and before and after surgery with the proptosis very well relieved. And of course, this kind of a preoperative, prenatal diagnosis and surgery got its own share of media coverage. This is the child about a year back. The child is about 3 years old and doing extremely well. Now, given a choice, why would anybody of us, whatever be the age, whatever be the sex, why would anybody want a visible scar? So that is one basic logic. Then if you have to do it faster, more precisely performed operations, faster healing, lesser downtime, and can be performed as a short stay or even as a daycare procedure. We'll run through a series of patients over the years. I've been doing this work for almost the last 20 years. And we see large intracoronal lesions, which were earlier removed through a lateral orbitotomy, bone flap, drain, hospital stay for 4 or 5 days. And we'll see how we've been removing these through what look like very small incisions, but which can be customized, which can be enlarged. And theoretically, one can go 360 degrees around the conjunctiva. You can go transcaruncular and get a lot of access. Of course, the risks of orbital surgery do remain. And this is the single suture at the end, at the lateral corner of the eye. Another patient with a large proptosis, a huge mass in the intracoronal space. You can see how it is kinking the nerve up. MRI. And this was a vascular etiology tumor, and this has been exposed using mandible retractors, good assistance, hypotensive anesthesia, good lighting, and very careful, meticulous dissection to separate the tumor from all the adhesions and gently deliver it out like a baby rather than pushing or pulling. These are large tumors which are the size of the eyeball or better. This is another gentleman who served with the armed forces who had a large intracoronal mass, and he was told he would get a scar which would make him unfit for army service. He would lose his job and go on to retirement. So this is the proptosis, the Naff-Zygers view. And one can see the large intracoronal mass which is kinking the optic nerve. This is the other view, which also shows the sagittal view, which also shows the nerve kicked both in the first and the second pictures. And this tumor was also, one can see the optic nerve pushed down by the tumor. And this is the tumor removed at the end of surgery through a transcaruncular, transconjunctival approach. This is the appearance at the end of surgery, absolutely no sutures to hold anything in place. Gently, in the earlier stage of my career, I used to put conjunctival sutures, but later I stopped that also, because if there's any bleeding, it will come out. Putting the conjunctiva gently back, and this is the patient at follow-up after 1 month, obviously a very happy patient. Some of the other conditions like a large dermoid, medial angular dermoid, are also removed through this. This is a montage of cases wherein one goes in transconjunctivally to expose the mass, and then with a limited decompression of the material, remove the mass through the transconjunctival approach. And that is the end. At the end of surgery, the top 2 pictures show the appearance at the end of surgery. And this is the patient on the first post-operative day doing extremely well. So I think that comes to the end of my talk. There's a video, but I think in terms of time limitation, if needed, I would skip that as well.
Dr. Ravindra Mohan, that was fantastic.
Thank you, sir. Thank you.
One hemangioma removed by a transconjunctival approach, inferior fornix, that you showed in some conference.
Yes, sir.
And not placing the suture is a good idea. There is no need. The conjunctiva gets opposed very nicely within 4 to 5 days. So excellent, and congratulations. Very nice.
Thank you, sir. I feel blessed. Thank you very much.
You are. Thank you very much. Now let's have Dr. Seema Sen. I'm looking forward to see her. Seema Kashyap. Seema Kashyap. Is she going to be the last speaker? Seema Kashyap?
Dr. Renu did not answer when we called out for her, so I'm not sure whether she's there.
So technically, Seema is our
Technically
last.
Yes.
Okay. Go ahead.
Okay, sir. Good afternoon, sir. Sorry about the glitches.
Good afternoon. Really longing to see your picture. Go ahead.
Okay, sir. I shall be sharing 4 interesting orbital lesions. I shall try and stick to the time. Case 1. This is a 28-year-old female with fullness in the right lower lid for the past 6 months. She had history of right-sided nasal blockage and recurrent maxillary sinusitis, which had been treated conservatively for the last 2 years. In addition, she had watering from the right eye for 1 year. She received treatment with oral steroids outside with the diagnosis of orbital pseudotumor. Now, this is the picture of the patient with fullness in the right eyelid. And this is a CT scan showing dense mass in the inferior orbit. These are the MRI pictures. So a biopsy was done, and this is the microscopic picture of the lesion. As you can see, this is a densely populated lesion, a very cellular lesion. And as we go on to high power, this is a neoplastic lesion with large to moderate cells with hypochromatic nuclei, numerous mitotic figures. So this was definitely a neoplastic lesion with blood vessels in between. And focal areas of necrosis were also seen in this particular lesion. So we went ahead with immunohistochemistry. CD20, which is a B cell marker, was negative, but CD3, a T cell marker, was strongly positive. This is CD56, which was also positive along with cyclin D1. And Epstein-Barr virus latent membrane antigen was also positive in this particular case. So a diagnosis of NK T cell lymphoma was given in this particular case. The patient received 6 cycles of chemotherapy and adjuvant EBRT, and the tumor showed complete regression after 2 cycles of chemotherapy. The patient was free of disease at the last follow-up. This is the picture of the patient at the last follow-up. The tumor completely regressed. Now, these are rare cases. Most of the lymphomas in the eye are B cell type. These T cell lymphomas represent just 1 to 3% of the primary ocular, orbital, and neck cell lymphoproliferative lesions. So the rarity of this tumor plus inflammatory signs, sometimes when they accompany, it makes it challenging to identify these tumors earlier. Extranodal NK T cell is known for poor survival, especially in older age group patients. And the mean survival has been reported as 12.5 months. So basically, a high clinical suspicion should be kept. An early biopsy and aggressive treatment should be done in these cases. Case number 2, this is a 7-year-old female child with right orbital mass lesion, which was present since birth and was gradually increasing in size. So a large tumor mass was noted in the right orbit and the eyeball was not visualized. CT scan, there was a large mass with solid and cystic areas and absence of any eyeball, but there was an ectopic tooth within the tumor mass which was seen. A lid sparing orbital exentration was done and the tumor mass was excised. Now this is the tumor mass which was sent to us, a huge mass, and microscopically what we saw was, this is the flattened epithelium with hair follicles, numerous hair follicles representing ectoderm. This is the colonic epithelium. We have the bone marrow also in this particular mass. Then cartilage, lamellar bone, fat, they were all present within the mass. There were no undifferentiated cells or malignant component in this particular tumor. So this was basically a mature orbital teratoma with an ectopic tooth in a primary and ophthalmic socket, which is very rare. And histologically also, we did not find any layers of the eyeball, any components of the eye. So this was a mature orbital teratoma. Case number 3. This was a 45-year-old male with swelling in the suprolateral aspect of the left lower lid since CT scan showed a heterogeneous enhancing mass in the lacrimal gland. And so a clinical diagnosis of pseudotumor versus a pleomorphic adenoma was kept. Now, when we received this tissue, now as you can see, this is a an inflammatory, densely inflammatory lesion, and within the inflammatory lesion, you can see these lacrimal gland acini as well. Higher power shows the lacrimal gland acini, and this is a dense lymphoplasmacytic proliferate. This is wrong. Okay, going on to high power, again, you can see that there are numerous plasma cells, there are small blood vessels, there are eosinophils within the infiltrate. Here you can see numerous blood vessels which are almost occluded, numerous eosinophils. And here you can see the plasma cells, number of plasma cells along with lymphocytes. Also, large areas of fibrosis or collagenization was seen. So here in this particular case, we had a dense lymphoplasmacytic infiltrate, phlebitis, eosinophils, and fibrosis. So we had a diagnosis of IgG-related disease. This, as you can see, immunohistochemistry shows strong positivity for IgG4 plasma cells along with IgG plasma cells. So this was reported as an IgG4 related disease. Although serum IgG4 was not elevated in this particular case, but this was a case of IgG4 along with those 3 major histopath criteria, as I mentioned, the dense lymphoplasmacytic infiltrate, the phlebitis, and storiform fibrosis. Along with it, IgG4 plasma cells, positive plasma cells, so more than 50 per high power field in our particular case, and IgG4 and IgG ratio was more than 40%. So that criteria was met, which is very important for the diagnosis. Now these can involve IgG4 related diseases, can involve any ocular structures. They respond very well to steroids. Hence, it is important to keep this entity in mind, which has recently been diagnosed, and appropriate management should be given at the proper time so that long-term damage to the tissues do not take place. And IgG4 related patients should be kept on close follow-up since they may have an increased risk of non-Hodgkin's lymphoma. Case number 4, this is the last case. This was a 44-year-old male who had right eye proptosis for 2 to 3 years associated with pain. Now, he gave a history of orbitotomy done in 2012, but we did not have the previous reports of this patient. And when he came to us, CT did show residual mass in the supralateral orbit in the lacrimal fossa region. Now, on microscopic examinations, when this mass had come to us, you can see there are 2 different areas. Now, this area, when you go on to high power, you can see that these are benign glandular elements present, and the stromal element, the myxoid stroma, is also apparent. So this was the pleomorphic adenoma component. And if you can see this particular region, high power, this is a very aggressive looking lesion, which when you go on to high power, you should see these gland-like formation. You have these irregular nuclei, hypochromatic nuclei, dense pleomorphism, and mitotic figures. Here also in this particular picture, you can see the increased NC ratio, irregular nuclei. So this was a lacrimal duct carcinoma in a setting of a pleomorphic adenoma. So it's important to recognize these lesions. Cytokeratin was positive and S100 was also positive. So these basically, they result from accumulation of genetic instabilities in long-standing cases. And these are extremely aggressive carcinomas The pleomorphic adenoma as such, the patients, 25 to 50% patients are known to develop recurrences. So you should keep a watch out for such recurrences and these aggressive tumors. Thank you.
Thank you. Thank you, Dr. Seema, for a wonderful presentation. I think really the kind of work that is being done in RP Center has not just remained high, but it has actually gone from strength to strength, as evidenced by the #1 position accorded to it by a recent survey by one of the leading journals. So I think this work like this that takes RP Center really, really high. Beautiful photo micrographs and wonderful cases. Thank you very much.
Thank you. Thank you.
Thank you very much. I think with this, we come to the end of the session. I wish to thank all the panelists and all my other colleagues, Dr. Feroz, Dr. Akshay, Dr. Ravindra Mohan. Grateful to you and conducting a very nice session. Thank you all. Thank you very much. We have enjoyed this.
And also wish to thank the very motivated participants who have held on despite all the challenges of time and delays. Thank you very much.
Thank you. Bye-bye.
Thank you.
Sharing of me.
Are we starting on time?
Good afternoon, everyone.
Good afternoon.
Good afternoon, Dr. Shalu.
Good afternoon.
Hi, good afternoon.
Good afternoon, Dr. Nubur.
Hello, hi.
Good afternoon, everyone.
Dr. Hardeep has not joined yet. No? Should we wait for 5 minutes or we should start the presentations? Dr. Hardeep has not joined yet.
No, I think we can start, and if he does join in, then we can, present at that time, because all sessions.
So I think the second presentation is mine. Do you want me to?
Yeah, you can start, Dr.
Okay, sure. Let me just share my screen. So the screen is visible, I hope.
Yes, yes.
Yeah, I'll just put it on the slideshow mode. Yeah, it's on slideshow mode now.
Yes.
Yeah. Yeah. So a very good afternoon, everyone. I'm Dr. Nupur Goyal, and I'm a cataract and oculoplasty surgeon practicing in Mumbai. And at the outset, I would like to thank Team DOS for giving me this opportunity to be a part of this very wonderful session with along the wonderful panelists. And so the topic of my talk is Piece the Puzzle. Often you will not know it's there. So it's a case presentation, and why I have named this presentation so. We will be solving this interesting case piece by piece like a puzzle. So we'll go ahead with this. So before I actually start my presentation, certain acknowledgements. So Dr. Tarjini Dave, who is also the moderator of the session, fortunately for us. So she was the consultant. We saw this case and she was a consultant. I was a fellow with her. The LV Prasad Institute, the Cryology Institute, and the photography and the CAVU team of that institute. So this was a 9-year-old male child who first presented in January 2017 with a complaint of left eye pain, swelling and discharge from the near the lower lid since 2 days. He had been having such recurrent episodes since 2 years. The syringing was patent since last 5 years in 2012, and the last was documented in 2015. All this was done elsewhere. With respect to the other history, there were no other ocular complaints, no history of trauma, the birth history, antenatal history, everything was normal, and there were no systemic illnesses. So currently, when he presented, he was on oral and topical antibiotics and oral NSAIDs. On ocular examination, the visual acuity and the intraocular pressures were normal. On external examination, there was a left lower lid swelling with redness and matting of eyelashes, as you can see in the external photographs. The rest of the anterior and posterior segment examination was within normal limits. Thus, a clinical diagnosis of left eye acute or chronic recurrent dacryocystitis with patent syringing was made. So now, as we all know, that the crux of a dacryocystitis, which is the inflammation of the lacrimal sac, is the stasis, is the NLD obstruction, which leads to stasis of tears in the lacrimal sac. Thus, the colonization by the pathogenic microorganisms, acute dacryocystitis, recurrent such episodes would further aggravate the inflammation and scarring, and further in a vicious cycle would aggravate the NLD obstruction. So the crux, the NLD obstruction in a dacryocystitis should lead to a syringing, not patent. So thus came our first piece of puzzle that we were dealing with a case of acute dacryocystitis with patent syringing. So we decided to further explore the differentials of this entity, and we came across atonic sac. So atonic sac is basically the Horner's muscle, which is the lacrimal pump muscle. So when that goes atonic, there is stasis in the lacrimal sac of the secretions and the tears, and thus it leads to dacryocystitis and a syringing, which is patent. Also, there was this case report where the atypical ethmoid air cells were infected, and they masqueraded as a recurrent dacryocystitis with a patent syringing. Then also dacryolids were documented to have caused dacryocystitis, but a patent syringing because of the movement or the fragmentation of the dacryolid, and also postural variation leads to intermittent symptoms. Further exploring there were congenital anomalies which led to acute dacryocystitis with a patent syringing. So in this case, the case series, the authors have described 2 cases. One was a fistula and one was a diverticulum. Further, lacrimal sac diverticula was noted to be having this entity. Again, a case report, a photo essay published in the Saudi Journal of Ophthalmology. So we decided to move on with all these differentials in our mind. We further decided to go on to the second piece of a puzzle, that was the imaging, and we decided to go for CT dacryocystogram. So on CT dacryocystogram, it was noted that there was a diverticular filling of the dye noted, which was in connection with the lacrimal system. If you can see with the red arrow, there is an outpouching, there is a filling of the dye on the left side. So these are the images, and thus with these 2 pieces of this puzzle, we were fairly confident that we were dealing with the lacrimal sac diverticulum. So we explored literature further, And I have, this case was seen in 2017, but I have further updated the literature with the recent ones, so do not have that confusion. So the diverticulum has been reported as early as 1932, 1937, 1943. There have been various case series. The largest case series has been reported by Siveric et al. A case series of 12 cases of lacrimal sac diverticulum. So this recent literature, this is a nice review published in the OPRS in January 2019, wherein they reported 10 cases of lacrimal sac diverticulum, as well as they've summarized and compiled all the cases that have been till reported in the English literature. So there have been 36 cases reported, and they very nicely summarize the entire thing. So reviewing this literature, the certain points that came out about the lacrimal sac diverticulum were that it is basically an outpouching communicating with the lacrimal sac. It was first described as early as in 1772. The etiology can be the congenital, traumatic, or inflammatory. So considering the history, we were pretty sure that we were dealing with the congenital variant. So as we all know that during embryogenesis, during the 6th week, the ectoderm invaginates between the nasal process and the maxillary process, and this cord canalizes to form the lacrimal system. The proximal end forms the canaliculus and the distal end forms the nasolacrimal duct, and it is at this stage that any diverticulum or any anomaly can develop. So the OPRS review, they also studied 400 consecutive DCTs to study the actual incidence, and they found that the incidence of diverticulum was 1.6% per lacrimal system. So thus it is likely that the vast majority of cases of lacrimal sac diverticulum are either asymptomatic or have such mild symptoms that they are never investigated. So often lacrimal sac diverticulum is asymptomatic and may go undetected. Therefore, often you will not know it's there. Even if it's there, you will not come to know. So a congenital diverticulum of a lacrimal sac, if there's an intermittent obstruction or drainage, it will enlarge in size because of vascular engorgement or retention of secretion. It will increase in size and cause pressure symptoms. So usually it is usually asymptomatic, but if it is large enough, it can lead to tearing or discharge. In fact, the OPRS review has said the most common presenting symptom is epiphora, followed by swelling, followed by dacryocystitis or discharge. The diverticulum is typically fixed to the deep tissue, but it is not fixed to the skin. It is tense and fluctuant when clinically apparent, and it is generally lateral to the lacrimal sac. The reason being that the lateral part of the lacrimal sac is only covered by the lacrimal fascia. So that's the only space the outpouching has to probably grow. The medial side has a bony obstruction, and imaging like a DCG or the cryocystogram or a CT-DCG is necessary for diagnosis. So now coming back to the case, the third piece of the puzzle, that's the management. We decided to go ahead with the surgery. So I'll just quickly take you through this quickly. So this was the tear trough incision being marked. You can see the swelling that's there. That's again being marked. So yeah. And then the syringing was done. So syringing in our case was not patent. Rather, there was a regurgitation seen from a conjunctival fistula. So then the tear trough incision was taken, and as soon as the orbicularis fibers were excised, the diverticulum was noted. It was bluntly dissected out from the surrounding tissue, and it was the communication between the diverticulum and the lacrimal sac was noted. The diverticulum was excised in toto, and it was sent for histopath. Following this, syringing was done again. The communication between the sac and the diverticulum was closed, was sutured. The wound was sutured, and in the end, the conjunctival fistula was sutured as well, and the syringing was confirmed to be patent, or noted to be patent endoscopically. So post-operatively, at 1 week, and at 3 months, the patient remained asymptomatic with an FDDT less than 3 minutes. The diverticulum, the excised mass, which was sent for the histopathology, showed a lining of columnar epithelium, which was similar to that of a lacrimal sac. And this is the last piece of the puzzle, because the clinching diagnosis of a diverticulum is that the lining has to be that of the lacrimal sac. So with this, I would also like to say that there was one more interesting report of, a dermoid, which one would think it's a diverticulum, but then it was noted to be a dermoid actually. So if you go by all the pieces that we have solved, then one would not miss on this diagnosis, not misdiagnosis at a diverticulum. Thus, we have all the 4 pieces of the puzzle, and we finally solved the puzzle of a lacrimal sac diverticulum. So the take-home message would be lacrimal sac diverticulum is rare, but an important cause of dacryocystitis with patent syringing. Imaging, which is CT-DCG, is an important diagnostic tool in suspected selected cases of lacrimal sac diverticulum. In cases where you're fairly sure that the syringing is patent and the NLD, there is no obstruction, a diverticulectomy alone may suffice, and thus you can prevent the need for the DCR. And the histopathology is essential for diagnosis because the pathology of the cystic wall should be identical to that of the lacrimal sac. So thank you so much for your patient listening. Thank you.
Thank you, Dr. Nupur. That was very interesting case. Any input from any of the panelists regarding this case, or in their experience if they have encountered this like diverticulum?
I think we have Dr. Tarjini with us, and she was actually the consultant who, we managed. So if she could also add on to the.
Hi, thanks Nupur, and hi Dr. Shalu. So diverticulum is one challenging sort of a presentation, and if you especially are seeing signs of acute dacryocystitis but not in the region of the lacrimal sac, probably a little medial or lateral, then you sort of want to rule it out. And also these are patients who will have intermittent symptoms of inflammation on and off. So that's probably the only other thing. CT-DCG is pivotal in making the diagnosis, and I think Nupur has emphasized on that very well. Surgically, the challenge is to whether remove just the diverticulum or do an associated DCR with it, because several times you end up damaging the lacrimal sac. So if you're able to remove just the diverticulum, then that works well. If not, you might need to add on a DCR if you've sort of traumatized the lacrimal sac.
Yeah, you don't think if the post-op scarring may lead to the obstruction again in these cases?
It can. The incidence of iatrogenic lacrimal sac trauma in such patients is pretty high. So eventually consider a DCR in these patients.
Thank you. Now, I'd like to invite Dr. Akshay. He will be speaking on maximizing outcomes, bloodless DCR.
Yeah, I hope I'm audible.
Yes, you are.
So, yeah, external DCR, I think a lacrimal section would be incomplete without a talk on external DCR. And as much as all of us practice this is probably our bread and butter, I can just add a little bit by showing my technique of how I make sure that the surgery is clean without any, bleeding. Any beginner will tell you that bleeding is the most important thing that they come across in a case of DCR. And that's one of the reasons why even residents don't enjoy doing a DCR. They're probably not able to identify structures when they see a DCR being done. DCR as a whole, as a surgery, is an extremely good surgery, extremely successful surgery that can give gratifying results for the patients, functionally and anatomically. As you can see here, there are reports that talk about 98% success rate, 100% external DCR success rate, in pediatric age group between 97 to 95%, again in adults 94%. So there's really nothing much that I can add because the surgery itself has been mastered over the years. But from my perspective, I can what I do is make sure that all systemic conditions are optimized before the patient is on your table, whether it's a diabetic, a hypertensive patient. Make sure that all the factors that you can control before the surgery begins are taken care of. Patients above 40 years, you should actively involve your anesthetist assistants in making sure that you get a hypotensive condition. You can offer certain beta blockers like metoprolol have a very, very large safety window. So even non-hypertensive patients can be administered a single dosage of metoprolol preoperative to make sure that their sympathetic tone is reduced and bleeding is less. Giving oral tranexamic acid 30 minutes before surgery also helps. I am a little old school. I like to offer give patients a prescription of a nasal spray decongestant 2 days before surgery, so that by the time of surgery, the nasal mucosa is completely decongested. And in addition to that, intraoperative or preoperative nasal packing is done with a decongestant and lignocaine with adrenaline. My local anesthetic is 5 cc of lignocaine with adrenaline along with 5 cc of bupivacaine. So I will play this video of a DCR surgery that will show the steps of DCR. I'm going to start here at the incision. The incision is one of the most important things. Ideally, it should be just over the anterior lacrimal crest, such that you directly hit the bone after the incision. Once that is done, retract the muscle and the skin wound, upper edge of the skin wound. Clearing the orbicularis from above, from the bone is important. I use a metal suction cannula tip to clear off and bluntly dissect the muscles rather than cut it. You can see there is minimal use of cautery till now. Orbicularis is not dissected or cut with the cautery. Identifying the medial canthal tendon, the superficial head, is important. I like to disinsert the medial canthal tendon, the superficial head. This is because only after doing so will you be able to get complete access to the fundus of the sac. Once that is done, the periosteum is then elevated and the entire lacrimal sac is separated from the lacrimal sac fossa. This is done till you are able to posteriorly come across this suture line, which is the area, the junction between the frontal process of the maxilla and the lacrimal bone, and then posteriorly you have the ethmoidal air sinuses. And that is where the ostium needs to be initiated. And I can do that with the periosteum elevator itself. Once a small initial ostium is made, then serially larger punches can be introduced and punching is done. You have to be very careful that you don't damage the mucosa. And to do that, the punching has to be done in a very systematic manner. There are 3 steps to it. First is to introduce the boning punch and engage the bone. Punch it with the thumb approximating the fingers, and then twist. The twisting of the wrist is important. That allows the bone to easily come off, as you can see there, without damaging the pink mucosa underneath. Engage the bone, punch, and twist. Once that is done, the entire bone is removed. We can see the pink mucosa, but how much of a bone has to be removed? This much bone has to be removed. Superiorly, I like to go at least about 5 millimeters above the common canaliculus. Anteriorly, as much as possible, preserving the bridge of the nose. Inferiorly, till the bony NLD is deroofed, and posteriorly till the ethmoidal air cells are seen and cleared. That big a nasal mucosal patch has to be seen. A lot of surgeons say till the size of your fingertip. My fingertip is different from other surgeons' fingertips. So that is a very poor estimation. Another tip that I learned from Dr. Javed is to inject the lacrimal sac with a viscoelastic material that dilates the sac. And also when you make the lacrimal sac flaps, you don't damage the opposite end of the lacrimal sac mucosa. I like to make a single U-shaped flap. So I don't suture posterior flaps. I just suture the anterior flaps. 2 linear incisions made with a 11 number blade, and then that is joined with by making a cut using a Westcott scissor. You can see a nice U-shaped large flap. Similarly, the nasal mucosal flap is created. Injecting a little bit of local anesthetic before cutting the nasal mucosal flap blanches it and makes the bleeding even lesser. Posterior flaps can be trimmed off or cut off, and you can make sure that the mucosal approximation of both the flaps is adequate. In case the nasal flap is large, you may have to trim it. Once this is done, you can apply mitomycin C. I prefer 0.2 milligram per ml for 3 minutes in all my cases. It's a personal preference. Once that is done, the nasal mucosal flaps are approximated edge to edge, and 3 sutures are taken with an absorbable material. Once that is done, the orbicularis and the skin can be closed in layers with a suture material of your choice. I prefer Vicryl for both. It does not cause too much scarring since we anyway take off the sutures at 1 week, and also economically you don't have to open another packet of sutures. So These steps are sound surgical technique during the primary surgery will make sure that you don't have a failure. Mucosal apposition is key. Intubation when necessary, such as post-acute dacryocystitis cases, revision cases, secondary NLDO where there is a obstruction following a fracture or any other sort of trauma. These cases I'll definitely intubate. And mitomycin C is a personal preference to use it in all cases, but again, surgeons have their own option of being judicious in using it for selective cases. So that is that, and I'd be happy to take any questions if we have the time to.
Thank you, Dr. Akshay. It was very nice video and truly bloodless. It was appearing as a cadaver dissection rather than on a patient. So you don't do the nasal packing before starting?
I do the nasal packing, ma'am. I do just before.
What concentration you use?
I use.
Yes, stop me.
I add a little bit of xylometazoline and then 4% lidocaine.
Okay. Any inputs from any panelists?
Wanted to ask a question. I'm Dr. Nitin. I wanted to ask a question. Is this DCR was under GA?
No, this was under local anesthesia. You could see the patient blinking.
Yes, yes. Because the patient's eyelid was so immobile for a long time, so I thought it's under GA.
No, unfortunately, although I prefer to do surgeries under DCRs under GA, in private practice, convincing a patient for GA for a surgery like DCR is a little difficult.
Yes, yes, definitely. Local, we also prefer local for the.
Wanted to congratulate Akshay on the excellent recording. To get clarity in a DCR.
Yes,
These are very convenient and excellent quality of video, Akshay.
Thanks. I will be honest, this was not my first attempt at recording. This was probably the third or fourth surgery that I recorded, and this finally I got it, good enough for making a video. Otherwise, there's always a little bit of extra bleeding somewhere. Sometimes you nick an angular vein and there is, a flood of blood. So I'll admit to, having multiple tries to getting it right.
Okay. Now, I'd like to invite Dr. Urmil Chawla. She will be presenting the pearls in the management of dacryocystitis.
Good afternoon, everybody. And thank you so much. And thank you, Dr. Akshay, for this wonderful presentation. You've made a lot of my job easy. I'll just touch the important pearls which we can come across during the management of dacryocystitis. I think my slide is not moving.
Ma'am, try using the arrow button at the bottom, the forward arrow.
Yeah, ma'am. It's not working. I think I'll stop share and again arrow. Yeah, I think now it's working. Thank you. So dacryocystitis, as we all know, is inflammation of the lacrimal sac and caused by the obstruction of the NLD and followed generally by bacterial infection, and it can have varied presentations. And we have the common two types, acquired and the congenital, and the acquired can be acute or chronic. Now coming to the congenital, which is as important as the ones we see in adults, it is 5 to 30% in early phase of childhood with higher prevalence in the premature infants. Commonly unilateral, but 20% cases can be bilateral. And as we all know, the mechanical obstruction located distally in the NLD at the valve of Hassner is the cause. Now, important is to check for the triad of epiphora discharge and matting of eyelashes. And clinically, at least do these three, Roplas, the tear meniscus height, and the FDTT to confirm the diagnosis of a congenital NLDO. The two clues which we can keep in mind while dealing with such patients, that if you get a mucopurulent discharge on Roplas, the distal obstruction is generally at the Hassner valve more likely. And if we get a watery discharge, we should expect a destruction at the valve of Rosenmuller near the sac. Now, for the treatment, as we generally do, is initially the conservative and then the invasive approach. McEwen, in his study on epiphora in the first year of life, he predicted the spontaneous resolution rates according to the age of presentation. And according to him, the earlier the age of presentation is, more is the success rate, like presenting at 3 months, 90%, 6 months, 75, and so on, it goes on decreasing. So early the presentation, early we should suspect to it resolve spontaneously with a success rate of almost 32 to 95%, which is pretty good. And Krigler's massage is there to augment that spontaneous resolution, done at the right place and 10 times in one session and total 4 sessions in a day, really gives good results and a good success rate. Now, topical antibiotics, we should always remember that they should not be taken casually and just prescribed in each and every case of NLDO. It's because it has a risk of developing a resistant flora and NLD chronic infection. So it is indicated only with the clinical evidence of infection and not in routine conservative management of CNLDO. Gold standard, as we all know, remains the probing, done by an experienced surgeon. Even though it is considered as a little blind procedure, it gives a very good success rate. We should confirm our procedure once we are in the right position, the probe overlying the supratrochlear knot, and we can do the spring back test just tapping the probe, and we can see it springing back to its self-retaining position, and also the metal to metal touch. So these two things give us a fairly good idea about our probing being successful and giving us a good success rate. Now, the debate regarding early and late probing continues as always, with the people favoring the early approach, arguing that why should we prolong any inflammation that may result in secondary fibrosis? So they prefer to do an early probing before 12 months of age. And those who prefer the late one, they argue that because since the success rate is good by 1 year of age, so let us wait for a spontaneous improvement and not to go and create an iatrogenic stenosis. Well, my choice is between 12 to 18 months, and that gives pretty good results. And however, once probing still remains the gold standard, I would say, especially in government setups. However, in certain cases of buried probe, complicated NLDO, endoscopic probing does have a place with its benefits of improved success rate, reduced likelihood of complication, and possibility to deal with the complications of inferior turbinate fracture in case of bone abnormalities. However, the drawback is that a learning curve is there. If an ophthalmologist needs to learn and do it to have a high skill rate, or you have to have an otolaryngologist with you. And the cost factor is even more in a developing country like ours. So I would say that as of now, as a primary procedure, simple conventional probing is still the procedure of choice. However, once it's a failed probing, or you find that you're not successful in one or at least 2 turns, you can go ahead with the endoscopic probing. Primary probing failure is patients usually develop it with the tearing and crusting within 6 weeks of intervention. Repeat probing can be done minimum not before 4 weeks, and late 4 to 6 weeks we can give a try. But I personally feel not more than 2 tries of probing. Once, if you are not successful, we should look for other causes and refer the patient, or go ahead with the endoscopic probing. While doing the endoscopic probing, or otherwise also, if it is a complicated NLDO, we have other options like laserolacrimal intubation, the balloon catheter dilatation, turbinate in fracture, and lastly, if it isn't a success, DCR is our choice. Another presentation of congenital NLDO can be a lacrimal sac mucocele or a dacrocystocele, which on decompression, it results in an egress of the purulent material from the punctum, or sometimes if it is a severe dacrocystitis, it may rupture through the skin and lead to a fistula formation. We should keep the differential diagnosis of hemangioma, encephalocele, glioma, etc. in our mind. Ultrasound is quite helpful, although it's a spot diagnosis clinically with less of confusion, but still in cases of where differentials can be thought of, you should go for an ultrasound. A medial cystic mass in communication with the dilated nasolacrimal duct, in addition to the typical fluid and debris content, is the diagnostic feature. Initial medical treatment for few days, not 8 to 10 is also, I would say, more, 1 or 2 days, and if no improvement, probing is the procedure of choice, and it minimizes the risk of dacrocystitis, and it gives a fairly good success rate. And acute dacrocystitis and cellulitis should give rise to the suspicion of a coexistence of an intranasal cyst in such cases. And again, nasal endoscopy is the procedure of choice. Marsupialization can be done along with the probing. Now, coming to dacrocystitis in adults, which is synonymous with the epiphora in adults, we need to categorize it as true epiphora, where watering is due to the real obstruction in the pathway. Pseudo, when hyperlacrimation causes, should be ruled out in any case of epiphora. Again, the true epiphora could be anatomical or it could be a physiological. Then while evaluating it, history, the adnexal examination is very important to rule out reflex causes of hyperlacrimation, any trichiasis, entropion, other corneal ulcers, any reason can be there. A good slit lamp examination may be helpful, and other causes like tear film breakup time, Shermer's, and even Jones test if required can be done to rule out hyperlacrimation. The Roplas, FDDT, sac syringing and probing, and the endoscopic nasal examination if required is helpful. And wherever required, the imaging or DCG can be done. Now, whenever we interpret the Roplas, whenever it's a clear mucoid or mucopurulent regurgitate, it's expected to be an NLDO. If it's a blood tinged, we should expect a dacrolith. And if there is no regurgitate but the distended sac empties into the nose, are the more common causes of diverticulum, atonic sac, and partial NLDO. And if no regurgitate and the distended sac does not empty, then an encysted long-standing chronic dacrocystitis and encysted mucocele is expected. Always, we should, before proceeding for our DCR surgery, whenever in doubt, we should go ahead with the diagnostic probing, which is fairly, gives a good diagnostic intervention. If it's a soft stop, we suspect a canalicular block, and hard stop gives us a diagnosis of NLDO. An older patient, because the lacrimal drainage system loses its laxity, they are more risk for acute dacrocystitis and the poor hygiene. Symptoms are pain, redness, swelling, and it may develop either as an acute exacerbation of chronic dacrocystitis or as acute peridacrocystitis due to the involvement of neighboring structures. Now, it may pass to the stage of cellitis, abscess, and the fistula formation. And we should keep in mind the microbiological spectrum, the most common, the Staph aureus and the epidermidis, followed by the streptococci and the Klebsiella. Even Pseudomonas is known to be very commonly involved. While chronic dacrocystitis is more commonly seen in postmenopausal women, spontaneous or follow the lacrimal infection, and in infants also. Symptoms are almost similar to those of, but more of mucopurulent discharge is there. Then again, we need to evaluate it on the basis of history and physical examination. Our cultures can be done. If in doubt, lab studies and blood cultures, and CT if orbital cellitis or extensive infection is suspected and it is very much appears to be as a differential. And a DCG can also be helpful. In chronic cases, the serological testing and for ruling out Wegener's granulomatosis and SLE, we should do these ANA tests. Differential diagnosis of orbital cellitis, cyst, neoplasm, ectropion of lower lid, and dacroadenitis should be kept. For treatment, as we all know, acute, we need conservative management of warm compresses, IV antibiotics, at times local IND if abscess is formed is to be done. Probing should generally be avoided, generally or maybe rather always avoided in the acute phase. And chronic, we have to go for the DCR. Surgical options nowadays, probing in adults is also being tried, and it has been found to give good results, especially with mitomycin C, especially in those cases of dacrocystitis which are an year or two, not very old, but an year or so old. It has been seen that they have responded to a good probing done with mitomycin C, and the need of DCR has not been there. Other techniques, balloon dacroplasty and NLD, intubation and stenting, DCR, endonasal DCR, and DCT at times in fibrosed or old patients, fibrosed sacs. And DCR, as Dr. Akshay has very well explained, I don't think I need to further go into it. It creates an anastomosis between the sac and the nasal mucosa while the bony ostium, and that is our goal also. So extent of osteotomy, as he has already told, posteriorly the lamina pepraceae, superiorly at the up to the medial canthal tendon should be there. The flaps should be properly H-shaped flaps. We should try to make the lacrimal and the nasal mucosa. They should not be overhanging. We should always, if they are too large, they should be trimmed to a smaller size so that a good flap apposition is there and does not sink down due to the large size. Again, the closure should be with the 3 vicryl sutures, and a good skin closure should be there. Coming to the comparison between the double flap anastomosis or the excision of posterior flap, the study by Serene D, it almost told us, and even we have been following now, that with it gives no further advantage, the double flap anastomosis, except making it a cumbersome and a very tedious process. It is giving no extra advantage or increasing the success rate. So it is always easier to trim the posterior flaps and go ahead with the anastomosis of the anterior flaps only. Again, mitomycin C has been proved to increase the success rate of DCR to around 95%. And so, as Sir said, it is a personal choice and can be used in routine also. Silicone intubation in bicanalicular silicone tube intubation is useful in cases of associated canalicular stenosis or post-traumatic NLDO or treating a failed DCR. The use of silicone, intubation, it also increases the success rate. Some cases come to us with a already bursted sac and a fistula formation. So additional fistulectomy is required, and infected lacrimal sac has to be removed. The complications can be wound dehiscence and tube displacement in the early post-op, granulomas in the intermediate, and a web facial scar is common in the late as a late complication. External and endoscopic DCR have been debatable and have been compared. But however, the conventional teaching was that endonasal was considered to be better. But presently, in the present scenario, external DCR and endonasal stand the same balance. And my take-home message would be that dacrocystitis is an important disease and ophthalmologist comes across. Hence, it needs to be timely diagnosed. CNLDO is an important cause in children and can be easily managed. In adults, DCR is the effective way, and the scale is maybe tipping, appearing towards the endoscopic approach, but external DCR still remains the gold standard, and newer modalities can also be tried. Thanks, and a happy New Year to all.
Thank you, Dr. Urmil, for the overview of the dacrocystitis in both the congenital as well as in the adult group. In congenital, we prefer to advise cricketer massage at least to 9 months, and then only we try to probe it. And the use of endoscope has been highlighted by you, and especially in the failed probing, which we come to are referred to us, then the endoscope has an added advantage and helps in finding the reason of fail. Sometimes there is a mucosa and overlying it, and we have to give a nick to the mucosa to make an opening at the valve of Hessner. So, and any other, Dr. Tarjini, any point you want to make?
No, I think Matt covered nearly all the points. Just one additional piece of literature that has come out now from Javed's group is on the timing for probing. So what was traditionally taught to us as McEwen and Young's gold standard study that said that, 6 months is the tip off, after which, the surgical procedures should be considered or probing should be considered. From his big data analysis, he has recently concluded that you can wait almost until 2 years. And in his practice now, he probably does not perform syringing and probing until 2 years and continues lacrimal sac massage. So that's just an additional sort of piece of information I thought I'd share.
Yeah, the cricketer massage should be explained to the parents, and that is very important. They should be demonstrated to them how to do it. So now is Dr. Vasu there? I can't see him. Then the Tarjini, I'll invite you to speak on the volume augmentation in a contracted socket.
Are my slides visible?
Yes, ma'am, they are visible and you're audible also.
Okay, sorry. So I just said the entire thank you on mute. So I'll just repeat it. Thank you very much, Dr. Shalu, Dr. Namrata. And I know Professor Bateria is here. Dr. Urmil and Nupur and Professor Bajaj, who are also the chairpersons and the convener for this session. Thank you very much for having me. I'm Tarjini Dave. I'm going to talk to you about secondary volume augmentation. And there is another talk on contracted socket management by Dr. Nitin. So I think between between the two of us, we'll probably cover the aspect of surface and volume augmentation in sockets. I have no financial disclosures to make, and you are going to see full face photographs of my patients, for which we have the appropriate consent. Now, when we talk of anophthalmic sockets, the amount of emotional discomfort that the patient goes through having to lose an eye is a lot, and there is a lot that you could do to give back to the patient over here. So this is an eye which has an excellent volumetric outcome and a very good prosthesis, which are the two most important things to give back a good appearance to a patient with an anophthalmic socket. So how do I go about treating my patients? I'm going to briefly discuss that with you. Whenever we talk of volume replacement, the most important thing is to do it in the primary sitting. So what you want to achieve is a good size implant that goes into the socket. And you can easily achieve this by making scleral flaps or petals, as it is labeled, which allows you to give a very good outcome post-operatively. So on your left-hand side, you see a lady who's undergoing evisceration with a 20mm implant versus the gentleman on the other side who has had an 18mm implant. And you can see the difference in the sulcus deformity. So whenever you're augmenting volume, for Indian orbits, remember that 20 is the baseline size of the implant that needs to go in to give you an excellent volumetric outcome. And this is primarily because 70% of the lost volume needs to be replaced by your implant. And if you do your volume calculation of pi r cube, axial length minus 2, then you will eventually come down to, for Indian Asian eyes, and axial length is around 23mm. So you come to 21mm, which is the ideal size of the ball implant that needs to go in, so that you give 30% to the prosthesis and you have a very good outcome. But that's as far as primary volume augmentation is concerned. What happens in secondary sittings? So you have a plethora of options as far as secondary volume augmentation is concerned. What I will share with you is what I do as my preferred practice pattern. This is not what is the absolute truth. This is just my practice pattern, and I'll share that with you. So when I see patients who do not have an implant in the socket, I prefer to perform a secondary implant. If there is some amount of surface loss as well, I add on a fornix formation suture and a mucous membrane graft. Briefly taking you through the steps of surgery, I make cruciate incisions within the conjunctiva and the tenons and raise flaps. I dissect both the anterior as well as the posterior tenons to expose the central intraconal fat, as you're seeing over here, within which I place a well-sized implant. A 20mm ball implant is being used here. And over that, I close the wounds again in layers. So you see the closure of the posterior and the anterior tenons here. And since this patient had some amount of surface loss, I'm using the conjunctival flaps that I had dissected to form the fornix formation suture. So that conjunctiva that was over the bulbar surface is now going in and forming the fornices. And the central bare area is covered with a mucous membrane graft. I like to harvest the graft from the lip mucosa. If I need a lot of surface area, I go to the buccal mucosa. And essentially, I use a combination of radiofrequency and surgical dissection with scissors to harvest the graft. I make sure that I have a thin graft. I debulk all the submucosal glands from the graft and suture it with the help of a 6-vicryl running suture into the bed of the socket, and place a conformer and perform a tarsorrhaphy over it. The fornix sutures are removed after 3 weeks, and a conformer is placed usually after 6 weeks. And this is the sort of outcome that you will get in a patient who otherwise did not have an implant. So this would be my first choice in a patient who is sans implant. This slide is just to show you how beautifully the mucous membrane graft seamlessly integrates with the rest of the conjunctiva and also gives you a very good volumetric outcome post-operatively. Now, the other option that you have in patients who have a combined volume and surface loss is to perform a dermis fat graft. I think Dr. Nitin would go into the details, and since we are running slightly short of time, I'll quickly run through the video and not show it in entirety. I like to harvest the dermis fat graft from the buttock area. I remove off the epidermis with the help of a simple blade. You can even use a surgical dermatome. And then I tend to harvest at least a 2 centimeter thickness of the dermis fat graft. This is then transposed into the socket, and I tend to avoid an extreme overfill. I oversize the graft by about 20% and suture it to the edges of the conjunctiva. If I can isolate the muscles, I'd like to do that and attach them to the edges of the dermis fat graft. This is the sort of outcome that you get. You need to wait for about three to 4 months for the entire graft to vascularize. You see over here, the central area of the graft has not vascularized completely, but the volume buildup is very good. Over a period of time, when you wait, you will see a complete vascularization of the DFG starting from the periphery going on to the center. Now, in patients who have a little bit of implant migration inferiorly and also volume loss, in these sort of patients, if I have to augment the volume, rather than removing that implant, I prefer to perform a second implant inferiorly in the floor of the orbit. So I insert a Porex wedge and I follow the standard transconjunctival incision where you go in the inferolateral quadrant and essentially you are going transconjunctival, transseptal to expose the floor of the orbit, just as you would for a fracture repair. Since these patients are anophthalmic, there's not much worry during dissection. And your Porex wedge is available in 2 sizes, in regular and large, and comes size specific, right and left side specific, with that notch for the nasolacrimal duct. I insert whatever implant seems fit to go in after sizing. I use the same sizer that is available with the titanium 3D implant system for fracture repair. And based on that, I use either the regular or the large size Porex wedge. And I tend to adhere it into the floor with the help of cyanoacrylate glue. This is a patient who had you see the hypotropic appearance of the prosthesis and a large sort of retraction of the lower eyelid if you compare the both lower eyelids. So this is a patient who had an inferior migration of an existent implant which was small size. And in him, all I have not performed any eyelid procedure, but I've just done a Porex wedge implant on the floor. And it gives a nice lift to not only the implant, but also the prosthesis and helps in correction of that hypoglobic appearance. Now, in those patients that have a small implant which is not migrated, is central, another option is to harvest autogenous fat from the patient's own body. And umbilical or buttock area or inner thigh, these are all areas from where you can harvest the fat. There are some patients who probably also have a double chin, and in them you can do both together. You can harvest the fat from the chin and sort of put it into the socket. So the process is, it has a learning curve, but is pretty gratifying. You need to sort of overcorrect the proptosis, or you want to induce a proptosis in these patients by overcorrection. I have now moved on to using 1 cc syringes for injection, and that's how you leave the patient at the end with a little bit of proptosis, which will resolve over a period of time. So this is a pre and post of a patient who has undergone fat transfer, and you see that subtle buildup in the superior sulcus that was not there preoperatively, and correction of phenophthalmos. The last one is on filler injection. This is filler injection that I performed in a child, but essentially that's just to show the technique. In adults, you can go on just like a routine retrobulbar injection and inject in the inferotemporal quadrant. That quadrant has the least important structures, and you're least likely to produce any complication when you are using the inferotemporal quadrant. This is a gentleman who has had a filler injection in the orbit, and you can see a good buildup in the right superior sulcus and a correction of enophthalmos post-operatively. I like to use a more cohesive filler like the Bilotero volume or the Juvederm voluma versus a more dispersive filler in this sort of a situation. So in essence, I've covered all the options for secondary volume augmentation, and I thank you all for a very patient hearing.
Thank you, Dr. Tarjini, for a very good overview of the secondary volume augmentation. So the primary surgery with the implant, these meticulous primary surgery should be the goal of all the surgeons, but we do encounter such patients, and over the years, even after the meticulous surgery, they may have contracted socket, and the management, it goes on during the years, their follow-up. We need to give them some revision surgery they require, and you have given a good overview of all the techniques which are available to us and the procedure which can be done. And you have shown that you can do the secondary implant along with the mucous membrane graft also. Usually we do in a step surgery, but in a single stage also we can do the secondary orbital implant as well as a mucous membrane graft if there is a mild to moderate contracted socket.
Yeah, in extreme contracted socket, it will not work. In grade 3 and grade 4, it's difficult. And those are cases where probably you might divert more towards a dermis fat graft.
So it can be done in a single stage also if we want to combine both the procedures.
Ma'am, long back we used to use the Ellen's implant also. What is your experience, or is it almost obsolete now?
I have actually explanted more Allen's implant than
implanted. Yeah, that's why we also stopped. That's why I was just asking whether it is still there or stopped.
I have never used it for implantation. I have never been taught how to use it. So.
Yeah, when we were as senior residents, so there was a trend of implanting the Ellen's implant after doing an enucleation. But slowly, you are right, the lot of explantation cases used to come, and slowly it has just a Newell's implant or this round ball implant has replaced that completely.
And do you use a hydroxyapatite implant for volume augmentation?
Yeah, I would, if I have a good scleral shell, if it's a patient who has undergone an evisceration earlier without the placement of an implant, and I'm doing just, a secondary implant without the need for any surface augmentation, then I would use a porous polyethylene. I tend to use porous polyethylene more than hydroxyapatite. And if I feel that there isn't sufficient cover, then I do not hesitate in doing either an anterior scleral capping or a complete wrapping in vicryl mesh before placing the implants.
Can you just tell me, like in cases of extensive anterior staphylomas, in them also you are going ahead with the evisceration with implant, or you prefer?
In all cases where we have ruled out an intraocular tumor, either a proven intraocular tumor or even a suspicion of an intraocular tumor, in all those cases, whether it's a staphylomatous globe or a very tiny eyeball, extreme thicical eyeball, we perform evisceration and implant here.
Thank you, Tarjini. Now I'd like to invite Dr. Nitin for presenting the management of contracted socket.
Good afternoon, everyone. Am I visible?
Yeah, you're visible. Just share your screen now.
Is my screen visible now?
Yes, you've started, but your slides are not yet visible.
Okay, now?
Yeah, please put it on slideshow.
My slide is not functioning. Just hold. Okay. Is it visible now, or is it still not visible?
It is visible, but it's not on slideshow. If you can probably do it, or otherwise we can carry on. Actually, there's no button from the DOS end.
Yeah. Is it visible now on slideshow?
Yeah.
Okay.
Yes, it's on slideshow.
Can I start?
Yeah.
And good afternoon, everyone. It's good that DOS has given me this opportunity to present. And after presentation of Dr. Dave, we all know her, and with such a good video-based presentation, it is difficult to catch up with the level set by Dr. Dave. I will be presenting on contracted socket management. As you know, in present scenario, on present era of social media and selfies, everybody is conscious of their own appearance. In our practice, we do get many cases of trauma, especially blast injury, as well as other cases which have been operated, which are undergone enucleation or evisceration elsewhere. Many cases in our practice are not being given a due cosmetic repair at the time of during the primary or even the subsequent visits. So managing such contracted socket, we do get many cases, not very as frequent maybe as LV Prasad, but we do get many cases. And whatever the contracted socket we are getting, we are trying to manage in-house. And what we are trying to do as know in contractor circuit, we is trying to go for the both volume as well as augmentation of the furnaces and try to give the customized ocular prosthesis. So management of is most difficult, as you all will agree with me. Contractor circuit management over such cases, patients do follow up over a long period of time. Patient satisfaction as well as getting a happy outcome at the end is not only the one case surgery. I have also have to operate somebody who has got the good ocular prosthesis, customized prosthesis. He comes after 2 or 3 years. We generally move from one place to another, but the patient do follow up. And such cases, even if he is happy on the, let's say, 7th or 8th post-op day on the first surgery, he may have to have a recurrence problems after some months or about a year. So what causes is what mainly we see is a contracted socket which we get following anophthalmos. Anophthalmos may be of any cause. Other causes of contracted socket are less likely in our practice. What we generally get are most commonly as post-enucleation or post-evisceration, which has been operated for initial trauma, or even the post-traumatic like a blast injury which has not been corrected or which has not been given a cosmetic thought. As others, other causes other than trauma like post-radiation, post-macrophthalmos, or inadequate conformer, a child who has been using small size implant, as child has grown, the implant size has not increased. Such cases are also do present with the contracted socket. Gopal Krishnan classification we all know as which we are following. Management of contracted socket, I will try to bring it to the as per the grades. Such a small historical perspective as Dr. Urmil was asking. I also had seen during my training days Allen's implant being placed in the Viva table for the PG trainees, but nobody daring to use it during the surgery because of the complications post-operatively. We have come long way from it. Come back to the circular implant like Mule's implant is what we are preferring nowadays. And what Dr. Bajaj Shalu was asking, putting the implant like volume augmentation, I try to go along with the surface augmentation. I will show the slides first. So what changes which we are looking for in the enucleation or anophthalmic socket which has not been given the volume augmentation, where there is always when the loss of volume is followed by a drop in the superior and LPS and superior complex. So there is always a space which remains there at the superior part of the globe, which we generally later we say there is a superior sulcus deformity. When we put the orbital volume augmentation or Mule's implant, the inferior placement or inferior displacement of the implant over a period of time do occur. And as you can see, as you remove the eyeball and or the you do the enucleate or there is a post-traumatic loss, the superior inferior complex do tend to go down. Also, there is a due to gravitational effect, there is a loss of the anterior position of the lower lid, and fats tend to collect inferiorly. So what we are looking for the contracted socket, as Dr. Dave also has shown, that contracted socket grading as well as there is a loss of volume, and not only just putting the round implant is sufficient many times, but you have to give the volume augmentation also. So what we are looking for the basically correcting the superior sulcus deformity, also correcting the ptosis as well as the lax lower lid. So what, as you can see in our cases, sometimes there is a contracted socket has lasted for grade 4, grade 5. In such cases, DFG or dermis fat graft is what we go for. When we go for the acceptable implant, it should be a central place implant with adequately epithelial lined socket and well-fitted prosthesis. Earlier, we used to go for the stock prosthesis, but customized prosthesis we have started dispensing. So early contracture, there is what we are looking is the loss of conjunctiva, tenons, and poor ill-fitting of the prosthesis. In late case causes, there is a migration of the implant which we should look for. how do you manage? First and foremost is when you have a contracted socket, look what is the cause, and also look whether there is a volume deficit or not. If there is a orbital volume deficit, always correct the orbital volume deficit in primary surgery. That surgery can be combined with surface correction, but just putting a larger size prosthesis or trying to give only inferior fornix suture without trying to cover the orbital volume deficit will have an unhappy patient. Volume replacement, you look for whether what size of implant has been used. Many times we have explanted the round basic Mule's implant, which is well centered, but size was inadequate. Replaced it with a larger and adequate size implant. Along with that, you look for the fornix formation sutures. Many times when the patient comes with a contracted socket, there is a horizontal shortening. So, and also there is maybe because of the prosthesis for a long time, there is a lengthening also of the lower lid. So that lower lid, which gives the support to the prosthesis, should have a tighter configuration. So it can be combined with the lateral sarser strip in the primary setting. Ptosis can be corrected if you feel that adequate size orbital implant as well as prosthesis has not given the lid the contour which the patient desires. Rather than increasing the size of the prosthesis or trying to go for the larger orbital implant, a small ptosis correction surgery can give the better cosmetic appearance. So as we discussed, if the size is smaller by the previous surgeon, or if you feel that when you have operated about a year back or 2 years back, size seems to be small, you can replace the implant, and Mule's implant in such cases is my choice of implant with the larger size implant. So what to go for, integrated or non-integrated, is still, as the previous speaker was asking, whether you go for the hydroxyapatite implant. I still go for the Mule's round implant. Hydroxyapatite implant, if it is being put in as a secondary orbital implant, or if we are explanting the primary implant and then going for the secondary implant, non-integrated implants like Mule implants tend to do better. In my case, I have had a what is called as late extrusion, or even when you are suturing the in layers, you always feel that you are not able to get the good strength. If it is with the wrapping, with the sclera, then again volume size which you want to put into the orbit, you are not able to judge which size of the hydroxyapatite implant you should take and then put the wrapping. So from my side, or my choice is always Mule's implant in such cases. Orbital floor implant, as Dr. Dave has shown, if there is a post injury where there is a fracture of the floor, or there is a roomy orbit and contracted socket along with the roomy orbit, if you tend to give the more or bigger size implant, the implant will tend to migrate over a period of time. Inferior orbit floor implant should be placed. Like in our case, there was a migration of the implant inferiorly, and there was a roomy orbit. Somebody had put the orbital round implant there, but in such cases we went for the floor implant. I implanted a silicone plate. That was a cheaper option that I had available. Volume augmentation, as Dr. Dave showed, it is also to be done in case the patient, you feel that volume augmentation is not that much, which requires the explant of the implant, which has already been there. But the patient complains of inophthalmos, like in such cases where you can see in this patient, the patient said that eyeball seems to be shrunken, and there is no drooping of the orbital prosthesis. Then you definitely go for the volume augmentation, and fat is what we choose. In my practice, I harvest the fat with the help of the surgeon, or if a reconstructive surgeon is available or plastic surgeon is available, he gives me the fat retrieved from the large syringes. Syringes can be just kept. There is no need for a centrifuge. You can keep the syringes in vertical position. The fat tends to collect superiorly, and then you can get it in the smaller syringe and inject where you want it. Patient do get fullness of the lid, mild. You look, as you say, you get us whatever area you want, and how much in ophthalmos you want to correct, you slightly over correct because the fat gets absorbed over a period of time. But one time procedure is not sufficient in such cases. In this patient, he went for twice fat injection, but otherwise he was happy immediately. So I will not comment on it, but there are a few things are available and other surgeons are definitely doing it. There are so many cases where there is just inferior fornix formation sutures will give you the bigger and better depth, and the patient will have a better cosmetic appearance by changing the prosthesis. You go for that in such cases. Ptosis, you do correct. As I said, in this my case, there was a you feel that there is a drooping or that the implant has shrunken down, but if you see, it is just requires a correction of the lid margin position. Patient went for the ptosis correction. It's just switching of the LPS and shortening of the LPS is required. That LPS correction, how much is want? You go on the table. The what we go for 14, 16, 18, 20 millimeter correction for as a pediatric ptosis is not applicable here. You get the LPS separated. Many times it's difficult to separate in contact socket. So whatever you get, you on table, you find out how much you want to correct the ptosis, and then cut the LPS. There are other things in literature. I have not used it, so I will not put it. But ptosis crunch is there, as we can use spectacles for the ptosis crunch spectacles. That can be used. Again, then the surface reconstruction. This is how the case is. There are, in this case, there was a grade 4 contact socket. Volume was okay, but surface was inadequate. Patient came with that previous implant which was put few years back. Implant is in place, but she is not able to put the prosthesis. So again, as been shown by the previous surgeon, buccal mucosa from the lip is what choice you get, and it you can go for repeated surgeries. I have also many times you feel that there is a lot of volume augmentation is required. Thus, you may not get the adequate size of mucosa from the inner lower lip in first go. You can correct the partial, wait for about 4 to 6 weeks, and after 6 weeks, the lower lip mucosa resurfaces. You can go for repeat mucosal harvesting from the same site, because I know when we say that harvesting of the mucosa from the buccal side or from the inside of the mouth or from the hard palate, it is there, people do operate, but it requires a lot of surgical expertise as well as training. If you want to harvest the mucosa, lower lip is easiest place to harvest, and you don't have to suture it back after harvesting. You just leave it to heal by granulation process, and if there is no infection and no minimal scarring, you can repeat the harvesting procedure from the same site in 2 months. And in such cases where you feel that you just require a surface reconstruction but no orbital reconstruction, orbital implant, secondary implant, you can go for 2 or 3 times surgery to achieve the adequate surface and volume. So in such cases, you can at the end of the surgery, you definitely should put a inferior fornix suture. Even not only the surface, even if you feel that after putting the mucosa in first step, if the lower fornix is not getting formed, you can use the mucosa to form the lower fornix, because it is the formation of the fornix which is important. If that area has the mucosa, there is the adhesions are less. The adhesions in the central part can be tackled subsequently, but if your inferior fornix is not formed in the first setting, it will be difficult to go for the subsequent harvesting. Also, after putting the graft and inferior fornix suture, you can put the amniotic membrane before putting the conformer. But that helps in healing as well as decreasing the formation of adhesions. As you can see in photo E, there is a whitish thin line. This is the amniotic membrane which was put, and then the conformer was placed. Dermis fat graft, I don't have a video or photo, but in grade 5 with the no implant inside, and guys, you cannot put an implant also, or you cannot go for the surface reconstruction, then the DFG is the choice. But DFG is the last surgical frontier, or the last surgical choice to be given to the patient. There are other factors also. We may feel from the surgeon side ki, I will master the technique, but when you ask the patient to use the gluteal tissue inside the eye, a patient has I find it's always has reluctance. So DFG as a primary procedure, I don't give the choice to the patient. We always say we will try to go for the fornix augmentation or surface augmentation with the mucosa, or try to put a Mule's implant. When that first surgery doesn't give the adequate cosmetic appearance to the patient, and we say you cannot put more volume inside the eye by artificial means like Mule's or other implant, then second stage, then patient I do give the choice of DFG. I do DFG less. I'm not doing the DFG on a very regular basis. I do put a secondary implant and mucosal augmentation more than DFG. So as there is not much to be shown in me, as Dr. Dave has showed, that elliptical graft we do harvest, and the size has to be at least 15% more to compensate for the resorption of the fat. Then there are called as malignant contracted socket. The patient who has come with the blast injury or injury because of the high explosives, patient never accepts for the removal of or that not able to put the artificial eye. They go for the multiple implants, multiple surgeries. But that such cases are we cannot give a even the DFG will not work in such cases. In such cases, we go for the spectacle based prosthesis. In such case, first thing to remember, before you give the permanent tarsography, in such cases you have to locate the lacrimal gland and excise the lacrimal gland, because if you don't excise the lacrimal gland before tarsography, the patient do get continuous watering and healing processes or the sinuses can occur. So what are the 2 or 3 cases I have done for the spectacle based? We first step was to locate the lacrimal gland, do extensive, because in such case we are not going to save much of the tissue now. So extensively blunt dissect and find out where the lacrimal gland can be and excise, and then go for the permanent tarsography. Such cases then can be given spectacle based prosthesis, and that gives the better cosmetic appearance. Then the other few cases which we have done recently, again a patient with a blast injury and loss of eye and along with the skin. So if you can see, this is the after the first surgery, this is the skin graft, full thickness skin graft was given to make the lower lid. Then there was a second stage was done for the orbital implant and the mucous membrane grafting to have some superior inferior fornix, and then the customized prosthesis was given. Then there is a notching. It was then later corrected with another extra skin graft, full thickness skin graft, which was it has given a better appearance, but still small notch is remaining. But a patient who was just 23-year-old with a severe blast injury with loss of orbital tissues, he has at least a confidence to face the world. Then there are other few cases of contracted socket.
Kindly sum up, please.
Yes, thank you. And that was my presentation. Thanks. Thanks a lot.
Thank you, Dr. Nitin. Thank you, Dr. Nitin, for the very nice cases you have shown and you have managed. Now I'd like to invite Dr. Dheeraj Kumar. He is a prosthodontic rehabilitation in cases with orbital defects which are difficult to manage in children who are congenital microphthalmia or irradiated post-tumor excision, and they have the contracted, in addition to the contracted socket, they have contracted orbit also. So in these, we have to do the prosthodontic rehabilitation. I'd like to invite Dr. Dheeraj.
Yes, good afternoon, ma'am. Good afternoon to all the chairpersons. I'm audible?
Yeah, you're audible.
My screen is also, ma'am, showing?
Yes.
Yes, I am Dr. Dheeraj, faculty from All India Institute of Medical Science. Will be presenting my topic on prosthodontic rehabilitation. I am thankful and grateful to the organizing committee giving me opportunity to share my thoughts on the rehabilitation part of orbital defects in a conference. So coming to the rehabilitation part, rehabilitation, as we all know, is a long-term process. It takes time of the patient, from the doctor, physician who is treating them, and from so many aspects it has to be treated. So rehabilitation of facial defects which are caused due to some neoplasms or congenital defects and trauma are usually challenging for the surgeons and the prosthodontics. In context of surgeon, I'm talking, they will be very challenging in defects where the tissues has to be harvested, the vascularity management, the size, the patient's acceptance of the defect, and the recurrence of the defect. And for the prosthodontic point of view, when we are seeing the patient difficult, we see in the perspective of the available tissue, the size of the defect, the patient's acceptance of the prosthesis again, and the margins of the defect which we concentrate. So here the small, I will be telling of our 15 years experience of the OPD patients which we are getting here. The major chance comes from the maxillectomy defects. Out of that, we are also getting major number of orbital accentrations patients for rehabilitation in our department from collaboration with the RP center in our dental center. So we can see as the number of patients referred to us and they get rehabilitated with the prosthetic eyes. So eyes, no need to say anything. They are the epitome of facial universe and they lead to expression of so many things. But in certain situations, when we have to remove that by the means of evisceration, enucleation, accentration, they lead to a disfigurement. The disfigurement leads from accentrations are more damaging for the psychological perspective, functional, aesthetic perspective for the patient and his acceptability in the society also. So when we talk in terms of rehabilitation, surgical with prosthodontic in context of orbital or other facial defects, for orbital defect, it is sometimes very difficult for surgically to rehabilitate it, but still surgery part can enhance the prosthetic outcome in terms of the anatomy of the defect, in terms of removing the communication with the nasal cavity, with the oral cavity, with the defect part, so that the prosthetic outcome offers good quality. So prosthetic rehab have an advantage, like it requires less time for the patient visits. Patient has to get no surgeries again. If it is required, minimal surgery will be required. And it is mostly when the skin match, everything is naturally looking. The disadvantage part will be because everyone wants their own tissue part there. So it is again patient will not be very much accepting because he has to remove it. He has to again place it on their socket part. He has to clean that thing, and whatever material we use, silicones that we are using, still deterioration happen with time because of the contact with the body fluids. So the whole aim of or goal of this rehabilitation is to improve the overall quality of life of the patient by socially integrating them and to improving the functional aesthetics of the patient. So a team approach will be required where all the team members will interact and plan a comprehensive treatment plan for the patient. So surgical procedure that will enhance the prognosis in context of orbital prosthesis will be the lining of the defect with a split thickness graft, avoiding distortions of the eyebrow of the patient, and do not closing with the heavy flaps of the defect part so that the depth of the defect will be reduced. So further rehabilitation with the orbital process is difficult, and leaving the retained eyelids. So these are some cases which are referred. We have rehabilitated with the orbital part because they have been referred for ocular part, but because of deficiency, we have fabricated a orbital component for them. Here we can see the remnant eyelid creates some difficulty in fabrication of the prosthesis for us. Similarly, some cases referred to us, not from our center, AIIMS only. We get as a tertiary, so many centers refer the patient to us. Sometimes defects has been overly closed by a flap part. So there is no anatomical area to fabricate a prosthesis. So flap has been closed in this area. A burn patient also came from a rural part of Punjab for rehabilitation. It was again difficult. We doesn't have anything. Secondary surgery, patient was not willing. Maximum time we don't want a secondary surgery. So we have to compensate that part by fabricating a prosthesis which have the sufficient depth with a retentive component also. And we do get some complicated trauma cases. They are definitely required a second surgery to improve the prosthetic bed for the prosthesis. Some other reconstruction, mild reconstruction should be done so that we can fabricate a acceptable prosthesis for the patient. So, but in terms of ideal orbital defect, usually we don't want a defect should be there, but when we are talking in terms of ideal orbital defect, it should have a healthy and bony margins all around. No raw and inflamed area should be there. We have to wait for that time. No mobile or less mobile margin should be there, so that because the prosthetic eye should have a firm base over that. Lining with the skin graft improve the prognosis of the prosthesis, and the depth of the defect, very important thing. Too shallow defect, difficult to fabricate a prosthetic eye. So this is something an ideal defect. It also has some limitation where the distortion of the eyebrow is there. There is some communication is also there, but still it comes in an ideal orbital defect where the normal type of spectacle return process can be made. So patient selection, usually the type of patient which are we are engrossing in that thing, those have submitted themselves are more compliant for the prosthetic needs. So physical conditions, psychological status, their concurrent disease and underlying diseases, their recurrence chances, and alternate treatment, all the possibility, the age, patients on desire should be discussed in detail. The treatment planning process with the etiology, the type of reconstruction, the type of material, either resin acrylic we are using or a silicone we are soft type material we are using, and how the retention of that process is going to take place. So this is a pictorial diagram of a simple or vital processes which we do. We do the facial markings, take a facial moulage impression, then on a conformer, on a custom conformer, we take a stock ocular part and just position it on the patient face, then do the sculpting with the wax, make a mold of that thing. Inside the mold, do intrinsic shade matching with the silicone, different type of shades are there. Manual matching will be done, and a room temperature polymerized silicone will be packed for the final processing. Then this ocular part will be again inserted there, and the eyebrows part will be either the custom made, it will be sew there with the threads, or maybe we can use a stick-on type of eyebrow also. So different retentive weights I will be elaborating here. The most simple will be if a defect will be of an anatomic undercut is there, that is very useful for smaller defects. In a superior lateral margin, some defect is there and skin grafting is there. A normal prosthesis with a good depth or a defect retains there without any support. In major cases, when we don't have a very good depth defects or so shallow defects are there, there's spectacles with the mean of screws or via some attachment mechanism, we attach it. We do the try-in at the time of impression stage, we attach it with the wax pattern. So that the final silicone conformer will have a hard part attached to the rim of the spectacle. It is economical in our scenario for the patient, easy to fabricate, and are less time consuming for the patient. And due to the spectacle margins also, the margin part of the process also gets concealed. So very well accepted by majority of the patients. Then certain cases don't have spectacle retained part, or maybe some have a combined ear defect also. In that cases, we don't go for a spectacle retained prosthesis. There we can use a normal glue type gum resin adhesives are there. Adhesive type of prosthesis can be fabricated, which can be easily used by the patient. But the main concern with adhesive is skin reactions, and due to the skin perception and the oily part, the deterioration of the prosthesis takes very faster. So again, careful selection will be required for these cases also. There are some cases with a continuous defect here, but we can see with the maxillectomy is there with the orbital defect. There's a combination of prosthesis by using a indigenous socket type arrangement with the maxillary plate part. So the socket will be inserted, give retention to the prosthesis, to the external part also, and to the internal part also. Here again, a combined defect where the magnet attachment has been utilized for compensating with the external component of the orbital part. And here we can see there is small obturator part which has been magnetically attached to the upper component. So the final result of this thing patient will get a acceptable prosthesis. Now, when coming to retentive part, integrated oral implants are also placed in region of the orbit part to enhance the retention of the prosthesis. Primary side will be superolateral orbital rim, where the amount of bone is of a good quality with a good vascularity there. So the advantages will be it provides good retention. There no use of any undercuts will be required. They avoid regular use of adhesives, and retention of in larger defect is also very good importance. The main limitation drawbacks will be the cost part. Bone should be of a good quality. Additional surgery for the patient and the patient compliance. And if a radiated treated bone is there, again we have to see for some other options. The survival of orbital region implants, the normal titanium implants are good as the study suggested, but in case of irradiated orbital area, the success rate is too less. Hyperbaric oxygen therapy improves the integration of the implant. So it's the case of orbital which we have done here. So this is the defect. A conformer was used with a marker a CT data has been generated where we can get the location of the bone in relation to the implant position. 2 endoceous implants were placed in the supraorbital rim area. Wait for 3 to 4 months for the integration of the implant. Once the implants were healed, a secondary screws was attached to connect the implant from the soft tissue part, a healing collar. Then a normal conventional like a dental implant process is we fabricate. Similarly, impression was made, wax sculpting was done. A bar was casted here with a magnet attachment there, so that a magnet type of attachments were used. Different type of attachments like a titch button type, like bar, as for a dental processes we use, can be utilized here to give the retention to the orbital processes. Now, when we come into now the 3D planning CAD/CAM, this thing, normal face measuring profilometers, facial scanners, even this model I have scanned with a normal iPhone camera scanner. So this type of models usually generate a STL file. Still, the accuracy of these models are not good, which I am just showing here. They can be the future time, a future thing for planning for the processes. We can just scan it. No need to take a more extensive moulages. 3D files can be taken. And one mimics planning I have done for this thing. Like we can have a planning. We can get the STL file transferred to the mimic software. Do the cutting, 3D cutting part. And plane orientations can be done here. After the plane orientation, we can mirror it on the other side, trim it to the socket defect, and then we can either, if we have a wax printer available with us, because silicon printer is still not available, we can print it in a wax printer, or we can get a mold dimension 3D mold for this eye defect, and then inject the silicon inside that thing and make a process. So this is usually followed, but we are on a starting phase for this thing still to begin with this part. Designing, we have already started for some cases. So the instruction for the patient after this processes will be reverse the process during the night or during taking bath, because that will deteriorate the quality of silicon which we have used, or even acrylic also. Cleaning of the defect regularly. Repeated formation in cases of young individuals, or with some collapsed cases where the size of the defect changes. So in terms of take-home message, I will say accentuated defect create more of the functional, aesthetic, and psychological disfigurement for the patient. So well-retained processes may increase acceptability of the patient, so that all the physiology, anatomic, and functional cosmetic requirement will be fulfilled, and that will add to the boon the confidence, and patient will lead a better life with more socially acceptable to the society. Acknowledgement to the organizing committee of the DOS conference. Professor Veena Jain, my colleagues Dr. Aditi Nanda, Dr. Rajiv, and my residents in the department. Thank you so much.
Thank you, Dr. Dheeraj. This was a very nice presentation showing how we can cosmetically and psychologically rehabilitate such patients who have already undergone so many trauma in their life, surgically as well as the radiation. So, and I'd like to ask how many visits a patient require, how much time from the first presentation to the first presentation to you, and then how much time they do require when they visit you?
Usually, ma'am, we try to make it by, because mostly as you here in the AIIMS, we are getting most of these type of patients coming from the distant part, not from the New Delhi, from the NCR or maybe from UP, distant part of UP. They usually stayed there for 1 month when they came for checkup in RP center, eye center here in AIIMS. So we try to make them within 2 to 3 weeks the processes for them. So usual main work is because now 3D planning, we are in a phase of starting that thing. Manual work requires more time, because when we are sculpting the eye on chair side with the patient, or we take a clinical photographs also, it takes 2-3 hours to make the acceptable outline of sculpting of the wax pattern. So we try to make it 2 to 3 weeks time, and we try to deliver the processes. Even it can be done faster if we are doing exclusively only orbital part.
And the 3D printing has advanced technique and gives the good outcome. The use of 3D.
Yes, ma'am. Yes, ma'am. Now studies are coming up with 3D printer. Case reports are there now. They are suggesting, because still only 3D printing waxes are available, still the manual silicon will be packed there. So this reduces the sculpting time, basically, how the data can be duplicated and it can be easily aligned with the patient's remaining eyeball.
And the glue implants, aren't they cumbersome? They have to remove it every night, and and they may come out anytime, or they have a good glue.
Maxillofacial, there is a gum resin which is available. This is a alcohol-based thing which usually give a sticky layer. This has to be daily. We usually supply this thing to the patient also, and patient has to daily clean that thing in the evening part, and from the prosthesis part, it also has to be cleaned regularly, so that no sticky part and the deterioration of this process should not be done. But it is well accepted by the patient where the defect is very shallower. Spectacle can also not be used there in these cases. And resin, this thing, adhesive prostheses are very useful for the patient.
Thank you.
Very gratifying surgery otherwise.
Thank you, ma'am.
I'd like to invite now Mr. Sachin Gupta for the custom ocular prosthesis, myths and facts.
Am I audible?
Yeah, you're audible.
Yeah, good evening, everybody. This is Sachin Gupta, and I will be presenting on ocular prosthesis and myths and facts about it. I would like to mention here that I do not have any financial interest through this presentation, and I have used watermarks for image protection. Custom ocular prosthesis is prosthesis which is made by an ocularist for an individual after taking the impression of eye, and it is painted according to the patient's other eye. It can be customized and made ultra thin in cases of phthisis bulbi, or hollow prosthesis where a thick prosthesis is required. Custom ocular prostheses are advised and fitted to the patients with disfigured eyes due to unfortunate conditions like injury, infection, etc. Such conditions can change the whole look of the face and needs a cosmetic correction in form of custom ocular prosthesis. It provides natural look to the patient and help them to join back the society with confidence. In today's presentation, I will be talking on myths and facts about ocular prosthesis, and I will try my best to explain the science behind it. So let's begin with the first myth. It is said the prosthetic eyes are made by stone or plastic material, which is not true. Present custom ocular prostheses are usually made by either acrylic or glass, though in past various materials like metals, porcelains, and ceramics were used. Now acrylic and glass are the only material used in making prostheses. Glass was most popular material until the Second World War. Now acrylic, which is PMMA, polymethyl methacrylic, is widely used. It is very strong and tough material, and these properties helps in making its surface ultra smooth and shiny, and it's not easy to break. It is lightweight, which helps in better tolerance in the socket and good for prevention of lower lid complications. And it is also biocompatible, which helps in forming better relation with the tissues in the eye. In many industries like medical and dental, it is widely used in form of rigid IOL, scleral lenses, multiple type of implants, and of course ocular prosthesis. So the fact is custom ocular prostheses are made by PMMA material, which is inert and highly biocompatible. The next myth is frequent cleaning. Why does the patient need to clean the prosthesis very frequently? Or why they need to remove it in the night? Either they have frequent discharge from the eye, or they are not comfortable with the prosthesis, or it is causing pain or causing severe dryness. When we make a custom prosthesis, it is made after taking the impression of the eye. This impression is used in making of the prosthesis, and when the prosthesis is made and fitted over the eye, it replicates anterior surface of the eye and its lost volume. In custom ocular prosthesis, there is a negligible gap between the eye and the prosthesis, which prevents discharge collection in the eye and friction of the prosthesis over the eye, which makes it most comfortable. So the fact is, custom ocular prostheses are very comfortable. A well-made prosthesis causes negligible discharge in the eye and they don't require frequent cleaning, and patient can use them in the night when they are sleeping. The another myth is that age is a factor and prosthesis should be fitted in adulthood, which is not true. The eye grows very fast in early stage of life. And for the even growth of canthus, a custom prosthesis should be fitted as early as possible. In pediatric patients, we fit a very tiny prosthesis and we keep enlarging it till we get the desired size of the socket. Early treatment makes the difference. So the fact is, custom ocular prosthesis should be fitted as early as possible in kids for optimum socket growth, and in adults for early rehabilitation of physical appearance and psychological trauma caused by disfigurement. The next myth is that kids doesn't require custom prosthesis as it is expensive and they need frequent change of prosthesis due to their fast growth. In fact, the same prosthesis can be modified multiple times to match the size. So patients or parents do not require to invest in prosthesis very frequently. Many times patients ask whether it is covered in Mediclaim. Unfortunately, in India, it's yet not covered, and patient has to pay their own. In many other countries like US, UK, New Zealand, UAE, and some European countries, it is covered in medical insurance, and patient can claim its replacement after every 5 years. A very common question by adult patients is whether they are entitled to get a valid driving license or can they renew their driving license in India? The fact is a big yes. Under the section of 9, subsection of 8b, a person with monocular vision can apply and obtain a valid driving license if his or her other eye is fit to drive. In such cases, applicant has to submit an additional medical fitness certificate of his seeing eye. It's been more than 2 years since the central government notified the state governments that they should issue a driving license to people with monocular vision, subject to the fulfillment of certain medical and fitness conditions. An RTI reveals that according to Department of Ophthalmology AIIMS, a person with monocular vision who has visual acuity of 6/12 or better in better eye and 120-degree horizontal visual field or more than that, and had more than 6 months after visual loss of one eye are eligible to apply for driving license test. So in conclusion, I would like to say that every procedure comes with its sets of myths, but it is important to know the facts to help provide the best possible outcome for the patient. There are basic needs for better results. In surgical cases, we need appropriate size of implant, which should be well covered and it should be in the center. Good size of conformer should be there throughout the healing period. And in cases of tarsorrhaphy, the tarsorrhaphy should be removed at least 1 week prior to the ocularist appointment. In thesical cases, a well-made and polished custom ocular prosthesis can be fitted over a sensitive cornea, even where the volume loss is very less. Patients with ciliary tenderness are not good candidate for custom ocular prosthesis. In microphthalmic cases, we prefer starting early. Ocularists can handle volume augmentation, socket expansion, canthal expansion all together in some extent. Sometimes surgical intervention is required when the weight of custom ocular prosthesis is more than within normal limit, even in very early stage of the patient's in early stages. In contracted socket cases, contracted socket grade 2 to 3 can be managed by custom ocular prosthesis. And in such cases, we recommend patching and pressure bandage in night. Ultimately, teamwork of oculoplasty surgeon and ocularist is the key of successful results. Thank you.
Thank you, Dr. Sachin. It was a very good overview, and you have answered many questions which the patient asked us in our practice. and you have given a very nice overview of the from the oculoplastic as well as the ocularist point of view. Dr. Urmil, you want to ask anything or to add?
No, I have been referring patients to him. A lot of time and he's giving me very good results. So I know his custom-made prostheses are giving very gratifying results, and the patients are quite satisfied, and it's a big relief for them. So I think keep up the good job.
Thank you.
I think Dr. Hardeep Singh sir has joined since quite long, and his talk was left out. So
we'll invite Dr. Hardeep now for his talk on management of punctal stenosis.
Thank you, Dr. Urmil and Shalu, and thanks for accommodating me, because I left my laptop somewhere else, so I gone back to get the laptop. So I will try to finish it off as early as possible, only the practical tips. Now, how to manage a punctal stenosis? As we all know that the acquired punctal stenosis denotes anatomical narrowing of the lacrimal punctum, or maybe associated with canalicular environment. Could be congenital or it could be acquired. So I'm not going into details. And the main risk factors for developing risk factors are old age, chronic blepharitis, females, and inflammation of the external punctum leading to gradual fibrotic changes. Everybody can hear me, na? I'm audible?
Yes, sir. Yes, sir.
Okay. So there are few grading, how to grade the epiphora. And there are certain options for punctal stenosis management. There's a simple punctal dilatation, or you can insert a perforated punctal plugs, balloon dilatation, punctal snip procedures, use of mini Minoka stents, and trephination along with canalicular strictures. So this is small. I have 3 to 4 videos, only small videos. A simple dilatation. My idea is to emphasize here is that you have to use a very good quality of punctum dilator. It should not be too narrow, otherwise it can cause false passages. So anyway, this is a temporary procedure. Restenosis can occur. It requires frequent dilatations. And the other option is punctal plugs. Now, the long-standing dilatation of punctum is required in order to prevent restenosis. This is a punctal plug. Nowadays, the punctal plugs are available in a very good shape, that they have an arrow-shaped head which retains the punctal plug for longer time. The extrusion chances are quite less. The other option is bicanalicular stents. This is required only in cases where there is both canalicular area are involved. Then it is more beneficial. Otherwise, the cost is high. The other option, which is very easy and very easily available, is mini Minoka stent. It is a 40 millimeter long mini Minoka stent with a collar in the top with head and this neck. This retains the stent in the punctal area. Now, the small video showing punctoplasty. You just dilate the punctum in the patient in which you require frequent punctal dilatation. Just the collar of the punctal area is removed, and the canalicular area is very finely sutured with 8-0 vicryl, either in continuous fashion or in an interrupted version. And most even such cases can also close. So we require a very close monitoring of the patient every weekly, initially 2 days, 3 days, then weekly. And next procedure is the 3-snip procedure, in which the punctum is dilated nicely, quite deeply, up to 3 to 4 millimeter. And one snip with a very fine Vanna scissor is given, and second snip is given, and from the bottom a horizontal incision is given, and the major chunk of the punctum and along with the canaliculi is removed. And it is very important to suture, otherwise it will close again. And a frequent repeated syringing is also required, just to ensure our dilatation is required in serial number of visits to the patients. Now this is the insertion of mini Minoka stent. In this patient, the punctum area is visible, but I am not able to insinuate. So at the area of punctal papillae, a fine incision was given with RF cautery, which gives a very neat and clean hemostatic incision. And we can see a very white glistening endothelium lining of the canaliculi. And the punctum dilatation is done. And before push to show the patency of the lacrimal duct along with the canaliculi. And a mini Minoka is insinuated, and it is suture is passed just to reinforce that it should not extrude. As in this case, there is a wide opening of the punctum is there. So a suture is passed from the collar of the
Sir, you need to unmute yourself. You got muted. Dr. Hardeep, sir?
You have lost contact. You have to
Yeah,
start.
lost contact also, and I think it did also. I think he's not aware of it also. He's continuing with his presentation.
Dr. Hardeep, please share your screen.
It's not visible.
No, you have to share your screen again.
It was not visible.
For last 1 minute, it was not visible, sir.
Yeah, I'm not, something wrong has happened.
You can stop share and again restart, sir.
Okay, you have seen the last mini Minoka stent movie
Yeah.
video?
Yes, sir.
Then this is the end of my presentation. This is the last movie.
Dr. Hardeep, what do you prefer, 3-snip or single snip with mini Minoka? Because nowadays we prefer single snip with mini Minoka stent. What is your procedure of choice?
Okay. These are my few old videos. I just want to show the procedures done in the past as well as right now. These are my old videos just to complete the list of procedures. I am showing these 3 snips and all these videos.
Nowadays, what are you doing, sir?
I'm doing just dilatation and mini Minoka stent. In cases, I've done few cases by extirpation of the punctal area where we are not able to do the punctal dilatation, where we are not able to enter the punctum. You do just remove with a lacrimal papillae and do the probing or ensure whether canalicular area is patent by doing syringing and then put a mini Minoka stent.
Thank you. Now we'd like to invite for the last talk Mr. Ravikant Sharma. He will be telling us what's new in ocular rescue.
Ravikant Sharma, are you there? Mr. Ravikant Sharma? Yeah, you can start your presentation. Kindly unmute yourself also.
Yeah, my this screen is shared. My
No, not
screen is
as yet.
visible, ma'am.
No.
Unmute on this. Oh, I wasn't getting it.
Is it visible, ma'am?
No, you have to share your screen.
I have already shared my screen. I'm not able to share my screen. I'm sorry, I don't know how to do it.
So you need to press the share screen icon.
Yeah, it is already pressed, ma'am. And it is showing some basic, advanced, and files, something like that.
Okay, just go to just click on the basic. Is there any from one from DOS?
Nobody from the DOS side. Your presentation is on your desktop, I hope?
Yeah, it is on desktop,
It
ma'am.
is open on the desktop. So once you press the share screen option, I think your presentation should be visible and you should click on that.
I don't know what is happening.
So Vikant, there's a green button at the bottom.
Yes,
Share
sir.
screen.
Sir, I
Press on
already
it.
pressed it.
You'll have a window open in which your open presentation, PowerPoint presentation will be seen minimized. You click on it and it will share. Have you opened the PowerPoint presentation?
Yes, sir. My presentation is there.
Okay.
There is a problem actually. It is showing me four windows like desktop one, whiteboard, iPhone via AirPlay.
Correct. In which your PowerPoint, if it is open, will also be shown.
Okay.
Click on the
I'll do
PowerPoint. Yeah. You'll find 5-6 windows. All open windows will be shown there, but you have to click on the PowerPoint window that is open.
Okay, sir. It is on this.
You have to open your presentation on the desktop first.
Correct.
Yeah.
Keep your PowerPoint open, then go to Zoom, share screen. You'll find a window with 4-5 open windows. Click on PowerPoint window.
So I got I opened my presentation and desktop one, whiteboard, iPhone, this stuff to do.
हाँ जी सर, iPhone और whiteboard के नीचे अगर आपकी PowerPoint खुली हुई है, so you can just click on that.
That is open, ma'am. Already open.
Then double click on
presentation
that.
open है.
Double click on that.
But उसमें show नहीं हो रहा है, ma'am. Presentation तो open है, but वो show नहीं हो रहा है. I don't know how. It is again asking me like you want to share, Zoom want to ask something or something like that. I don't know how to share.
So do you want to mail your presentation to me? I'll share it from here if you're comfortable.
Yeah, ma'am. Okay, I can do it.
I've just shared my email ID on your chat box. I'll share it from you. Yeah.
Please. Thank you.
Yeah.
In the meantime, good evening, Dr. Santosh sir. It's such a
evening. How are
pleasure to have you here. Sir, I
How are
just
you?
had a query, like in certain cases of punctal stenosis, I have seen at times, once I had seen that even the dimple of the punctum is not visible. So, sir, what do you do that? Just a guesswork or how do you manage? Sir, absolutely no visibility of any papillae or anything.
Right. So if the punctal papilla is flat or if it's grade 4 or 5 punctal stenosis, then you can do what is called a canalicular cut down. You know exactly where the punctum is because pars ciliaris and pars lacrimalis. Pars ciliaris has lashes. Where the lashes end within a millimeter or 2 is the puncta. So you can make a posterior lamellar cut down in that area, identify the cut end of the lower canaliculus, and if that is visible, exteriorize it. So that will form your new punctum.
Okay, sir. Thank you, sir. Thank you so much.
Have you mailed it, sir? I have not yet received
Yeah,
it.
I'm doing it. I'm doing it. Ma'am,
Okay,
I'm sorry,
sure,
I'm doing it.
sure. No, no issues, sir. No issues.
Ma'am, did you receive it?
Just 1 second. Let me just check it. No, not yet.
I did send it actually.
Yeah,
Again, I'll send you back.
just try it again. Yeah.
Okay, again.
I haven't received it.
Some issue with your network, I think. If you have someone at home, your kids or somebody, they are much active. They might help you if you can call them. If you really want to present.
I'll just
That's
ask
the
my
only
son.
way out.
Sorry.
Yeah.
मनु, मेरा
I
स्क्रीन
haven't
शेयर नहीं हो रहा है वहाँ देखिए जरा एक बार Zoom. हाँ
It's not there in my spam also.
मुझे की नोट हाँ तो होनी है ना स्क्रीन शेयर हाँ ये है ना प्राइवेसी सिक्योरिटी एंड प्राइवेसी तो शो ही नहीं कर रहा है इसमें। क्या करूं? हर बार वही मैसेज नहीं हो रहा ना, वो एनेबल नहीं है, डिसेबल आ रहा है।
So unfortunately, I think if it's not working, we can then sum up now.
Yeah, I'm just trying in last moment. If it is done, okay. I'm really very
Yeah.
sorry to keep
No,
you
no,
waiting
there's
for.
nothing to be sorry. We are feeling bad that you've not been able to present, but point is that there's nobody there to help out.
Yeah,
The problem is staying the same.
I don't know.
Dr. Shalu, are you there?
Happening actually. I'm really.
Yeah.
Achha.
One more minute to Mr. Ravikant. Dr. Nipur, have you
Yeah,
not
ma'am. I've not received it on the mail, ma'am. No. I think his network is a little.
Actually, there are two small videos in it. Maybe because of that, it is not.
There's nobody from the DOS backend also right now. So
Yeah,
it
they are not.
shows there must be inauguration and all going on.
I'll try one more time to send you by Gmail, ma'am. Please.
Yeah,
Just,
yeah.
I'll
Do you
just
want me
last
to
I'll try.
type my email
Yeah,
ID
yeah.
again? I'll just type
Yeah,
it.
yeah,
Yeah,
yeah.
one second.
Okay,
Just
ma'am.
copy
I'm
paste
sorry,
it,
I'll
okay?
just, yeah, yeah. Okay.
No
Okay.
issues. You got my ID, no? Yeah.
Yeah, I got it, ma'am. I got it.
Just copy paste it. Yeah.
Yeah, yeah. I'm just doing.
We'll just try.
It is nupurgoyal.ms@gmail.com.
Yes, yes, yes. You sent it?
Yeah, I'm just sending you. Yeah, it is uploading, ma'am.
It's uploading.
Yeah, it is 25 MB. It will be sent by Google Drive link.
Okay.
It is just uploading the file. It will be sent as a Google link to you, ma'am.
Yeah.
Will that be okay? Yeah.
Yeah, yeah, that should be okay.
It is being uploaded. Yeah, yeah. It is being uploaded. I'm really very sorry for kept you waiting for actually. I'm really very, very sorry. जल्दी से होगा.
DOS backend.
So when you're pressing on the share screen, what's coming exactly? Can you just unmute yourself? Unmute yourself.
Sir, please unmute yourself first.
Yeah, it is showing me desktop 1, whiteboard, iPhone, iPad, AirPlay, iPhone, iPad via cable, Safari unknown, mail unknown, keynote unknown, ऐसे करके आ रहा है मैम.
कीनोट में बनाया है प्रेजेंटेशन? नहीं, डेस्कटॉप का ऑप्शन आ रहा है.
हाँ, में डेस्कटॉप पे हाँ आ रहा है, लेकिन बस एक क्वेश्चन मार्क जैसा आ रहा है कुछ.
Just click on desktop, sir, once.
Actually, we are already delayed and session is waiting for us.
Do we have any session in this hall after our session, Dr. Nupur? Any idea?
Yes, I think all the panelists and speakers are already waiting in the.
I think it is too long now. We should put an end. This won't look nice. The other session will be delayed too long.
Yes, ma'am. Yes, ma'am.
So, Mr. Ravikant, we can please. We are sorry, but I think better luck next time.
Okay,
Dr.
I'm
Shalu,
really
are
very
you
sorry
there?
for it. Actually, it is.
Yes, and I think we should.
Yeah, we should wind up now because the next session has to start.
And I'm really sorry for the next session.
I'm really very sorry, ma'am. It is not happening. I don't know why. I'm so sorry for it.
Thank you, Dr. Nupur and Dr. Urmil, for staying. Thank you. Thank you, Mr. Ravikant.
It was a very nice session. Thank you, ma'am.
Thank you. Thank you to all.
Thank you. Thank you.
Hello, everybody. Good afternoon. So we move on to the next session. I welcome you all to the session on ocular oncology. Is Dr. VP Gupta there? I don't see him there. So anyways, we are much behind schedule and we already have 13 presentations. That is like, stacked up, the talks stack up to about 91 minutes and we have a 90-minute session and a keynote address. So let's start right away. I would request all the speakers to please stick to their time. The first talk would be by Dr. Santosh Honawar. He needs no introduction. Everyone knows him. He is the director of Center for Sight, Hyderabad, and the editor of Indian Journal of Ophthalmology. So, sir, please.
Is my screen seen?
Yes, sir.
Okay, I'll go ahead then.
Yes,
I thank DOS for this opportunity. I'll be speaking on retinoblastoma and their live and see. So what's really new in retinoblastoma is the evolution. It has evolved from 1900s with 85 to 98% mortality. In 2020, we have 98% survival. And when we talk about retinoblastoma, we talk about life salvage as our primary goal, followed by eye salvage and vision salvage. So how have we improved vision salvage? There are specific trends in focal therapy. We still do cryotherapy with good success, but for tumors which are located more centrally, we defer doing cryotherapy and then do TTT instead. That is one change. We have abandoned photocoagulation, which has a lot of complication and also produces a much larger scar, as you see here. Photocoagulation is no longer performed because a small tumor will end up with a large scar, and also there will be vascular occlusions and visual field defects. And we have started using transpupillary thermotherapy routinely for all small tumors, which are located anywhere in the fundus. We can reach this with an indirect ophthalmoscopy delivery system. For example, you see in TTT that the vessels that pass through the scar are classically patent and the scar is very crisp. So you can do it on top of a vessel, you can do it in the para foveal area with excellent outcome. So that's TTT. And a recent advance in TTT is ICG enhanced TTT, which acts like photodynamic therapy, where tumors which are located on avascular scars, which don't generally take up TTT because of lack of pigment background, can be treated with ICG enhancement. So that's a recent advance in the management. For selected cases, we use plaque brachytherapy, and with the notch plaque design, we can get to next to the optic nerve. As you see here, it's a macular tumor which has regressed with plaque brachytherapy. This optimizes vision because the scar that is ultimately formed is much smaller than the tumor that you began with. And the economic barriers for using plaque brachytherapy have been overcome with an indigenous plaque that is currently available. So plaque has specific indications. So in focal therapy, in terms of optimizing vision, we use transpupillary thermotherapy, and also we have selective indications for plaque brachytherapy. On the horizon is transscleral strontium irradiation, which is being tried, and also what is known as a chemoplaque to deliver chemotherapy at a high concentration specifically to the tumor by extraocular application. The second advance is chemotherapy, which has brought about a paradigm change. This was in 1996 when intravenous chemotherapy first came into vogue. Intravenous chemotherapy is extremely effective when it is given in a 3-drug protocol, either standard dose or high dose. And as you see here, the tumor which we start off with becomes a much smaller scar, a flat scar, and macular fovea is quite early in the treatment phase exposed so that the child has optimization of vision. The second principle of chemotherapy is the regression of tumor towards its source of blood supply. For example, this particular tumor is receiving blood supply from the supratemporal arcade, and you can see that the tumor has regressed towards its source of blood supply, thus freeing the fovea macula very early in the treatment cycle. So this is initially when the tumor was abutting on the foveola, and you can see after 6 cycles, the tumor has freed up foveola and the macula is very healthy for optimization of vision. So systemic chemotherapy has also helped in optimization of vision. It was the standard of care for several years, but now we have chemotherapy plus. That means that we have other forms of chemotherapy that have helped us in taking the excellent prognosis that we achieved with intravenous chemotherapy to a much better scale. This is intra-arterial chemotherapy. We get into the ophthalmic artery and deliver not 1 drug, but 3 drugs. This makes us use lesser number of cycles of intra-arterial chemotherapy, thus optimizing the financial situation, and also gives us much better success than using melphalan alone. These are the effects of intra-arterial chemotherapy, where you see the total bullous retinal detachment settles with 1 cycle of IAC, and you can see a large tumor much regressed, and the disc and macula are fairly healthy in this situation. For recurrences as well, we use secondary intra-arterial chemotherapy. This is recurrence on top of a scar. This is the recurrent area. And after 1 cycle of secondary intra-arterial chemotherapy, you can see the recurrent area is completely regressed. And we realize that IAC is most effective in group D and E retinoblastoma and also for larger recurrences. For the vitreous seeds, which were a major bugbear, now we have a new classification of not just vitreous seeds, but the entire spectrum of intraocular seeds. How do we treat them? We use intraocular or intravitreal chemotherapy for seeds that are residual following regression of the retinal tumor. These are a bunch of vitreous seeds that are residual, and after melphalan 3 injections, they're gone. But we started realizing that melphalan has complications such as retinal pigment epithelial changes that we see maybe in the macular area, thus reducing visual potential. It also causes uveitis and cataract and needs weekly injections, that's adding to logistical complexity. Thus, we have shifted over to topotecan. Topotecan given 30 microgram 3 weekly, not weekly, can regress vitreous seeds. 2 or 3 sessions of topotecan is all that is required. This case has a bunch of vitreous seeds gone after 2 doses of intravitreal topotecan, and a similar result here. When there is a refractory situation where multiple injections of topotecan have not helped, we combine it with low-dose melphalan. This was one example where the vitreous seeds have become less following topotecan. You can see after 6 injections of topotecan, vitreous seeds have become much less. but there are still a bunch of residual seeds which went away after we combined it with melphalan. But please note that there are RP changes in this area. So melphalan does cause retinal pigment epithelial changes and should be used only when the seeds are refractory with topotecan. Now, intraocular chemotherapy currently has extended indications. We are now using intracameral and intravitreal chemotherapy for anterior chamber seeds. Eyes which were earlier enucleated can now be salvaged by intracameral and intravitreal chemotherapy. This was a patient where there are anterior chamber seeds which are gone following this form of treatment. When there is infiltrative anterior chamber seeds where there is ciliary body extension, trabecular meshwork extension, and also anterior chamber seeds, we use intracameral or intravitreal chemotherapy in addition to plaque brachytherapy for the ciliary body component. You can see that the ciliary body component has regressed as well as the intraocular seeds. One more extended indication for intravitreal chemotherapy is combination of subretinal and diffuse vitreous seeds. Like in this patient, there are vitreous seeds as well as subretinal seeds, both of which regress following intravitreal chemotherapy. This is a clear example where this extensive diffuse subretinal seeds went away following just intravitreal chemotherapy. We didn't have to do laser. For example, if we had to do laser, we had to treat all this area resulting in a scar. But now since we have not used laser at all, just used intravitreal chemotherapy, the child has much better looking retina and optimized vision. So retinoblastoma seeds are finally conquered. For life salvage, we have a better form of enucleation, much safer technique, and also we realized that the optic nerve stump longer the better, at least 15 millimeter, and also the high risk factors following enucleation, such as ciliary body invasion, major choroidal invasion more than 3 millimeter in diameter and thickness, and optic nerve invasion beyond the lamina cribrosa are all risk factors for metastasis. And these patients, we provide post-enucleation adjuvant chemotherapy. The risk of metastasis can be reduced from 24% when you don't give adjuvant therapy to 4% when you do give adjuvant chemotherapy. Thus, just by this particular modality alone, we have 20% more children surviving. So enucleation is not the end. In orbital retinoblastoma, we have either clinically diagnosed orbital retinoblastoma or radiologically diagnosed, as you see here on MRI scan, where mortality used to be about 70%. But with multimodal therapy, where we begin with neoadjuvant high-dose chemotherapy, and after the orbital component reduces and the eye becomes thiazical, we perform an enucleation with a long optic nerve stump, then give adjuvant radiation and adjuvant chemotherapy as well. So this helps even in patients who have optic nerve extension right up to the orbital apex. You can see normalized caliber of the optic nerve following treatment, and also anterior intracranial extension of the cavernous sinus, which is resolved following neoadjuvant chemotherapy, and what is left is at the superior orbital fissure amenable to stereotactic radiation. These children achieve excellent cosmesis without having to perform orbital exentration. So orbital RB also now has a cure. With all these added together, survival has scaled up to 95% with protocol-based management. So looking at the evolution in terms of life salvage, when we did external beam radiation and enucleation, we had 40 to 50% life salvage. With intravenous chemotherapy and adjuvant therapy, it scaled up to 80 to 90%. And now with new adjuvant chemotherapy, and also multimodal treatment, now we have about 95 to 98% life salvage. In eye salvage, we have everything put together in 2010 onwards, we have 85 to 90% eye salvage in retinoblastoma, and vision salvage has also improved to 85 to 90% with the current improvements in the management. So in conclusion, I would say that retinoblastoma management is complex, but individualized management using protocol-based techniques does help salvage life, eye, and vision. Thank you so much.
Thank you, sir. That was an excellent overview in such a short duration. You covered all aspects. If anybody has any questions to ask. Okay, so can we proceed to the next speaker then? Dr. Aditi is there. Yeah, so Dr. Aditi will be talking on OSSN diagnostic dilemmas. She is working at Batra Hospital, New Delhi currently. Dr. Aditi, you can start.
Yes, sir. Are my slides visible?
Yes.
Okay, so thank you so much for the opportunity. Good evening to all the dignitaries. Without much delay, so I'm Dr. Aditi, and I'll be speaking on ocular surface squamous neoplasia and diagnostic dilemmas. So these will be all from the point of view of a cornea consultant. So we all know it is an umbrella term for benign intraepithelial neoplastic lesions and invasive squamous cell carcinoma of conjunctiva and cornea. Very frequently, we see the patients who have association with risk factors like old age, males more than female, HPV, HIV, xeroderma pigmentosa, and systemic immunosuppression. So various clinical presentations you come to our clinics with different site involvement, whether it can be just conjunctival, corneal, limbal, or a more diffuse site presentation. Morphology-based classifications are there, where it either can be gelatinous, leukoplakic, a papillomatous form, or a more combined form as well. So now the more interesting ones are the corneal ones, where sometimes the diagnosis is missed. Sometimes they're treated as scars, neovascularization, limbal stem cell deficiencies. These are the cases which require a more active and keen eye for early treatment. Like here we can see translucent sheet on the cornea can be seen along with vascularization, which was diagnosed as a neovascular conjunctivalization in previous cases. Scleral invasion and orbital involvement are the more dreadful complicated cases. So for diagnosis, clinical examination with rose Bengal staining, gonioscopy and lymph node check is a must. Here we can see on rose Bengal staining, there's a staining pattern can be seen on green filter, which is very frequently used in cornea clinics to see the involvement. Impression cytology is a very easy and handy tool. Very easily we can take up these papers, nitrocellulose papers, and get an idea before planning any excision or further imaging. With more extensive involvement, we do need an ultrabio microscopy, ASOCT, for when we suspect a lid or more fornical involvement or orbital involvement. We do take oculoplasty consult, where they've advise radio imaging in form of CT or MRI orbit. Histopathology is definitive for diagnosis. Others are HIV screening and oncologist consult. So impression cytology, it is based, the diagnostic criteria is based on race NC ratio and nuclear pleomorphism, but it has a pitfall. Sometimes it is not very much conclusive in keratinized lesions, and they do suggest for biopsy. Histopathology classification, no matter what the morphology looks like, it is a definitive diagnosis. So coming on to the cases, this is a 50-year-old female who was referred to a cornea clinic with recurrent blepharoconjunctivitis. Now the thing was, it was a unilateral blepharoconjunctivitis being treated over the years. So if we can have a look over the superior conjunctiva, we can see congestion. It can show corneal involvement, which took rose Bengal positive stain. On eversion of the lid, we could see abnormal lid, upper tarsal conjunctiva, which was not seen in the other eye. We took an impression cytology where it suggested of nuclear atypia. And along with our oculoplasty consultant, we went ahead with excision. And it came out to be a sebaceous cell carcinoma. Here we can see on HP, intraepithelial spread of atypical large cells. So sebaceous cell carcinoma is one, especially when it is not involving the lid, can be misdiagnosed as a recurrent blepharoconjunctivitis and missed. Coming on to the next case. So he is a 60-year-old male gentleman referred to our dry eye clinics post-cataract surgery. He had undergone multiple IPL sessions, steroids for this unilateral congestion, again unilateral. Here we can see inferior congestion, and if you can see, there are stippled staining on rose Bengal staining. And on the cornea as well, we could see a very thin translucent pattern, which could be suggestive of a corneal involvement as well. The impression cytology was inconclusive in this case, but showed a little bit of pleomorphism and so we went ahead with one cycle of mitomycin C, and here is the result. The patient completely resolved, the lesion completely resolved with just one cycle of mitomycin C. The third case, a 24-year-old male being treated over the years for VKC followed by chronic allergy after 20, and loads of lubricants and on topical steroids. So here we could see that there was something like a feeder vessel. There was minimal stippling on rose Bengal. We could see some cystic lesions, which could be easily misdiagnosed as limbal activity or limbal involvement seen in VKC cases. We went ahead with a UBM just to see the hello, am I audible? We went ahead with the UBM, followed by an excision where the HP was suggestive of moderate dysplasia. Coming on to the fourth case, here this 56-year-old female referred for a recurrent pterygium after 2 years of pterygium surgery. We thought it was not just a recurrence and could have been a misdiagnosed OSS in the first place, followed by a recurrence. So we went ahead with a wide excision with cryo and amniotic membrane, and on histopathology, CIN was detected. This is the patient doing well after 1 year of surgery with no recurrence. Case 5, this patient, a 50-year-old female diagnosed as OSSN elsewhere, came to us with feeder vessels, but we could not find any rose Bengal staining. The impression cytology was inconclusive, so we went ahead with excision. So now the histopathology was suggestive of hyperplastic epithelium with minimal inflammation, not suggestive of OSSN, but of granuloma. We probed a lot for our questions, and we got to know that she had undergone some surface surgery in her younger age, but did not have any detailed reports. Case 6, a 40-year-old female, status was bone marrow transplant, referred for severe dry eye disease, again on multiple lubricants and steroids. Here on the unilateral, we could see a lesion. We went ahead with an ultrasound biomicroscopy for the same. Impression cytology showed pleomorphism and raised NC ratio. We went ahead with 1 cycle of MMC, and this is a follow-up after 3 months with no recurrence. Case 7 is a 78-year-old male, status post-renal transplant, referred to us with diagnosis of SCC without any histopathology reports. As there was a lot of lid involvement, our oculoplasty consultant was referred. They went ahead with exentration, and the histopathology was suggestive of mucoepidermoid carcinoma, not SCC, with both mucoid and squamoid components. The 8th case, a 35-year-old male who underwent OSSN surgery, a wide excision with cryo, amniotic membrane, and post-op MMC, was doing well. But after 2 years, for our follow-up, we could see there was a small lesion at the same site. We went ahead with excision along with cryo, amniotic membrane, and MMC, and there is no recurrence till 1 year. So recurrence is a very common thing, and we have to counsel these patients for follow-ups, and we have to check up the eye in the subsequent visit as well. Last but not the least, this is a patient who came to us during the COVID time with a bilateral masses. He had come for cough, and from there they were referred to the eye clinic for the masses. This young male was HIV positive. Unfortunately, this patient was lost to follow-up, did not come back to us when we suggested of an excision. So the take-home message is high degree of clinical suspicion is required in atypical cases. Tailored investigations are needed. Excision and HP analysis is definitive. Early diagnosis and with new adjuvant treatment, we get best results in such cases. Multidisciplinary approach to involve the oculoplasty and oncologist specialties as well. Patient counseling for a regular follow-up is must. These are the references. So I would like to thank my department in BHMRC, my alma mater, Shankar Netralaya, Chennai, Dr. KK sir, for all the wonderful diagnosis of histopathology analysis, my department in Shankar Netralaya, Kolkata, and my oculoplasty counterpart, Dr. Shahid Alam and Dr. Neha Srirao Mehta, oncology department, TMC, where we send our referrals, and definitely my cornea fellows and DNBs. Thank you so much for being a patient audience.
Thank you, Dr. Aditi. It was a very nice presentation, a lot of interesting cases, and I'm sure each of these cases can be discussed at length for a long time. But since we are running really short of time, we'll have to move to the next speaker. Dr. Usha has some other commitment shortly, so she would be talking first. And her topic is really interesting, something which we are facing in current times. It's about Orbit and COVID-19. Dr. Usha ma'am, please. Dr. Usha is HOD of Oculoplasty department at PGI Chandigarh.
I'm just trying to, yes.
Slide share is not working, ma'am?
Just a second. I'm just trying. I'm unable to enlarge the screen.
Okay, we can see like this only then in that case.
Usha, go to slideshow.
Slideshow.
Click on slideshow at the bottom.
Just. I'm not unable to get it.
Bottom of your screen, there is that icon, slideshow icon. Just click on it.
No, there's something has happened. I want to enlarge the zoom on my screen, but that's not coming.
We are able to see your slides, but not in the slideshow format.
Oh, you're seeing my slides, are you?
We are seeing your slides. If you just press on the slideshow, then it may enlarge.
Slideshow.
Yeah, bottom of the screen, that screen-shaped icon. Next to minus and plus 58%, we are able to see. Next to that, left to that is a screen icon.
Towards the bottom.
No, the zoom window has disappeared from my thing.
That's okay. We can see your slides. You can just go to the slide share if you slideshow. Sorry.
Can I do a slideshow?
Yeah.
Yeah. From the please.
Now can you see my slides?
Yeah, we can see.
Right.
Is it visible now?
Perfect.
Okay. Good evening, everybody. I'm Usha from Chandigarh, and I'd like to present some orbital cases which I've been managing during this COVID times. And as we know that COVID-19 crisis has brought in a lot of challenges in the delivery of ophthalmic care. And the COVID-19 pandemic has affected healthcare system, and it has resulted in disrupted care for patients. And delivering medical care during the COVID-19 crisis has been challenging given the competing risk of loss of vision in patients with ocular conditions where timely intervention is crucial. And there is a likely higher lethality of COVID-19 in immunocompromised patients. Inadequate supplies of PPE for health workers and limited hospital capacity, including ICUs, and lack of point of care testing and seroprevalence data further complicate the care delivery. And also there has been issue at a big, PGI has been in the midst of all these, been actively involved in this COVID care, and it has, there's been a reduced personnel in the laboratories as they have been put on COVID testing. And this has led to further delay in reporting of non-COVID patients' reports. So the guidelines which have been given for ophthalmic malignancies and procedure, that we need to defer all benign cases and defer all low risk and low grade malignant tumors. Benign cases would be basal cell carcinoma and others tumors like lid tumors. And high risk or high grade malignancy should be prioritized. And among them comes the melanoma, retinoblastoma, rhabdomyosarcoma, and choroidal metastasis. And retinoblastoma and orbital rhabdomyosarcoma are of the highest risk, and surgery should be prioritized as delay is sight and life-threatening. And for other orbital cases where there is a risk of blindness, orbital decompression has to be prioritized. And here I would like to share some of my cases. Here's a 10-year-old child. And she had been having proptosis for 5 years, and we could palpate a soft compressible mass, which was mildly tender, and she had a recent increase for the last 2 months. So when we did the CT angio, it was a mildly enhancing lesion with very thin arterial feeder vessels from the ophthalmic artery. And here, as we saw, we took her up for surgery. and we had to cut the superior oblique tendon. And here we see the mass, and this we use a cryo extraction method, and it did take some of our efforts because the pupil was dilating and it was adherent to the surrounding structures, and we had to be extremely careful and very slow while proceeding. And we got the histopath, and this is a patient in the post-op period, and she has a resultant of enophthalmos. The vision was preserved to 6.6, and the histopathology showed us the congested cavernous spaces where intervening lymph-filled lymphatic spaces and lymphoid aggregates and lymphoid follicles, and this was all suggestive of lymphaticovenous malformation. Now here is another patient with a vascular lesion, and here we can see he's just 52-year-old male, and he had a acute proptosis for 7 days, and the vision was 6/12, and he had RAPD in this right eye. And we can see this mass lesion, it is lobulated and it's enveloping the optic nerve. And mild to moderate enhancement. So we took up this patient, and we can see for surgery, we can see that all these hemorrhagic areas, and we had done a cryo extraction. This again was difficult as we had to cut the LPS muscle to reach to this tumor. And the histopathology was a large muscularized dilated vessel wall lined by flattened endothelium, moderate and lymphoplasmacytic cell infiltrate, fibroblastic proliferation, and there were extensive areas of organized thrombosis along with hemorrhage. And these were all features of AV malformation, as there was a muscularized dilated vessel. Here is another patient. He had no light perception for more than 10 years. He gave history of CRO for 10 years, but the proptosis had increased for last 7 months, and he had an outward deviation. He was also a patient of heart, patient who had stenting done and on dual antiplatelets. So we took up this patient for surgery. And as we can see in this imaging, there is a tail-like extension behind. So we were not sure it's a nerve or it's the optic nerve. We could not see the optic nerve in any of the frames. Probably it was atrophic. We didn't, in the fundus, we did not see any shunt vessels, probably because he already had a CRAO. So we could not see. So we took him up for surgery. And as we can see, we tried removing. And when we came, it was this, we can see that the optic nerve is being cut. We had to cut this optic nerve. And this histopathology, all this tissue has come out from within this tumor, and we could remove it completely. Though of course this patient didn't have vision. The diagnosis was a meningioma. This meningioma is very rare in this middle-aged male patient. It's supposed to be typical in middle-aged female patients. And this is optic nerve sheath meningioma, and the tumor was showing lobulated growth pattern with prominent whorl formation. The cells display syncytium-like appearance due to poorly defined cell borders, and the tumor was abutting the optic nerve but not invading it. So I would like to come to my last patient over here. This is a young child, and this child he came to us with proptosis 1 month, and he did not give any history of URI. History of treatment for fever and similar swelling for last 5 months. And he had shown to locally, and he had been given a 7-day course of IV antibiotics, and he had responded. However, we just have this photograph of this patient. This is the swelling which he had 5 months ago. And when we went ahead and did a incisional biopsy, this imaging, as you can see the imaging, the sinuses are relatively free. There's no opacification in the sinuses. This mass is heterogeneous. It's indenting the globe. We took him up for fluid aspiration. Malignant cytology was ordered, and we also sent the sample for histopathological evaluation. The gram stain, bacterial culture sensitivity, KOH, cytology for malignant cells show inflammatory cells, but no malignant cells were seen in that fluid. So we were still awaiting the histopath report. So when we got this, got the histopathology, it reported as rhabdomyosarcoma, and we can see that we are removing it. And here we had to cut again, superior oblique tendon had to be cut and resutured. And we saw this mass was adherent to the superior oblique muscle. There will be a portion where you can see the muscle, this entire mass, which has a very irregular surface and the nerve on the surface. This is the superior oblique. And it was adherent to the fat, which was next to the optic nerve. And every time we would try to tug on it, the pupil would dilate. So we had to be extremely careful. We had to incise it between the optic nerve sheath and the mass. So that meant it leaving a little bit of residual tissue there. And it was also adherent to the superior oblique muscle. So we had to incise. And this was the embryonal type. And this is very rare in a very small child, which this child is less than 1 year old. And in small children, it is very aggressive. And here we can see the optic nerve, which is there. So we had to leave a residual tissue, and there was a microscopic residual tissue. So that was group 2. And the patient is still under investigations and staging investigations. But as far as the prognosis is considered in group 2, there's if with the radiation, the prognosis and survival is about 94%. And this case had presented like an inflammation, but it was a malignant tumor which had undergone necrosis. With this, I would like to thank you and conclude by saying that we have been seeing a lot of challenging cases, and I've been able to present only 4 cases, but we have been seeing quite a few of them. And they have produced a challenge in diagnosis and imaging and getting those special investigations done and getting pathology. And because of the short staff, we had to be waiting. And of course, in the rhabdo patient, a lot of time had been lost from the patient side. We speeded up everything. And with this, I would like to thank everyone.
Thank you, ma'am. Really challenging cases, really tough cases, all of which you showed. Just one question. In the first case that you showed, did you consider sclerotherapy in that venolymphatic malformation?
No, we did not consider because as we can see, this is it had one is a thin arterial feeder. We didn't want to go near that. We didn't want to. Also, it was very well circumscribed and very low. Only very few areas which are hyper intense, and it was like a heterogeneous. And our radiologist said it's you could go ahead safely as it wasn't very fresh, or where you can. Large cystic spaces were there, so you could go ahead. So we decided that yes, it was, and when we palpated, it was pretty firm and a little bit compression, but overall it was very firm because she has been having it for last 5 years. So we finally took a decision to go ahead and excise this. As you can see, the radiology, there are not many big cavernous spaces inside that. So we did not consider.
Thank you. That was really interesting. Any other questions or comments for Dr. Usha? Okay. So we move forward to the next topic.
Thank you so much.
Thank you, ma'am. So we've received another request. Dr. Subina also has another commitment shortly. So is Dr. Subina there?
Yes, sir. Yes, sir.
Can you share your screen, ma'am?
Sure. Can you see my screen, sir?
Yes.
Yeah. So can you hear me also? Yes.
Yes.
Thank you, sir. At the outset, I would like to thank Delhi Ophthalmological Society for giving me this opportunity. I would be talking about vision-saving modalities in intraocular tumors. As Dr. Santosh sir said, that the management has really undergone a paradigm shift from life-saving modalities. Now we are talking about saving vision of these patients. The vision-saving modalities are the focal therapies for small tumors. They are cryotherapy, transpupillary thermotherapy, photodynamic therapy, plaque brachytherapy, that is localized radiation. And sometimes you have to give chemotherapy to shrink the size of the tumor, which could be intravenous, which could be intraarterial, intravitreal, or periocular. Cryotherapy we have been doing since a long time for all pre-equatorial tumors less than 3 millimeter in size, and triple freeze thaw technique is what we do. Tumor destruction is usually achieved in 1 or 2 sessions, which are spread over a period of 1 month. The main mechanism of action is ischemia. Ice crystal formation is there due to intracellular supercooled water flowing out and cellular dehydration. There's denaturation of lipid proteins and cellular apoptosis due to toxic concentration of solutes inside the eye. This is a case of peripheral retinal capillary hemangioma. This was in fact von Hippel-Lindau disease. And we went ahead with cryotherapy of the peripheral tumors, and the tumors which were post-equatorial underwent triple T therapy. The laser treatment for intraocular tumors can be as photodynamic therapy or long pulse transpupillary thermotherapy. This is the photochemical is the mechanism of action in PDT, and photothermal is the mechanism of action in triple T therapy. In PDT, we are injecting the inactive form of the dye, which is administered systemically, and it is distributed throughout the body. But then we give localized exposure to light of the tumor. So there's active, the inactive drug changes into active drug, and by the singlet oxygen production, we have destruction of the tumor. This is a case of circumscribed choroidal hemangioma underwent PDT. The patient had come with drop-in vision, and there was a detachment, subretinal detachment, which could be seen in the macular area and over the tumor. And this is what we have 6 weeks down the line. There's resolution and improvement in vision. Brachytherapy is localized radiotherapy. Here we use radiological investigations to do 3D planning. And then with the, we stick the, it could be the iodine seeds or iridium seeds or ruthenium. We stick, and accordingly we give gamma radiation or beta radiation. After localizing the tumor on the sclera, we put these plaques, and they are there for a limited time as is calculated by the treatment planning system. And then we have, in fact, we are using iodine 125 because this has penetration till 10 millimeters. So this helps us to treat the larger tumors as our, well, like we have most of the times the larger patients presenting with larger tumors. This is a case who presented to us with choroidal melanoma and vitreous hemorrhage. The patient was taken up for brachytherapy, and after brachytherapy, there's shrinkage in tumor size and pars plana vitrectomy for vitreous hemorrhage. There was, in fact, almost 50% decrease in tumor size at 6 months follow-up. This patient is now on 15 months follow-up, maintaining vision of 20/40 and no mets. Sometimes you combine the plaque therapy with the transpupillary thermotherapy, which is also popularly called sandwich technique. So this is one such patient of choroidal melanoma, and this is what we have. The patient at 9 months follow-up without metastasis has vision of 20/100. Now, intravenous chemotherapy, as has already been highlighted, has been used extensively in cases of retinoblastoma, vincristine, etoposide, carboplatin, but then due to innumerable systemic side effects, we are shifting to localized kind of intraarterial, intravitreal, or subtenon's chemotherapy. Intraarterial chemotherapy we deliver through the fluoroscopic guided microcatheter into the ostium of ophthalmic artery. And this provides eye salvage in group D and group E retinoblastoma. Sometimes it could be as lucky as this. This was in fact treated by Dr. Shields, and we reported this also. This is after 6 cycles of chemotherapy, like Sir said, the tumor shrinks towards the its blood supply. So in fact, the macula is clear of the tumor. This group E retinoblastoma has got the vision of 20/20 now, maintaining more than 5 years follow-up. Sometimes it's always a multimodality treatment which is required in retinoblastoma. So this patient presents with vitreous seedlings and retinoblastoma. This is after 6 cycles of chemotherapy. You see that there's decrease in the tumor size. And then we, in fact, did almost practically everything in this. We did brachytherapy, we did intra-arterial chemotherapy, even intravitreal topotecan to give us a vision of 6/24. And she's still under follow-up with us. So it's a lifelong follow-up. This patient presents with vitreous seedlings and retinoblastoma. undergo 6 cycles of chemotherapy. And after that, the vitreous seedings were still persisting. So we went ahead with topotecan intravitreal therapy. But this is the first case report for case report of drug reaction after second injection of topotecan, which has been reported. Unfortunately, she developed corneal haze also. So through the haze, we are seeing there's definitely reduction in the size of vitreous seeding size. But this patient through hazy cornea maintains vision of 20/100. So you should, the follow-up has to be there, and you should be prepared for these kind of adverse reactions. You must time your treatment. This is a case of choroidal osteoma. When he first came to us, he was referred for PDT. So we defer doing PDT in this case, because if you do for subfoveal, you do PDT, then this would lead to decalcification, in fact, drop in vision. This patient was offered anti-VEGF injections. After 2 injections, there's absolutely no decrease in the size of serous detachment. The patient was asked to maintain follow-up with us. This is at 2 years follow-up. He comes back with sudden drop in vision, and there is development of choroidal neovascular membrane. This is at this time we re-injected with anti-VEGF agent. This is after 2 injections of anti-VEGF. The patient gets, the first time he gets vision of 20/30, and there's complete resolution of serous detachment. So one lesson learned here was that serous detachment does not improve in absence of CNVM if you're giving anti-VEGF, but if you have CNVM and you give anti-VEGF, it seems to work. Summarizing, early recognition and treatment helps us to preserve vision in patients with intraocular tumors. Focal treatment and chemotherapy are promising modalities. Multimodality and multidisciplinary approach may be required, and lifelong follow-up is a must in these cases. Thank you very much.
Very interesting presentation, Dr. Subina. You showed a lot of newer techniques and therapies being used these days. Nowadays, are you getting a PTT dye there? Because there was some shortage of PTT dye some time back.
This was the last case we did. After that, we have been unable to procure the dye, so it's stopped.
That's a problem now. Is Dr. VP Gupta there? Dr. VP Gupta, sir, are you there? No, I don't see. Okay. Any questions or comments for Dr. Subina from the panelists? So can we move forward? I'd like to invite Dr. Sunil Ganekal on a very interesting and currently relevant and subject, that's OCT and OCT angio in intraocular tumors.
Good evening, sir. Thanks for the opportunity to present in the DOS conference. Can I have my presentation, please? Hello everyone, today I'll be speaking to you regarding the OCT and OCT of intraocular tumors. The OCT basically helps in detecting the structural changes, diagnosing and planning the treatment planning and monitoring the response to treatment. The tumors which cannot be picked up on ultrasonography can be picked up on OCT. OCT is a non-invasive imaging which helps in the imaging the retinal and choroidal vasculature, and especially helps in planning the imaging the posterior pole tumors. Let me talk about the choroidal tumors. First is the choroidal nevus. Both anterior and posterior margins are well made out. There is a gradual transition from hyperreflectivity to the hyporeflectivity. There is a loss of choriocapillaries and multiple expressions of the RPE can be noted. On octa, there is a loss of choriocapillaries noted. Even the CNVM secondary to choroidal nevus can be picked up. The melanomas, sometimes small melanomas are difficult to differentiate from nevi, but SRF detected on OCT is a significant metastatic risk factor. Melanomas both shows an active pattern, OCT pattern, as well as a chronic pattern, which is could be either the active and the tumor can be dormant or inactive. In a dormant tumor, one can see retinal thinning, intraretinal cysts, and RPE thickening. You can see clearly there is an RPE thickening with the thickening of the outer retinal layers and the dome-shaped elevation of the choroid. There are certain limitations in large melanomas. Sometimes it's difficult to image the retina. The choroidal melanoma shows a vascular network inside the tumors. In fact, you can see that you can grade the radiation retinopathy post-brachytherapy into mild, moderate, and severe, as shown in this picture. Peripapillary circulation can be picked up pre and post treatment in melanomas. In choroidal metastasis, the multiple nodular elevations of thickening are noted at the level of the RP with RP detachments. The fluid collections in the retina, the hyperreflective deposits within the detachments indicates the tumor cells. The anterior choroidal reflectivity is variable. On OCTA, choroidal metastasis does not show any blood flow inside the lesion. The choroidal hemangioma, changes noted are subretinal fluid, retinal edema can be seen, retinoschisis, and the anterior surface is usually hyperreflective. The active leakage in a patient with a choroidal hemangioma shows a dome-shaped elevation of the posterior border that could be associated with schisis and intraretinal changes as shown here. Even response to treatment can be picked up. The active tumors on an OCTA, the active tumors, that is mainly the choroidal hemangioma, shows a club-like appearance in the deeper choroidal slabs. Signal voids are noted in the dormant tumors. So it can be used as a screening tool also when monitoring the response to treatment. In a diffuse hemangioma, on an OCTA, you can see a choroidal vessels are arranged like a fine threads. The pre and post laser treatment, you can see a laser-induced damage to the overlying choriocapillaries can be picked up. Pre and post PDT also, you can see that there's a vaso-occlusive effect secondary to PDT, right, as shown in the right picture. The choroidal osteoma is another tumor where there will be replacement of normal choriocapillaries with the dense hyperreflective mass. You can see a scalloped posterior borders with an adjacent hyperreflective anterior space in the retina. The overlying neurosensor retina is thinned out. The choroidal osteoma, you can see a fine vascular network inside the tumor. Even the CNVM secondary to choroidal osteoma can be picked up as a fine vascular network on OCTA. There could be an association of focal choroidal excavation with CNVM in choroidal osteoma, which is very well demonstrated in this OCT. Leukemic choroidopathy is another entity where there is diffuse infiltration or thickening of the choroid, which is very well picked up on OCT. Another entity is a common tumor is a lymphoma, which could be either vitreoretinal lymphoma or uveal lymphoma. In a vitreoretinal lymphoma, you can see a dome-shaped elevation of the RP, nodular RP irregularity associated with either cystoid macular edema and subretinal fluid. In uveal lymphoma, you can see a regular intermittent placoid choroidal thickening with loss of choriocapillaries. Overlying RP and retina are unaffected. The pre and post treatment in a primary intraocular lymphoma, in an ED enhanced depth imaging, we can see a decreased interstitial areas compared to the luminal areas. Now coming on to the retinal tumors, the pigmented tumor, that is CHRP, mainly shows as a thinning of the overlaid retina, loss of photoreceptor, posterior shadowing of the choroid in the pigmented region, and light transmission in the lacunar areas. The next is a combined hematoma of the retina and retinal pigment deposition. Here you can see the gradual transition from normal adjacent inner retinal layers to a disorganized mass with overlying pre-retinal fibrosis. Retinoblastoma, the thickening and disorganization of the neurosensor retina is seen. The posterior shadowing can be seen due to calcification, and the SRF and the intraretinal cysts are picked up. In a small retinoblastomas localized, you can see a small anterior tumor mass, optically empty cavities, shadowing from calcification and retinal draping of the inner retinal layers. Even the vitreous seeds can be picked up in retinoblastoma. OCTA in retinoblastoma has got a limited value, but still the vascularity of the changes can be very well picked up. Retinocidal astrocytic hematoma, even a calcified tumors, you can see a disorganized inner retinal layers and the intact RPE. Posterior shadowing from calcification can be seen. A dense ERM with retraction of the adjacent normal retina is seen. In a non-calcified tumors, intact outer retinal structures or choriocapillaries will be there, and retinal traction can be seen, and a moth-eaten appearance typically representative of intratumoral cysts can be seen, and retinal and macular edema can be seen. In a hemangioma, cavernous hemangioma, there is optically clear cystic spaces within the hyperreflective mass is seen. A periretinal membrane with traction can be seen. In a hemangioblastoma, you can see a mass pushing on the retina, shadowing of the posterior layers, RP and choriocapillaries are intact. On an OCTA, you can detect a white, bright lesions in the superficial retina. Feeder vessels are much more well defined. The margins are well defined than the distinct than FFA. Fails to image the peripheral tumors. The compact vascularity of the tumors can be picked up on OCTA. Even the small tumors which are missed on clinical examination can be picked up on OCTA. Retinal vasoproliferative tumors is seen as an inner retinal disorganized mass with the posterior shadowing on OCT. Optic disc melanocytoma did not reveal any blood flow within the tumor. Coming on to the anterior segment tumors, vascular tumors, you can definitely differentiate the iris, cyst, nevus, and freckle based on the vascular pattern as shown in this picture. Even the pre and post radiation, there is a decrease in vessel density, which can be very well documented on OCTA. So OCT and OCTA are non-invasive imaging modalities for intraocular tumors, which helps in diagnosing, monitoring, as well as assessing the response to treatment. Thank you for your patient hearing. I would like to thank the organizers
Thank
for
you.
giving me the opportunity to speak
Thank
in
you. Thank you.
OSCON 2020. Thank you, one and all.
Thank you, Dr. Sunil. That was very useful. OCT and OCT angiography have come up as very useful investigative modalities in the recent past for diagnosing these intraocular tumors, and there is still a lot that we need to understand and know about these modalities. It was very useful. Thank you.
Thank you.
Any questions from the panelists? So we move forward to the next talk, that is by Dr. Nivet Lomi. He will be talking about radiation therapy in ocular tumors.
Yes, good evening. Good evening, everyone. Am I audible? My
Yes.
slide is visible?
Yes, yes.
Okay, good evening, everyone. Thank Delhi Ophthalmo Society for this opportunity. So I'll be speaking on radiation therapy in ocular tumors. So ocular radiation treatment is aimed at conserving the eye with as much useful vision as possible while eradicating any risks to life. So ionizing radiation is highly effective when administering a sufficient high dose of radiation to the tumor while minimizing the collateral damage to the adjacent tissues. So these are ionizing radiations. Basically, it is electromagnetic and particulate. So electromagnetic, we have got X-rays and gamma rays. And for particulate, we have got alpha particles, neutrons, electrons, which is further divided into beta rays. The iodides are, the active radiations are strontium 90 and ruthenium 106. And we have got protons. So radiation has been given in the ocular tumors by various routes, various techniques, that is brachytherapy and teletherapy. So in teletherapy, you have got external beam radiotherapy, where you can give in a form of electrons, gamma rays, and X-rays. So delivery of teletherapy may be in methods like a single or multiple collimated fields, 3D conformal RT, and intensified modulated radiotherapy and stereotactic radiotherapy. So in my present, I will be discussing more of the ocular plaque brachytherapy. The goal of the treatment is to deliver a curative dose to the tumor while offering the least possible radiation to normal ocular structures. So the various indication for plaque brachytherapy in ocular tumors. Now, one, you have got choroidal melanoma, you have choroidal hemangioma, retinoblastoma, and retinal vascular tumors, vasoproliferative retinal tumors, and ocular surface tumors like ocular surface squamous neoplasia and conjunctival melanoma. So regarding the dosimetry calculation, it can be calculated with treatment planning system or manually easily calculated by medical physicists. The requested information to given are the clinical diagnosis, the tumor dimensions, the apical thickness and the larger basal diameter of the tumor, the locations, measurement of the tumor distance from optic nerve and fovea, and prescribed dosage rate and clinical approval from the radiation oncologist. So basically, it's a teamwork comprising of medical physicists, radiation oncologists, the radiologists. So coming to the case, retinoblastoma, the ideal tumor for primary brachytherapy are unilateral tumors, which is ideally located anterior to the equators with apical thickness of less than 6 millimeter and basal diameter of less than 60 millimeters. So basically, it is more of a secondary treatment option for residual and recurrent tumors when the conservative treatment modalities fail to regress the tumors. For the presence of anterior segment involvement and juxtapapillary locations are exclusion criteria for brachytherapy because of the anatomically it's not possible to place the plaque on this area. So here's the case, which one eye, other eye, right eye has been enucleated for group retinoblastoma, and for the other eye, left eye, there's a recurrence after the full cycle of 12 cycle of chemotherapy. So in this patient, this is the pre-operative fundus pictures. So you see. So you see, it's a large mass involving a superior quadrant. The apical thickness is 5.8 millimeter and basal diameter is 12.1. So we go ahead with the plaque brachytherapy in these patients. So here's a small video for this particular patients. This superior conjunctival peritomy was done in this particular located area, and the superior rectus muscle here is identified and dissected, and it had to be disinserted from its origin because the tumor was just lying just beneath this area. So it was disinserted temporarily using a 60 Vicryl sutures. Here in this patient, we even disinserted the superior oblique muscle because it was just engaging the plaque. This is not really required in all the patients. Sometimes you can just place the plaque just beneath the muscle also. Here, this is dummy plaque, and then the plaque has been placed in the particular positions, and then eyelid has been marked, and the position has been confirmed using the ultrasound B scan. So you see in this ultrasound, you can find the plug just behind the tumors. So we remove that dummy plug, and then now we place the final plug using this 80 bone suture, 5080 bone suture, and the plug has been sutured and placed in the particular areas, and then the rest muscles has been secured temporarily, and the conjunctiva has been closed. So this is the post of brachytherapy after 2 months, showing a very gratifying results where there's you see the regression of the tumors. Another case with retinoblastoma, recurrent and recalcitrant case. So after brachytherapy, the tumor has been regressed. There's another case with 3-year-old boy with other eye enucleated. This eye has been recalcitrant case. Post brachytherapy 6 months, there's regression of tumors. Which patient is on follow-up now. Another case with plaque brachytherapy has been on this patient. So you can see a very good result with plaque brachytherapy on recalcitrant case also. Now coming to plaque brachytherapy in choroidal melanoma, usually for retinal tumor thickness limitation is around 6 millimeter, and for iodine 1.5 is less than 10 millimeter thickness, and the dose given is at the PEX is 70 to 80 gray. 70 to 100 gray. So the choroidal melanoma is with inferior exudative retinal detachment. Thickness is more than 0.4 millimeter. So here the plaque brachytherapy is done, and in 6 months there is regression of tumors of 7.4 to 5.1 millimeter. Another case with a large choroidal melanoma, 8.2 millimeter thickness. So here we consider for sandwich technique, where the TTT was given entirely, and this is post-op 1 year follow-up. There is regression of nearly 50% regression is there. Coming to the choroidal hemangioma, you can do in case of circumscribes, or sometimes in case of diffuse choroidal hemangioma also, where the PDT is not amenable, or the laser or cryotherapy is not amenable because of the suboverlocation or presence of extensive subretinal fluids. So in this case, we have done the plaque brachytherapy in case of choroidal hemangioma. So this is a pre and this is a post of photography. So showing a great regression of tumor, and also the subretinal fluid has been settled down. Another case with massive exudative retinal detachment. Here plaque brachytherapy is done. So now we are starting using the new plaque, that's BARC plaque from India Med plaque. Here that you see the very good result in 1 month time. So we see the massive regression of this retinal detachment from nearly touching the lens, the retinal detachment. Sometimes you can use for Weber syndrome where there is diffuse choroidal hemangioma, so you can see the good result out here too. Coming to the ocular surface tumor, you can use in case of congenital melanoma or squamous cell carcinoma. Here's case with 50-year-old male with histologically proven residual squamous cell neoplasia. This is post-treatment after 3 months. Another case is large ocular surface squamous neoplasia, where excision has been done with embedded membrane grafting was placed. And in the follow-up on the intersegmental OCT, you find there's around the residual growth is still there, which has been proven by the histopathological examination. We have to use the plug over this patient, and then this is the 1 month result, and then this is at 3 months result. So coming to the external beam radiotherapy, it can easily indicated for patients who are at risk of local recurrence or large tumors which are not amenable for brachytherapy. Earlier we use for the retinoblastoma, extraocular retinoblastoma, and also for high-risk patients where there is histopathologically high-risk features are there. The disadvantage is that it causes radiation retinopathy, optic neuropathy, cataract, dry eye, facial deformity, growth retardation, and also from secondary tumors. So there is one case with choroidal metastasis here. Patient has been considered for the EBRT in this patient because it is not amenable for plaque here. So this is showing a good result with globe salvage and the vision salvage here. So sometimes indication for the stereotactic gamma knife therapy in choroidal melanoma, which is large size, which is not amenable for brachytherapy, or mass just over the optic nerve, young and adult patient wants to go for globe sparing procedures. Here, the visual prognosis has always to be explained properly to the patient because the vision is going to go down. So this is a procedure you have to fix the frame here along with the neurosurgeon people, and taking help from neurosurgeon people. This gamma knife unit is from the All India Institute of Medical Science we have done. The eye has to be stable, so the 3 rectus muscles have been tied and secured using the inverted Mercedes logo sign. So this is the result at 6 months time. This regression of tumor is seen from apical thickness 6.5 millimeter to apical thickness 4.1 millimeter. So you find a long result of gamma knife, there is always the reduction of visual acuity is there. So you have to explain to the patient properly. It's not for the visual purpose, but for the globe salvage basically. So in conclusion, with proper care selection and experience, ocular radiation therapy has gained promising modalities for an effective eye and vision sparing alternative to enucleation for patients of ocular tumors. Thank you for kind attention.
Thank you, Dr. Lomi. Plaque is increasingly gaining relevance in management of ocular tumors, with its availability becoming better. Especially now, Dr. Honavar has also developed a plaque, locally developed plaque. So I think that is very economical, and with that coming in, the use of plaque brachytherapy for all these intraocular tumors is likely to increase further. Any questions or comments for Dr. Lomi? Okay, so we move forward. The next speaker is Dr. Siddharth Madan. Is he here?
Yes, sir, I'm there.
Dr. Siddharth would be talking about periocular granular cell carcinoma, granular cell tumor. Dr. Siddharth, please share your slides with us.
My slides are visible?
Yes, yes.
Thank you. So good evening, everyone. I'll thank DOS for giving me the opportunity to present this topic. I'll be discussing periocular granular cell tumors. So granular cell tumors are benign, rare neoplasms, which can involve any part of the body, but they are common in the head and neck region. They are mostly observed by the oral and maxillofacial surgeons and by the otorhinolaryngologist in their clinic. Orbital GCTs account for 3% of all GCTs. Granular cell tumors of the eye, orbit, ocular adnexae, they are rare, but have been described in the periorbital skin, eyelids, extraocular muscles, lacrimal sac, ciliary body, conjunctiva, and caruncle. Rarely, GCT involves oral cavity with an incidence of approximately 1 in 10 lakh population per year. So involvement of the eyes may be an extension from the neighboring structures. So this was a case in our 60-year-old male patient who presented to us in 2015 with a history of blunt trauma to his left upper cheek area and leg, which he mentioned to have happened in the Nepal earthquake, following which a progressively increasing nodular mass was noted by him over the left upper cheek. 1 year later, he presented with pain in this mass. 6 months prior to presentation to us, the skin overlying this nodule ulcerated, accompanied with blood-stained discharge from multiple overlying sinus tracts. There was accompanying redness and purulent discharge from this eye. He was a chronic smoker for 40 years and reported difficulty in chewing food. His best corrected visual acuity in the right eye was 660 as he was a phakic, and in the other eye it was 6/9. His fundus and intraocular pressures were normal. So on examination, we noted a well-circumscribed mass, which was extending from the left zygomatic area up laterally to about 4 millimeters in front of the tragus. The mass was tendered, hard in consistency, immobile. It was non-pulsatile. There was surrounding erythema of the skin. However, the temperature overlying the mass was not raised. So we presumed a differential diagnosis of a post-traumatic osteomyelitis with underlying fungal etiology, query a cold abscess with atypical tubercular or actinomycotic maxillary osteomyelitis. His X-ray of the orbit and PNS was suggestive of infective changes, and it was reported as a case of chronic osteomyelitis with left maxillary sinusitis. The pus from the sinus revealed methicillin-resistant Staphylococcus on culture. ZN staining was negative for acid-fast bacilli, and so were the fungal elements on KOH. FNAC was performed from the enlarged preauricular and submandibular lymph nodes, which demonstrated reactive lymphadenitis. So a proliferative growth was observed by a maxillofacial surgeon. So we sought an opinion because nothing was coming out positive. So at this point of time, a growth was observed by the dental surgeon in the left upper alveolar retromolar region in relation to the mandible. And this growth was extending up to the midline and communicating with the external growth. So we performed a CT scan, which showed a large, ill-defined, heterogeneously enhancing soft tissue infiltrating and bone eroding mass lesion, which was destroying the entire lateral orbital wall, lateral half of the floor of the orbit, with extensions into the maxillary sinus and left extraconal space of the orbit. Greater wing of sphenoid, zygomatic arch, squamous part of the temporal bone, walls of the maxillary sinus, conoid process of mandible. So the surrounding bones were all eroded and involved. A diagnostic workup was done to rule out focus of malignancy elsewhere in the body, and this was unremarkable. A possibility of stage 4 maxillary sinus carcinoma could not be denied. The patient was admitted and was obviously on a course of IV antibiotics, but this was not showing any significant response. Sputum testing for AFB was unremarkable. So this is the picture after 10 days of IV antibiotics. The lesion remained the same. So on histopathological examination of the sinus edge biopsy, it revealed a chronic inflammatory cell infiltrate without any granulomas or evidence of malignancy. So we performed a biopsy from the left retromolar region, and this showed sheets and cords of multiple polygonal, almost similarly appearing polygonal cells, which had which are prominent nucleoli. There was abundant granular eosinophilic cytoplasm, which was present in all these cells, and this cytoplasm was positive on periodic acid staining. So it was PAS positive, and there was accompanying pseudoepitheliomatous hyperplasia of the overlying epithelium, as we can see in the figure 3b. Immunohistochemical staining was done. It was CD68 and S100 positive for the large cells. Neuron-specific enolase was weakly positive. However, P53, Ki67, and epithelial surface markers like epithelial markers for like EMA and chromogranin, these markers were all negative. So based on the Farnberg criteria for histopathological categorization of GCT, which constitutes 6 criteria, based on the presence of necrosis, vesicular nuclei, spindling, increased mitotic activity, which should be more than 2 mitosis per high power field. But now the latest studies are showing that if the mitosis is more than 5 mitosis per high power field, that is considered significant. Cells showing high NC ratio and pleomorphism. So if any of the 3 are positive, the tumor is characterized as malignant. Our patient fell into the criteria of atypical, as he had only 1 or 2 of the criteria positive. And if only the pleomorphism in the cells is seen without any alteration in nucleoral morphology and vesicularity of the nucleus, mitotic figures, then it's considered benign. So to mention, malignant variant of GCT is extremely rare and is responsible for less than 1% of all the 1 to 2% of all cases. This is a table which I've taken from a review which was published in 2016. So nearly what we can see is nearly all patients are demonstrating positivity for S100 neuron-specific enolase, vimentin, and CD68. So GCTs are mysterious tumors. Earlier, they were thought to be arising from muscle cells, but now the cells of origin is considered to be Schwann cells. It may occur at any age. Most commonly, it occurs from 40 to 70 years of age. Females are more commonly involved than males. So orbital GCTs commonly present with diplopia, proptosis, ptosis, limitation in ocular motility, with inferior rectus being the most commonly involved. Patients can have dystopia. Symptoms persist for a long time before final diagnosis is established. And they are mostly well delineated and discrete tumors unless they are malignant and invade the surrounding structures. So this is a case report published in 2009, where this patient presented with limitation in superior gaze. And to be noted was that his visual acuity when looking forward was normal. But when he was looking upwards, his visual acuity deteriorated. So this was on imaging was found to be a lesion which was isodense with the surrounding extraocular muscles. And to be noted is that on T1 weighted MRI, the periphery of the lesion enhances brilliantly and the center is less brilliantly enhancing. It's less intense. So this patient was found to be having a benign GCT. As we can see, the cells are arranged in cords. This was another patient who presented with ptosis, and he had involvement of the superior rectus, and this underwent excision, and it was found to be benign GCT, and the tumor shrinked following surgery to 1.3 centimeters. Another case reported in literature is 45-year-old male. He presented with proptosis. He underwent complete excision of the mass, and at 55 months, there was liquor recurrence, cavernous sinus and maxillary sinus metastasis. So he had to be treated sequentially with exentration, gamma knife radiosurgery, and tumor excision. Another case presenting with proptosis, he had involvement of the inferior rectus. And then on surgery, it was found to be benign GCT, cells are arranged in cords, and he was positive for S100. This is another case, interesting case of a subconjunctival GCT. So this has to be really distinguished from conjunctival stromal tumors. So here we can see the cells have abundant PAS positive granular cytoplasm. And this is another case of benign GCT. So differential diagnosis in the cases have to be ossifying fibroma, central giant cell granuloma, aneurysmal bone cyst, or other giant cell lesions. Management wise, 1 to 2% of histologically benign GCTs can metastasize to distant structures through hematogenous route, namely to bones, regional lymph nodes, peripheral nerves, peritoneal cavity, breast, and lung. Treatment consists of conservative excision, which may be followed by radiotherapy for the residual tumor. For malignant variant of GCT, a wide local excision remains the standard treatment modality. Radiation has debatable roles, but this was reported in a case in 2018 where adjuvant radiotherapy in a femoral triangle GCT helped in local disease regression. So this can be tried in patients with malignant GCTs following a surgical debulking. Role of chemotherapy is uncertain. Most GCTs are refractory to chemotherapy. There has been a case report in 2015 where this drug pazopanib, a VEGFR receptor and PDGF receptor c-KIT antagonist, it has shown a role in soft tissue sarcomas. So I would conclude that local periocular examination is must in all cases. Though rare, one should be aware of the presence of this entity. It involves a multidisciplinary management. Histopathological examination is confirmatory in all cases. Radical excision may or may not be possible in all cases. Radiotherapy may be considered as an adjuvant to surgical debulking for tumors at high risk, which of local recurrence and metastasis. If they show rapid growth, they are more than 4 centimeters, and high KI index of more than 20%. A role of chemotherapy is not clear. Thank you.
Thank you, Dr. Siddharth. That was a very rare case. Next, I would like to now invite Dr. Saurabh Kamal. He is talking about lacrimal sac and peripunctal tumors. Dr. Saurabh.
Is my screen visible?
No, we can't see your screen.
Just made a list. Now?
Yeah, now it's visible. Yes, it's fine.
Okay. So good evening, everyone. My topic is peripunctal and lacrimal sac tumors, interesting cases. So I start this case, 70-year-old female who presented with mass over right lower lid since 1.5 months. There was no history of any watering, discharge, or bleeding from the lesion. On examination, the lesion was pinkish to yellowish in color. It was well defined in lower punctal region. Fixed to the tarsus, it was extending over the lower lid margin. Lower punctum was not seen separately. There was loss of lashes and pigmentary changes around the surrounding skin. The caruncle and the lower fornix was uninvolved. There was no feeder vessels, keratin, no regional palpable lymph nodes. So differential diagnosis, we all would agree in such a case for this lesion would be sebaceous gland carcinoma, ocular surface neoplasia, or basal cell carcinoma, and apart from others. There could also be benign lesion, simply could be squamous papilloma or pyogenic granuloma. So what would be the next step in this case? Do we plan the incision biopsy or do excision biopsy? As it is located near critical lacrimal structure, so incision biopsy, as it is easily accessible, would be the preferable choice. So this was done for this case, and this showed that in fact, the lesion was actually sebaceous gland carcinoma. So we know that sebaceous gland carcinoma is difficult to treat. It can spread not only locally, but also can involve regional lymph nodes with distance metastasis, can have higher mortality and morbidity, and also non-contiguous spread because of the multicentric origin and diffuse pseudo-inflammatory pattern. So the challenges in this case will be the not only dealing with the tumor itself, but also in terms of the eyelid reconstruction, achieving the tumor clearance, and also to rule out the involvement of lacrimal drainage system. So on literature search, the eyelid sebaceous gland carcinoma has been seen to metastasizing to the lacrimal sac after the excision, even after up to 5 years of age. And this could be because of these tumor cells which are free floating and can be seeded within the lacrimal sac system. So if you keep this thing in mind, the margin clearance would have to be achieved, which consists of basically taking the marginal strips after the excision. Also do conjunctival map biopsy to rule out the intraepithelial spread. As you can see, the eye was inflamed also, and to rule out the lacrimal drainage system involvement by taking the biopsy from lower canaliculus, lacrimal sac, and also from the lower NLD using the endoscope. So this was all done in this case, and it was negative. So next was after the excision was the eyelid reconstruction, which was done using the free tarsal graft from the ipsilateral upper eyelid, combined with the nasojugal flap and cryotherapy. So this patient did well. There was no epiphora or recurrence, and she has a fair bit of good cosmesis. So peripunctal tumors, they could be also benign, such as this lesion, which is, you can see how beautifully it is coming out from the lower punctum, causing the dilatation, and you can see the punctal wall, canaliculus wall, which has a clear margin, separate margin from the tumors. So this was pyogenic granuloma, which was removed from the lumen of the punctum itself and underwent mini Monoka tube. So for peripunctal lesion, you should see whether it is surrounding, it is involving and circling the punctum, it is benign or malignant on clinical examination. If you think that it is malignant, do incision biopsy and keep a high suspicion if the punctum is not seen, the lid has distorted anatomy, the lesion is involving both the lamellae, there is loss of lashes and effacement of gland orifices. So now coming on to the next part of the talk, the lacrimal sac tumors. So these are usually not very commonly seen, and they can be misdiagnosed because we have an entity called lacrimal mucosa itself, which occur in this area. So these patients, they have to be, we have to keep the high index of suspicions and see them clinically and also image them if we are thinking of the lacrimal sac tumors. So I would have just one case in this 43-year-old male who presented with watering in the left eye since 4 years, and he was diagnosed elsewhere as nasolacrimal duct obstruction and advised for DCR. So on examination, he actually had a firm non-tender soft tissue mass, which was palpable in the left lacrimal sac area. Regurgitation was negative, and on irrigation, there was clear fluid regurgitation from the opposite punctum with soft stop. So on the closer examination, if we do, we can see that the patient has obvious telecanthus, dystopia, and also proptosis. So the next step would be to consider him for a CT scan orbit, which showed a fairly well-defined soft tissue mass in left lacrimal sac area, which is also extending into the nasolacrimal duct, causing the dilatation of the duct, and its lower end was reaching till the inferior turbinate. So obviously the plan again would be to do the incision biopsy and see what are we dealing with. And this showed the benign spindle cell lesion. On immunohistochemistry, it was CD34 positive, EMA positive, Desmin and S100 were negative, CK SMA negative, and KI index was less than 1%. So pathologists suggested that this was a soft tissue perineuroma. So if we look in the literature, there has been only just one case report of this perineuroma occurring in the orbit, and it has been described in the lacrimal sac area itself. And basically, these perineuroma are more commonly seen in the lower and the upper lid and the trunk. There have been just a single case report in the orbit. So I would like to conclude that the lacrimal sac tumors are rare. They are oftenly misdiagnosed as a lacrimal mucocele, and if we do this, if we do not recognize them, then we may also miss them intraoperatively. So think of them if the mass is extending beyond the lacrimal sac fossa above the medial canthal tendon. There is history of any hemolacrimation, epistaxis, telecanthus, globe displacement. Syringing is patent or partially patent, and there is involvement of skin, lymph nodes, and on the nasal endoscopy, if there is any extension of these masses into the nose should be considered. If at all we do, you proceed with the surgery, that is a DCR, if there is a suspicion, if any mass is noted, then do not do osteotomy, take the incision biopsy, wait for the report, and always prefer the external approach in this suspicious cases and explore them before taking them for the DCR surgery. That's all from me. Thank you.
Thank you, Dr. Saurabh. You highlighted some rare cases indeed, and obviously these can be easily missed, and you appropriately highlighted the need for a proper clinical examination by showing palpation and the stressing upon the need for CT scan in doubtful cases. Thank you, Dr. Saurabh. Any questions or comments from the panelists for Dr. Saurabh? Okay, so next is Dr. Sorby. Dr. Sorby is an oculoplastic surgeon based in Gurgaon. He's a consultant at Artemis Eye Hospital. Dr. Sorby would be talking about large eyelid tumors.
Good evening, everybody. Just a second. Can you see my slides, sir?
Yes, yes.
But it's not coming on the screen.
You can see. Are you not able to see?
Yeah. Now, okay?
Yeah.
Okay. So I would basically be discussing the eyelid reconstruction post-excision of large eyelid tumors. So the eyelids, as we all know, is made up of the anterior lamella and the posterior lamella. So the basic principles of surgical reconstruction are that there are partial thickness defects and there are full thickness defects. For the reconstruction of the anterior layer, the options we have are skin grafts, which could be full thickness or split thickness, and skin flaps. For full thickness eyelid defects, for reconstruction of both the layers, at least one of our layers must have a blood supply. So it has to be a flap plus a graft or a flap. So we cannot place a free graft on another free graft. And the normal attachments of the canthal tendons to the orbital rim have to be restored. Looking at the anterior lamellar defects, first we'll go to the skin grafts. So the principles of reconstruction are that there should be no residual tension in the defect and there should be no distortion of the lid margin. Eyelid skin is of course the best color match, but it is often not adequate to fill in the defect. So retroauricular skin is what we have to resort to for larger defects. And a full thickness graft is always preferable in the periocular region because the contraction is much less and the color and the cosmetic match is much better as compared to a split thickness graft. So after measuring the defect, we harvest the skin usually from the postauricular area, close the donor site, and debulk the fat from the skin that has been harvested, give multiple stab incisions and place it on the host bed, or it can also be opposed with glue. Looking at the flaps, which can be used for anterior lamellar reconstruction, vascular tissue flaps, the rule of thumb is that the length to the breadth ratio should be 1:1, can be relaxed to about 2:1, but not more than that. And any tension should be parallel to the lid margins, that is horizontal rather than vertical. The flaps can be advancement flaps, such as here we see a large basal cell carcinoma involving the medial canthus, the lower lid, the nose, and the cheek, and the defect has been reconstructed using 2 advancement flaps from the cheek upwards and laterally from the lateral lower lid. The flaps can be rotational, such as the Mastare cheek rotation flap, which is often resorted to for larger defects involving the lower lid. So here is a reconstruction of the lower lid using a Mastare cheek rotation flap. These are basically defects which are more vertical than horizontal, where this flap is useful. So after the defect has been created, after removing the basal cell carcinoma, which was involving primarily the anterior lamella, and the posterior lamella was spared, this is how we have rotated in the cheek rotation flap, and this is the final post-operative result. Transposition flaps, which are basically raised on a pedicle and transferred to a nearby primary defect. There are various transposition flaps. Here is a small bilobed flap which has been used to reconstruct a circular defect created at the medial canthal area. This is again a combination of a medial canthal and a lower lid defect, which has been reconstructed using a combination of upper lid to lower lid transposition flap and a skin graft from the other eye. So the graft was taken from this eye, placed as a free graft, and the transposition flap was done from the upper lid. And this is the final result. This is another large tumor that was excised, and it was reconstructed using a large bilobed flap and combined with an advancement flap from the lateral part of the lower lid to cover the defect that was remaining after the bilobed flap was put in place. Another useful flaps which are often used for the deeper defects at the inner canthus are the glabellar flaps, which can be used as a sliding flap for a smaller defect or transposed for a larger defect. So this is a medial canthal BCC again, wherein the circular defect that was created after excision has been reconstructed using a glabellar flap. And this is how the patient was 6 months after the reconstruction. Coming to the posterior lamellar reconstruction, the length of the posterior lamella that is required can be measured by pulling on the edges of the defect to eliminate the horizontal lid laxity. The options we have are grafts, the oral mucous membrane, hard palate, nasal septal cartilage. So here is a mucous membrane grafting which has been used along with the Mastare cheek rotation flap for reconstruction of a very large lower lid defect that was created after excising this tumor. So here the anterior and the posterior lamella was involved. So we've used a free mucous membrane graft for the posterior lamella and then used a Mastare cheek rotation flap to reconstruct the anterior lamella. And this is the patient a couple of months after the reconstruction. Hughes tarsoconjunctival flap is of course one of the commonly used flaps for posterior layer reconstruction. This is a Hughes flap. This is a tumor that was excised. This is the large lower lid defect created. A Hughes tarsoconjunctival flap has been raised from the upper eyelid, and the free skin graft has been used to create the anterior lamella. Another large squamous cell carcinoma which was removed, and a Hughes advancement flap along with the small skin graft was done to recreate the lower eyelid. Then we have flaps which combine both the laminae together, which is the Tenzel's semicircular flap. This is a lower eyelid defect which was created after excising a small sebaceous carcinoma and has been reconstructed using a Tenzel's rotational flap. And then the Cutler-Bridge flap, which is used for larger lower lid defects, which are more horizontal than vertical in nature. Of course, this is a two-stage technique, so a second stage surgery is required to restore the upper eyelid. So another tumor which has been reconstructed using a Cutler-Beard flap. You can see this large mass of the upper lid which has been excised, and then a Cutler-Beard flap was done and the lower lid has been reformed after 6 weeks. These are again cases of reconstruction using the Cutler-Beard flap. So basically eyelid reconstruction, there are various reconstructive options which are available for covering any defect, and a basic knowledge of anatomy and reconstructive principles is useful in most of these cases. A combination of surgical techniques can often be used with good cosmetic and functional outcome in most cases. So these are a few larger tumors which have been reconstructed using combination techniques. So this is a cheek rotation flap and a Hughes procedure, which was combined with an advancement flap from the lateral forehead to reconstruct this large defect that was created after removing this tumor. Another large tumor which was removed, and the defect was reconstructed using Cutler-Beard with a glabular flap for a upper lid and medial defect. This is another extensive tumor which was reconstructed using a cheek rotation flap with the mucous membrane grafting for the lower lid, a free skin graft for the cheek defect, and an advancement flap for the upper part of the defect. Thank you.
Thank you, Dr. Sorby, for sharing some of your excellent results with us and revising all the techniques of lid reconstruction. Next, I would like to, any questions or comments for Dr. Sorby from the panelists? Okay, so next is, do we have Dr. Ruchi Goyal?
Stop the screen share. Will it stop automatically?
Yeah, it stopped. Dr. Ruchi is there? Dr. Ruchi Goyal? I don't think so. Dr. Raksha, are you ready with your slides?
Yeah, yes, I'm ready, Dr. Vikas.
Okay, please share.
Yeah, sure.
Dr. Raksha is a consultant at Narayan Nethralaya, Bangalore, and she was trained with Dr. Santosh in oculoplasty at CFS Hyderabad. She'll be talking about lid malignancy management.
Okay, are my slides visible?
Yes, Dr. Raksha.
Okay. So I'll be talking, good evening all panelists, and thank you for giving me an opportunity on this virtual form of DOS 2020. So I'll be talking on management of eyelid malignancies. Okay, so squamous cell carcinoma, basal cell carcinoma, malignant melanoma, Merkel cell carcinoma, and most of the hair follicle and sweat gland malignancies, when small and well circumscribed, can be managed by wide excision biopsy, which involves excision with 4 mm clinically clear margin under frozen section control. So clear margins, when we want to achieve, it is not only involving the anterior aspect, that is the skin side, but we must also achieve clinically clear 4 mm margin on the posterior aspect, that is the conjunctival side. Once an excision biopsy is done, the eyelid defect must be reconstructed by using one of the many techniques described in the literature, or as Dr. Saurabhi has already given an excellent talk before this. So as opposed to all these other malignancies, the management of sebaceous gland carcinoma is quite complicated. That is because sebaceous gland carcinoma exhibits a pagetoid growth pattern, which is the flat horizontal spread involving the superficial component of the eyelid or the conjunctival epithelium. And this is a histopathological feature. So this pagetoid growth pattern is seen in up to 40 to 80% of the individuals, and when present, it can carry a higher risk of orbital exentration, as concluded by a study by Chow et al. In yet another study by Rao et al., they concluded that the presence of pagetoid invasion causes a high mortality rate as opposed to the mortality rate which is lower in the absence of pagetoid invasion. So sebaceous carcinoma is a highly malignant and the most lethal tumor of the periocular adnexa. Hence, routinely, sebaceous carcinoma is managed by a two-step approach, in which the first step is to determine the extent of the disease on the conjunctiva by using conjunctival map biopsy, in which small bits of conjunctiva, 14 to 16 bits from different sites, is taken and subjected to histopathological examination, and based on those results, a more definitive management is then planned. So definitive management can be based on the size of the original tumor, and when small and well circumscribed, as in other tumors, in sebaceous carcinoma also, a wide excision biopsy can be done with 4 mm clear margins on both anterior and posterior aspect. This is followed by cryotherapy to all those areas which showed positive results on positive cells on conjunctival map biopsy. Yet another technique of definitive management when the tumor is slightly larger is the posterior lamellar resection, in which the eyelid margin along with the tarsus and the palpebral conjunctiva is stripped off the anterior lamella, and the entire area is then subjected to cryotherapy, and the tarsal area is reconstructed using a buccal mucosal graft. This is a study we conducted when I was doing my fellowship at Wilsey Institute, in which the posterior lamellar resection was compared to excision biopsy in sebaceous carcinoma. So the result was that in the long term, posterior lamellar resection was highly efficient because it led to fewer orbital excentrations, fewer lymph node and systemic metastasis. However, posterior lamellar resection can be used only in localized eyelid sebaceous carcinoma. That is, it cannot be used obviously when there is an orbital extension. Patients of sebaceous carcinoma also can undergo a procedure called as sentinel lymph node biopsy, which is usually the accepted standard care for melanoma. But of course, it can be used in sebaceous carcinoma as well. So what is sentinel lymph node? Is that it is the initial barrier to any further tumor spread. In this technique, first lymphoscintigraphy is done to identify the sentinel lymph node, which is then followed by sentinel lymph node dissection, which can histopathologically determine whether there is any micrometastasis present in that particular lymph node or not. With this relevant information, in case there is micrometastasis present, chemotherapy can be instituted that can probably prolong the remission of a particular patient. So what if the eyelid tumor is not just small and well circumscribed and it is extended into the orbit? So this is not only in case of sebaceous carcinoma, but also in all other eyelid malignancies. When there is an orbital component, a complete radiological evaluation is done to confirm the extent of the posterior extension of the orbit, and the patient has to then undergo orbital exentration. A small exception to this is probably advanced case of basal cell carcinoma. In the recent past, a lot of literature and a lot of studies have been done in the use of vismodegib, which is an oral drug, which is a hedgehog pathway inhibitor, which is given orally for advanced cases of basal cell carcinoma. And these studies have indicated that even advanced BCC has shown remission with this particular drug. It is now available in India, and but studies are yet to come up from India. So what is the so when the eyelid tumor is not just confined to the orbit but has also spread to lymph node, what is the treatment option? So in this case, as you see, this is a sebaceous carcinoma with orbital extension, and also the patient has a lymph node enlargement. This is a case where neoadjuvant chemotherapy was given, which not only reduced the orbital tumor, shrank the orbital tumor, but also caused disappearance of the lymph node. So Then the patient was subjected to eyelid sparing exenteration, and she was also spared of radical neck dissection, lymph node dissection. For aggressive tumors like Merkel cell carcinoma, angiosarcoma, and T-cell lymphoma, chemotherapy along with radiotherapy and surgery is definitely the mode of treatment, and this is multimodal management. These are aggressive tumors, and despite this multimodal management, a mortality rate up to 80% is seen in 5 years. So in all patients who have undergone a successful surgery or chemotherapy or radiotherapy, follow-up is absolutely pertinent. 3 monthly for a year, 6 monthly for 2 years, and yearly thereafter to catch any early recurrence and institute any further therapy. Thank you, everyone.
Thank you, Dr. Raksha. That was excellent. You highlighted all the principles for management of lid malignancies as well as the newer things that have come up. Thank you. Any questions or comments for Dr. Raksha? Okay, so next is me only. So I will just share my slides. The topic allotted to me actually by DOS was conjunctival tumors, recent advances. So I hope my slides are visible. So I'll straight away jump to the recent advances that have come up in the management of ocular surface tumors. The first being our way of looking at these tumors. So the first thing that we see is how we see the tumor clinically. Till now, we were focused on the clinical part of the tumor evaluation, but now we are more and more relying on OCT imaging of the tumors. And so what we see in such tumors is that the epithelium is involved. It is thickened, hyperplastic, and hyperreflective, and there is an abrupt transition from the involved dysplastic epithelium to the normal epithelium. This helps us to make a diagnosis. It helps us to know the extent. It helps us to know the depth of invasion of the tumor into the stroma of the cornea, if it's a corneal lesion, or if it's involving the superficial layers of the sclera. Then also we can get to know clinically many a times, unless there is a thick placoid layer of keratin on the surface. In all other cases, we are able to see how deep the lesion is growing, and this helps us in planning our further treatment, as I'll share later. So this is another example of ASOCT being done for a large lesion, and you can see this hyperreflective epithelium abruptly ending and the normal epithelium starting from this point. So this has made our job easier in the sense that we can evaluate the depth of invasion of tumor, and this really has an implication in modern times upon the treatment that we think for the patient. Also, sometimes there are some mimics and there is a slight doubt whether it's a tumor or it's something else. And ASOCT really helps in those situations also. If you find that epithelium is normal, but if it's just some stromal opacity or some stromal growth happening, most likely it is something other than OSSN. If the overlying epithelium is normal, it also in that way it helps us to differentiate between OSSN and some of its mimics. Another patient who had presented to me with a history of surgery done elsewhere and a large OSSN sitting on the limbus, and ASOCT showed that there was a deeper invasion into the sclera, and so this patient was managed appropriately the way we do for patients with scleral invasion. Another interesting investigation that has come handy and that is changing the way we look at these tumors is UBM. If there is a suspicion of a ciliary body involvement in these cases, that the area is so deep you cannot actually visualize with ASOCT so well, UBM comes handy there. For example, in this particular patient who presented with something like a pseudohypopyon, basically these were all tumor cells filling up the anterior chamber. This patient had a history of surgery done elsewhere and now had come with this kind of a picture. So when we see this kind of picture in these cells in the anterior chamber, these were not regular hypopyon inflammatory cells, but they were thicker, balls of tumor cells which could be appreciated. In such cases, you need to rule out a ciliary body involvement, and that's where the role of UBM comes in. The second advance is that we have a better classification system for the ocular surface tumors, and we can categorize them the way it's done for all systemic cancers into a TNM staging system. It has its drawback in the sense that it takes into account tumors which have been biopsied or surgically managed. Drawback is that for patients, most of the patients, the way we are managing these days with topical therapy, that's a lacuna that this staging system does not cover, but I feel that it's a step in the right direction. And with the coming next editions of AJCC classifications, we'll have some sort of inclusion of tumors being managed with topical medication as well. So talking about topical therapy is the new in thing. And yes, it works very well in a lot of patients. You only need to know where to use it and where not to use it, and don't use it indiscriminately everywhere. So this is, I'll just show a few examples. This was a patient who had a gelatinous kind of growth on the surface. And this patient had almost complete resolution after 3 months of using topical interferon. Another patient who had a limbal mass with feeder vessels and intrinsic vasculature, again interferon topically were used, and you can see the results after 2 months of therapy. Another patient with a large lesion, large OSSN on the surface, encroaching on the cornea as well, very prominent feeder vessels, treated with interferon subconjunctival injections as well as topical interferon eye drops. You can see a complete resolution of the tumor after 4 months. Before anybody starts thinking of using interferon as the main or a topical therapy as the mainstay of their treatment, I would recommend that everyone should read this editorial by Dr. Honavar. It's very useful, and it warns against the indiscriminate use of topical therapy for all patients. Remember that topical therapy is useful mainly for patients who have an intraepithelial kind of tumor, and not for more invasive varieties of OSSN, where surgical management is still the recommended of treating. Moving on to the surgical options. So surgical technique remains the gold standard for most of these invasive tumors of the ocular surface. That's the mainstay of therapy. And in such cases, what we see is that, if it's a localized form of a tumor, you excise using the no-touch technique, the double freeze-thaw cryo protocol with AMG, and you get very good results. Again, a well-defined tumor does very well with surgery. But what happens if you have a patient like this who does not respond to topical therapy, not much of response that you achieve, even if you want a kind of a new adjuvant effect with topical therapy? This patient was tried with everything but did not respond, so surgery is the option for such patients. But if you operate on these patients, what is likely to happen is that there are limbal stem cells at the limbus which are likely to get damaged, and as a result you may get a picture like this, where there's a lot of scarring of conjunctiva and there's a lot of encroachment of the conjunctival tissue onto the cornea, and sometimes even corneal opacities in more extensive cases. This is a result of extensive limbal stem cell destruction in such patients. So we've tried something else, and that is we tried it OSSN exchange with simultaneous limbal stem cell transplant, and the stem cells were harvested from the contralateral normal eye. And here you see, if you do it as a primary therapy at the time of surgery, you do get very good results, and there is absolutely no limbal stem cell deficiency. Another patient with more diffuse OSSN, treated with surgery and simultaneous limbal stem cell transplant. If we had gone with just the simple surgical technique, then this patient would have had a lot of stem cell deficiency, but after the limbal stem cell transplant, the patient is doing well. So we published some of our results as a multicentric trial in IJO of using limbal stem cell transplantation as a CLAG graft, and another case report of a patient treated with SLET. Now in SLET, we harvest the graft from the contralateral eye, and we place small bits on the cornea, and an EMG is used to cover the bare area first, and you can see the results are as good as a bigger graft taken as a CLAG graft. So this was also published in Cornea. The next recent advance is use of plaque brachytherapy in OSSN. I wouldn't call it very recent. It's been some years since it's been used, but it's better understood now where to be used, and more often I would say it's used as a sort of a treatment modality in places where enucleation used to be performed earlier. So if you have an extensive tumor like this, where there is evidence of a deep stromal involvement, now this patient was operated somewhere else, and you can see a scar in the sclera and some thinning in the sclera. So what do you do in such cases? Earlier, probably the option would have been to just enucleate these eyes. But now whenever we excise a tumor, we send it to a pathologist, and the pathologist in particular has to report on the base of the tumor. If the basal tissue of the tumor shows invasion by the malignant cells, then plaque brachytherapy has to be used as an adjuvant therapy. And with this technique, we have been able to save and salvage many eyes which would have been sacrificed earlier. Another patient I showed earlier where the OCT showed a deeper scleral invasion by the tumor. So in this case also, the tumor was removed along with lamellar sclerectomy in the involved portion, and the adjuvant plaque therapy was done secondarily. You can do plaque secondarily or at the time of primary excision as well. So you can see there is some amount of symblepharon formation, but the patient is recurrence free. And now I've been following this patient up for almost 7-8 years, and there's been no recurrence. Last, what Dr. Raksha also highlighted earlier, the role of sentinel lymph node biopsy. Now, this is a patient with a conjunctival melanoma arising from a PAM. It's a very large tumor here in this situation, very diffuse. The recommendation in literature says any tumor more than, earlier it used to be 2 millimeters. I believe now it's even less than that. Any tumor, any melanoma more than that has to undergo sentinel lymph node biopsy. Obviously, you need specialized centers where you can only do it. It requires a handheld Giga probe with a portable Giga counter, with which we can see that we isolate the first draining node, that's called the sentinel lymph node. You excise that node first, send it for a frozen section histopathology. If the pathologist reports that the first set of draining nodes is negative for the tumor, you don't need to dissect any further and don't need to do radical neck dissections in such patients. But if the pathologist reports there is a positivity in the excised nodes, then you need to go to the next level of lymph nodes in the neck and keep excising till you reach a negative set of nodes. So there are various levels that have been the neck nodes are classified into various levels. So you go 1, 2, 3, 4, 5, 6 this way. So to summarize, what we have now recently is the better use of newer investigative modalities, better topical therapies, and use of surgical adjuncts like SLET, LSCT, or sentinel lymph node biopsy as helpful adjuncts to our surgical management. Thank you very much. So, any questions or any comments? So, last but not the least, Dr. Seema Das is here with us. She'll be talking about recent advances in retinoblastoma management. Dr. Seema, all yours.
Thank you, Vikas.
You have a lot of time. Now there's no one coming after you, so there's no stopping you now. Go on.
Doing the toughest job. And I think this session, I don't see any attendees in this session. And I think most of the recent management in the retinoblastoma has been covered. Dr. SH has covered, and in fact, the most of it. And Dr. Lomi has covered it. And we had few other talks where I had to speak, and I think it has been covered. So I'm not going to repeat the things, and I'm sure all of us want to go back. It's Saturday evening. So for me, the last year, at least, if I talk about recent advances in RB, other than, of course, what has been there in the management, the intra-arterial, the plaque, intravitreal, everything else, what important for me to carry to the next year is just two things which I just wanted to share with this group. There has been a lot of ambiguity as far as high risk factor in retinoblastoma is concerned, with various studies has been using different sort of parameters as high risk factor. And this is one aspect which is very, very important, because we do decide our treatment, whether the patient needs an adjuvant treatment or not, based on whether the patient has a high risk factor or not. So for that purpose, it's very important to define what we call as high risk factor, and it has to be uniform. If tomorrow we have to compile our data and compare the outcomes and compare which treatment works and which treatment does not work. So the recent COG study has come up now with the result to answer these questions. In fact, this study, I remember, was initiated when I was doing my fellowship, and now the long-term data is there, which at least has attempted or at least clarified some of the things and given answer to some of the questions regarding the confusion of the high risk factors. So what's take home for me from this is, out of all the patients which they have enrolled, the patients who have undergone primary enucleation, and then based on the presence of certain set of high risk criteria which has been predefined, they have followed up those patients, and those who filled into that criteria, they were given adjuvant treatment. Those who did not were not given. And then they have seen whether any event in the form of death or any recurrence of the disease or metastasis happened in those group of patients. So in this whole group of about 300 odd patients, 300 plus, 6 patients had event. And what was important that out of the 6 patients, 5 patients who had high risk factor, who needed adjuvant treatment, and who had an event also had iris neovascularization, which we now know there are several other studies which says that a clinical marker for histopath high risk factor could also be the involvement of the iris. So iris neovascularization probably can serve to suspect that this set of eyes needs to be looked at a little more carefully and might harbor a high risk factor. The second thing is which type of high risk factor needs what treatment modality. Now, conventionally, what we do is if there is a high risk factor, the patient receives 6 cycles of adjuvant chemotherapy. If the high risk factors are in the form of erythrolaminar or transaction positive optic nerve, or if there is a full thickness scleral involvement, this patient receives high dose chemotherapy. So what the COG study tells us also is that if there is a massive choroidal invasion, normally in massive choroidal invasion, the recommendation is a standard dose of 6 cycles of adjuvant chemo. But in COG, they have found that the patient who had a massive choroidal invasion, which was in the 3 millimeter peripapillary area, along with that, if there was a concomitant involvement of the retrolaminar optic nerve, this patient had poorest outcome in terms of disease recurrence, metastasis, and death. So probably there is a cause for stepping up even the adjuvant treatment in this group of patients, make it more extensive. And though there is not enough data now, but at least it's an indicator that these are the group of patients where we need to be a little more aggressive. Possibly there is a role of adjuvant radiation also along with chemotherapy in this group of patients. The second thing, as I mentioned, NVI probably can be used as a predictor for poor prognosis. And these eyes needs to be looked at a little more carefully to see if there is any high risk factor lurking inside. And also they have found that children with only anterior segment involvement, where initially earlier adjuvant chemo used to be given for this set of patients also, these patients did not have any event during the course of the follow-up. So the recommendation is that it's possible that children with only anterior segment involvement, if there is no other concomitant high risk factor, can be just kept under observation, and the adjuvant treatment might not be required for those group of patients. Of course, all this deduction needs further study in the form of prospective, possibly multi-static data to kind of validate them. The second thing which I think is important is now the AJCC 8th edition, the TNF classification for retinoblastoma is now in place, and we now have the first multicentric study, the international collaborative study from the same group who has formulated the AJCC staging system for RB has now come up in 2 parts. The part 1 is to see the metastasis-related mortality as per the AJCC staging. And the second part is to see the treatment outcome and the GLOBE survival, again as per the AJCC staging. So I think this is very important because there are so many classifications of RB and there is a lot of ambiguity. For the same tumor, if you use 3 set of classification, we really can't prognosticate the tumor because they are going to fall into the different severity if you use a different kind of classification. So in future, to predict the survival, to predict the treatment outcome, and to have some data which is going to be uniform, it's important to follow a uniform set of classification. And validating the AJCC system with maybe future studies is going to be very, very important. At least the initial study just show that the risk of metastasis increases with the increasing T category, the clinical tumor category. As the tumor is more severe, the metastasis also increases. And also with the increasing severity of the P category, the tumor-related mortality or metastases are increasing. So of course there is the AJCC staging needs to be compared with the other staging system, as well as the grouping system of RB to see which one predicts the mortality as well as the survival better before we finally adopt. But I think this is one step in the right direction. The same for the part 2 of the study, which predicts the treatment success as well as GLOBE salvage, which says the same thing. There is risk of local treatment failure increases as the T category increases. Again, the AJCC has its own set of problem because it's staged in such a way that the CT4 category, where there is radiological evidence needed to say whether there is extraocular extension of the disease, the data might not be available in most of the retrospective studies because we might not be capturing this part. So that's one problem, but again, a prospective study should be able to answer it. So I think these are the 2 important things which, at least for me, seems something which we need to carry forward in the next year, and there is scope of doing a lot of work in this. And of course, there are the other things like targeted treatment and intra-arterial, the vitreous seeds, and of course plaques. So I'm not going to the details of it because this group does not needs to be. One thing about ISC, which I just want to highlight, is the fact that now the studies have come. ISC traditionally used to be reserved for patients who are more than 10 kg of weight. So in neonates, so the newborn, though there are isolated reports, it was not the recommended treatment option. But now there are studies from the Shields group. This study has come up, probably the largest series, which says that weight less than 10 kg is not an independent predictor of complication or the procedure failure. Meaning that if eligible or if indicated, we can now do the procedure even for smaller kids also, and the need for bridge chemo can be avoided in this group of patients. Of course, we have data now coming up from the various centers about the long-term outcome of the study. We have the data from the Indian group now. I think this is the first long-term data about the ISC outcome. That's from the Shankar Nethralaya group, who says that though at first year the eye survival, the eye salvage rate was 76%, but as we follow up this patient over 3-4 years, the eye salvage rate actually falls down to the tune of almost about 60 to 50%. So I think this is something very important, and we are waiting for the data coming up, the large scale data from the other centers of the country, and to be able to kind of make it much or apply it in a much more widespread fashion in our clinical practice. So I think that's what from my side, and I really don't want to go into the details of the other things which most of other speakers have covered extensively in their talks. So thank you for staying back patiently.
Thank you, Seema. That was like really going into the details and reading between the lines. Very useful tips and very useful points that you picked up. Thank you very much. Any other comments or any questions for Dr. Seema? Okay, so we conclude the session here. Thank you, everybody. Thank you, all the panelists. Thank you, all the speakers for your time. Thank you. So I think we'll end the session here. Thanks.
Thank you, Vikas. Thank you, everyone.
Thank you, sir.